Good morning. Are you the interpreter?
Yes, hi, good morning. I'm Leonina. I'll be your interpreter. Absolutely.
Okay. We just want to let you know we do see you. Thank you. All
Oh,
right.
thank you.
Bye-bye.
Good morning. Calling this roundtable to order. Today is Wednesday, December 3rd, 2025. The time is 9:30 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are holding this roundtable to hear from the public and district government leaders about changes to the FY26 budget to the district's public health insurance programs, including Medicaid and Alliance. This discussion will allow the public an opportunity to share their experiences with the rollout of these changes and allow for the government agencies to explain how they're implementing them, including outreach to beneficiaries, communication with providers, interagency coordination, and plans for administering these programs going forward. First, for some context, the Healthcare Alliance program administered by the Department of Healthcare Finance is a locally funded program that has been providing medical assistance to low-income district adults who do not qualify for Medicaid or Medicare since 2001. The Immigrant Children's Program provides Medicaid equivalent coverage to non-Medicaid eligible children under 21. Participation and cost in both programs have risen significantly since they began operations. For example, in 2011, they served 28,282 people with an average cost of about $1,800 per enrollee. By 2026, enrollment was projected to reach 37,024 individuals with an average cost estimated at $6,671 per enrollee. This growth can partially be explained by the fact that the average age of the Alliance adults have increased, and as they have aged, their medical needs have become more complex and more expensive. Coupled with a negative city revenue growth projection for FY26, the mayor proposed major policy shifts, including combining the Alliance and Immigrant Children's Program into a single Alliance program, moving from managed care to fee-for-service, and reducing income eligibility for adults over the course of the financial plan. And as a result, on October 1, 2025, approximately 2,200 individuals lost coverage, which was fewer than Department of Healthcare Finance had initially projected. However, incorrect notices and program changes caused confusion, particularly among immigrant communities already facing increased hostility. Even individuals who kept their coverage experienced some challenges accessing healthcare services because some clinicians and frontline staff were not aware of the scope of the changes. While the council was able to reverse some of these changes last year, there were further cuts to the Alliance eligibility set to take place in FY27 and 2028, unless the mayor is able to reverse those policy changes in her proposed FY27 budget. Medicaid spending has also continued to grow. Because Medicaid is an entitlement program with federally defined minimum coverage requirements, options for reducing costs are limited. The district could restrict eligibility, reduce benefits, or lower provider payment rates. To avoid destabilization of the program, the FY26 budget reduced eligibility for childless adults and parents and caretakers from 221% to 135% of the federal poverty level, which actually aligns the districts with Maryland and Virginia. is projected to affect about 18,000 adults. The individuals will be transitioned on January 1, 2026 to the newly approved Healthy DC plan, which is a basic health insurance plan administered by the the Health Benefit Exchange Authority. The BHP allows for district to draw down federal funds equaling to 95% of the premium tax credits and cost sharing reductions this population would have received on the exchange, making it less costly for the district. Further, because the Healthy DC plan was designed with no premiums or cost sharing, fewer people are expected to lose coverage than if they were required to enroll in the marketplace without BHP. HBX, Health Benefit Exchange, has been spending months working with Department of Healthcare Finance, health insurance carriers, and other stakeholders to develop program rules, provider networks, and reimbursement structures. While similar to Medicaid, the Healthy DC plan does not cover some services, such as vision, dental, and certain behavioral health supports. These changes come at a time when affordability, continuation of coverage, and access to healthcare remains a top concern for residents. We have a responsibility to ensure that our district agencies provide accessible, affordable health coverage and respond to evolving community needs in partnership with providers and stakeholders. My goal for today's roundtable is to promote transparency and oversight for these major changes and to ensure that the future policy decisions strengthen and not weaken coverage and access for most vulnerable residents, while acknowledging that the district does have some fiscal constraints. So I look forward to an honest and constructive conversation with both the public and the government witnesses today. I don't see any of my colleagues, but if they've joined, we'll certainly turn to them for an opening statement. We're going to start with our public witnesses first, and then we'll turn to our government witnesses for their remarks thereafter. So I'm going to call the first panel of witnesses, and I just want to explain the rules of where we're going for all those who are watching, listening, and online. This is a hybrid hearing, so there are people who are giving testimony in person and also online as well. We have a lot of witnesses today, and while I appreciate what everyone has to say, everyone has 3 minutes. Okay, 3 minutes. Now, that doesn't say that we don't want to hear all the pieces, but we do want to give everyone an opportunity, and certainly the written testimony that you provide to the council can certainly be longer, and we will review that. If you have requested translation services, which we do have some individuals who have, you will have 6 minutes to include the time for translation. That will begin at the beginning of testifying. After that, we'll then turn to our in-person witnesses, and then we'll turn to our virtual witnesses. In terms of the interpretation, our interpreter is online, so she'll be on the screens, and we'll go from there. All right. Okay. For those who require translation services, I've been asked that you pause so that the translator can speak in between every few sentences or so. Okay. Celeste Rodriguez, that is virtual, and Sandra Rodriguez Leon, who is here in person. Okay. All right, so the first person isn't here. Hold on. Leonina, Sandra is actually, she's going to provide her testimony in English.
Beautiful. Okay, I'll be here in case you need me for the next person.
All right, thank you.
Good morning, ladies.
Oh, no, you could take a seat.
Good morning, everyone. My name is Sandra Rodriguez. I am
Hold on. Sandra, sit down so they can see you.
Thank you.
Yeah.
My name is Sandra Rodriguez. I am a DC resident and an English language student. I want to take this time to thank the DC Council members for being able to share this space with all of you, and that my gratitude to the Healthcare Alliance for all the medical support that I received to better my health. Thank you, Alliance, for preventing, for curing, for comforting, and for being there where pain turns into hope. We cannot forget those who dedicate their life to helping us. Alliance not only improve body, but also build a strong and healthy community. that allows us to contribute to this community that support us. As a Bridge student, I want to read to you the gratitude we feel as a community to the Healthcare Alliance that you, our council members, have provided for us. The student community of Brilla Charter School express its infinite gratitude to Healthcare Alliance Insurers for their immense work in prevention and healthing in the community. We maintain the faith and hope that you, members of DC community, and that you will not allow the elimination of the Alliance Health Insurance Program, which benefits us all. Together, we can build a healthy and strong community to contribute to this city that welcomes us. I am urging that you support us by ensuring that there are other options for healthcare in DC. It is a better scenario that we will continue to have a healthcare alliance for all DC residents, and we are grateful for your compassion to the community. Alliance does hard work on our benefit. They are the bridge between life and death, dreams and reality. As an example, it prevents us from having serious illness such as cancer or leukemia by visiting our primary doctor for a well checkup. I want to tell you my personal story. In March 2022, my doctor diagnosed me with serious problem in my ovaries. Even so, I continued working and taking medication during a follow-up visit for this problem. The doctor ordered urgent laboratory tests, and the results showed complication with the possibility of cancer. I understood that my life could change completely. Thanks to my Alliance Health Insurance, in April 2023, I had 2 surgeries and then continue with medication. Alliance to take precaution to avoid complications. And thanks to them, I am now out of danger. Thank you 1,000 times, Alliance. I also have with me a signature sheet from the Brilla student community that share their gratitude to you, our council members and Alliance. God bless your decision. Thank you so much for listening to me. Thank you.
Thank you. Thank you. Okay, so if I had known that, I would have put more people at the table. So we're gonna add more people to the table now. So Abraham Plout. Great. Elena Eckner. She's here. All right. Bill Meffert. Okay. Carlos? Or do you prefer to go with all of your folks? Okay. Well, is Elena here? Oh, all right. Well, come on now. Come on upstairs. All right, Carlos, why don't you come to the table? And then April. Yeah. Okay. All right. For the folks who are downstairs, it's okay to come upstairs. The hearing has started and we're going to move. All right. Okay. All right. Abraham, when you're ready.
Thank you. Good morning. My name is Abraham Plout. I'm a Ward 4 resident, and I'm the medical enrollment coordinator at Bread for the City's Medical Clinic. I'm testifying on behalf of Bread for the City's Medical Clinic about the severe budget cuts to the DC Healthcare Alliance and the impact that it's had on our patients and the local healthcare ecosystem. Bread for the City's Medical Clinic provides primary care, dental, vision, and mental health services to all of our patients, all for free, regardless of their insurance coverage. Unfortunately, hospitals, pharmacies, and specialists across the DC healthcare ecosystem don't share this same commitment to free services. Moreover, many of our patients need specialized care or services that Bread for the City is simply unable to provide. Due to the budget cuts to Alliance, Bread for the City has been seeing an influx of new patients who used to receive services elsewhere that are now unable to afford co-pays and fees. Whether or not our working class and low-income patients happen to qualify for Medicaid or for Medicare should not be a determining factor in whether the city will permit them to access the medications and the specialized services that they need to survive and thrive as part of our city. In my work as the medical enrollment coordinator, I meet with our uninsured and underinsured patients every day to help them apply, recertify, and troubleshoot their health insurance. Looking into the eyes of my patients, it's very easy to see myself and my family members in their place. There was one patient not much older than me. If the circumstances of our birth were different, it could have just as easily been myself. He has a wife and young child. I met my cousin's new baby at home celebrating Thanksgiving. He has PTSD and anxiety, so do my siblings. He has psoriasis and psoriatic arthritis, so does my aunt. He's able to manage his condition and maintain employment only by working with a multidisciplinary team of providers and specialists. Primary care and behavioral health at Bread, dermatology and rheumatology 3 or 4 times a year, 3 topical ointments, twice monthly injectables, phototherapy, sometimes pain medications. Without Alliance, it's $4,000 to $7,000 per month just for the medications that he needs to prevent flare-ups and control his symptoms. Without Alliance, there'd be fewer options for treatment, wouldn't be able to see the team of providers that are key to managing care, wouldn't be able to connect to dermatology or rheumatology. I'd be suffering from daily severe joint pain, often preventing him from working. His symptoms in the past were physically painful and impeded his ability to be affectionate with his family, triggering severe emotional distress. Without Alliance, providers wouldn't be able to recommend him for the labs and imaging to monitor for disease progression and possible side effects of medications. Without adequate treatment, he'd likely suffer from more chronic pain, disfigurement or deformity, permanent joint damage, mental health complications, an inability to work or care for his children, and experience an overall reduced quality of life, limited by pain and self-isolation. There's many other patients like him whose lives were already hanging together by a thread. The severe budget cuts and changes to the Alliance program are akin to using a sledgehammer to solve the district's medical coverage crisis, when what we needed was a needle and some empathy. Thank you.
Thank you. All right. Bill, we'll get you on the next panel. Okay, Elena.
Good morning, Councilmember Henderson. My name is Alana Eichner, and I'm the co-director of the DC, Maryland, Virginia chapter of the National Domestic Workers Alliance. And so we're a group, as you know, of house cleaners, home care workers, and nannies, and the women who we work with really do the work that keeps this city running. They care for our homes, they care for our children, and the work is really physically taxing, whether it's breathing in toxic chemicals for years and years and years, or chronic pain from lifting senior adults. And domestic work is also an industry where very, very few workers receive employer-sponsored health insurance. And this is true with so many industries where immigrant workers are concentrated, that the work takes an extreme physical toll on their bodies, and they don't have access to care when they need it. So that's why, in my experience with domestic workers in DC, the Alliance healthcare program has been so game-changing, why it's made DC such a leader compared to domestic workers I know who live in nearby jurisdictions that are not DC. Pretty much every member of my organization who lives in DC relies on Alliance healthcare to meet their basic healthcare needs, and our city would not run without the work of immigrant workers, and this is a key support for them that's now being gutted. I'm just going to share a few pieces of the many, many stories I've heard from folks about the essential impact of the Alliance, and I'm hoping that these stories will make really clear that with your leadership and other members on the council, that figuring out allocating the necessary funding to reverse the cuts to this program is one of the most important things the council can do and must do. I'll start with the story of a nanny who lives up in Ward 4 from Guatemala, who first got access to the Alliance over 20 years ago. And the Alliance has accompanied her and her husband for 2 decades, everything from emergency surgery to remove his appendix to preventative medicine, brain scans, allergy tests, reproductive care, gallbladder removal surgery, just so many things that the Alliance makes possible that would not be economically possible otherwise. She talked about the Alliance, she called it a great blessing for her family. Another member of NDWA, a mom of 2 young kids who's here today, she's talked about being pre-diabetic and what that means to her, and that every 3 months she goes to a doctor's appointment where they check her sugar level, and she relies on the Alliance for this. It's essential to preventing the development of diabetes, and the loss of coverage that we're hearing about is not a future reality. It's already happening. She told me yesterday that she needs glasses, but she can't get them because she's lost her vision coverage through Alliance starting in October. I'll just close with one last story of a house cleaner from Ward 1. And she talked about how when she suffered a workplace accident in January of this year, she was able to receive surgery because of the Alliance, and she has now lost coverage, and she's worried about additional reductions in coverage. She was only able to undergo this surgery and remain in stable condition because of this program. So please prioritize the funding for this, return the income eligibility level to 215% of the poverty level.
Thank you.
Restore services and remove the age gap.
I said at the top, some of y'all weren't here. We've got a lot of people today, so we're gonna cut you off. Not because we don't like you, but because we want to hear from everyone. Okay, Carlos. You got to turn your mic on. Pull it close to you so we can hear you.
Good morning, Chairperson Henderson, council members, council staff. My name is Carlos Plazas. I'm the Chief Executive Officer at La Clínica del Pueblo. La Clínica del Pueblo is a federal qualified health center that has served low-income DC residents for over 42 years, providing culturally and linguistically appropriate medical, mental health, and community health services. FQs provide some of the district's highest quality primary care and preventive care when compared to MCO networks. We consistently achieve better outcomes in diabetes and hypertension control, higher rates of cervical and breast cancer screening, and a stronger performance in health education efforts such as tobacco cessation and weight management counseling. However, primary care alone cannot meet all the patient needs. Programs like DC Medicaid Alliance and the DC Medicaid cover for medications and specialty care, both vital for patients' health. FQACs are mandated to serve patients regardless of the insurance or ability to pay. The sustainability model relies on a balanced payer mix, in which has been significantly disrupted by changes to DC Alliance and DC Medicaid. From September 30, 2024 to September 30, 2025, 1 in 4 of our DC resident patients were Alliance enrollees, and 25% of them has lost coverage as of October 1st. If eligibility changes continue, 61% of current Alliance enrollees will lose coverage in 2026, and by 2027, mostly all of them will lose coverage. Many of these residents are not eligible for alternative coverage, and single and sliding fee payments alone cannot fill these gaps. And please remember that 25% that we lost as of October 21st. We are already seeing the effects of these changes in our patient visits. When we compare our visit numbers with no-show rates from last year, from October 1st to December 1st, missed appointments among DC Alliance patients increased by 25% as well. Our no-show rates for regular patients is about, regardless of the insurance, is about 15%, but for Alliance patients has increased to about 40%. And this trend is unique to Alliance patients. Higher no-show rates interrupt chronic disease management, delay diagnosis, treatment, reduce preventive care, and ultimately worsen healthcare outcomes. This leads for more emergency room use, hospitalizations, long-term costs for both patients and the healthcare system as a whole. This also jeopardizes the sustainability of agencies like ours. Our concerns are further heightened because the Department of Behavioral Health is also mirroring the Alliance eligibility cuts. At a time of significant mental health and substance use in the district, this will leave more patients without access to treatment and reduce reimbursement for behavioral health and substance use for agencies like ours. These cuts are real consequence for the most vulnerable DC residents and for the safety net providers as well. We ask the City Council to restore the Alliance in 3 ways. Return the income limit to 215% of the FPL, restore all service covered before October 1st, including dental and vision, and remove the age cap for adults 26 and older. We also urge the Department of Behavioral Health not to mirror the DC Alliance eligibility costs and ask the City Council to work with FQACs to protect our residents and our sustainability.
Thank you.
Thank you.
Thank you. April?
Good morning, Chairperson Henderson, council members, and council staff. My name is Abril Schuchman, and I'm the Community Partnerships Manager at La Clínica del Pueblo. Today, I will be reading a testimony on behalf of one of our patients, Maria, whose name I have changed to preserve her anonymity. Maria is one of the many housekeepers who keeps the district running, and this is her story. My name is Maria. I have been a DC resident and patient at La Clínica del Pueblo for 13 years. Today, I ask the council to restore and improve the Alliance. For many families in DC like mine, the Alliance has been the only way to receive medical services. Losing this coverage has had massive consequences for my health and the health of my children, family, and community. Having access to health services has meant a lot to me. Thanks to La Clínica del Pueblo, I have been able to manage my health and receive important referrals to specialist care. This includes getting help for my vision problems. While working, I experience a lot of discomfort in my eye and I don't see very well. As a result, my primary care doctor told me I need to do additional tests, but when I lost my insurance, I could no longer go to the hospital to do them. 6 years ago, they also found a small mass in my left breast. With my insurance, I could do mammograms every year and know that it hadn't progressed into anything serious. Now, having lost my insurance coverage, I cannot do the annual mammograms I need to monitor the mass progression. In the past, I have had serious medical emergencies that were thankfully covered by my insurance, like a severe burn on my face, hands, and other parts of my body that I got while cooking. Another instance is when I needed surgery in 2016 for an open fracture in my heel. Now that I don't have insurance, if I were to have another medical emergency, I honestly don't know what would happen to me. And just 2 months ago, before losing my insurance, in La Clínica, they detected high blood sugar levels. They told me I needed regular checkups and exams to monitor my condition, but without insurance, I cannot afford it. I am not the only one impacted by this. My family also lost their Alliance. My son was in the middle of a diagnostic process for a urinary condition, but he could not complete it. My daughter needs annual vision checkups that she can no longer do. Council members, as you can see, the Alliance is more than just an insurance. It's the difference between prevention and suffering. The difference between living with dignity and living with fear. The difference between being healthy and getting sick with no hope of getting better. My story is not unique. I am one of thousands of DC residents who depend on the Alliance and on community health centers like La Clínica. For that reason, I ask the council to prioritize our health and act to restore and improve the Alliance. Thank you for listening to my story, Maria.
Thank you. Thank you to this panel of witnesses. Ashley, if you could put me on I'm going to put myself on a clock. I'm going to model. You can put me on 5 minutes. I'm going to ask some questions for 5 minutes. But thank you all for being here. And April, thank you for lifting up your patient's words who couldn't be here. I just have a couple of follow-up questions. Abraham, thank you for being here as well and for the work that you guys do at Bread for the City. Prior to October, what was the volume that you all were seeing at the medical clinic at Bread?
To clarify, the kind of number of patients with Alliance enrolled in Alliance?
No. I'm just saying in general, because you said you guys have been seeing an influx of new patients, and I'm curious, was this something that was gradual over time, like you started seeing it over the summer, or is this something that has peaked like in October?
Yeah, I think since October, every week there's kind of new patients who are being seen. Since October, I've kind of noticed, more and more patients who've previously been seen, had primary care established elsewhere, who are coming to Bread, especially for those other kinds of services like dental that aren't covered by Alliance anymore.
Okay. What besides dental, does Bread for the City's medical clinic also do vision?
Correct, for free for all of our patients.
Got it. Okay. How often are you guys open?
We are open kind of every weekday. Every weekday
Okay.
across our Northwest and Southeast centers.
Okay. And in terms of his payer mix, you all take patients who have Medicaid and Alliance or no insurance.
Correct. Yeah, we have patients who have Medicaid, who have Medicare, various kind of private marketplace insurance, Alliance, and also patients who have no insurance. And all of our patients, regardless of their insurance, are never charged a copay or never charged for the cost of services received at BRED.
Okay. All right. Thank you for that info. Carlos, thank you for being here. And thank you for meeting with me a couple of weeks ago when I had an opportunity to come out to La Clinica to see the new pharmacy and some of the work that you guys are doing there. Can you say more about the DBH component of this in terms of, I think at the end of your testimony, you were talking about DBH's eligibility not matching everything else. You want to say more about that?
So prior to the changes of the Alliance, DBH had a different requirements for coverage for behavioral health. However, DBH decided to mirror the eligibility requirements to qualify for services for behavioral health.
Okay.
So a segment of patients who before could have been Alliance patients or could have not been Alliance patients that had coverage through DBH, as of October 1st, they do not have coverage anymore. In our substance use program, that meant that we had about a 35% increase of uninsured patients in that program. They were previously covered by DBH, but not anymore for substance use disorders.
Okay. So, I'm sorry, say that last part. Is this specifically for substance use disorder?
Yes. So as of October 31st, we had patients that were not Alliance enrollees who had coverage through DBH for substance use disorders. As of October 31st, they also lost coverage.
Okay.
The Department of Behavioral Health is mirroring the requirements for the Alliance.
Got it. Okay. All right, I'm making
Which
note.
it was not the case prior to.
Okay. I will say this, I think that one of the things that healthcare finance in the past had always done was like, they always talk about, we want parity between our Medicaid program and we want parity between our Alliance programs. And perhaps we need to divorce ourselves from that, given even though we're making changes on the Medicaid program, there is a portion of those individuals who now have a different option. Whereas if you try to have the parity on Alliance, then there's a gap, a larger gap, right? And that's something we'll certainly have conversations with in terms of the executive going forward. And perhaps maybe having to look at DBH doing their own level of eligibility, although I'm sure that can get complicated for some providers who do all different types of services. But you all have shown yourselves to be able to figure this sort of challenging state that we're in out. Okay. All right. Well, thank you so much. I don't have any further questions for you all. If you haven't provided your written testimony for the record, please go online and upload it. Thank you. Okay. All right. Bill Medford from the Festival Center. Carolina Miguel. Okay. Chris Gamble. Saw Chris. Claudia Sosa. All right. Daniela Gonzalez. Oh, wait. Okay. Who's who? Are you Claudia? And you're, okay, great. All right. All right, Bill, when you're ready.
Good morning.
Good morning.
Thanks so much for having this hearing, Chair Henderson. Thanks for allowing me to testify. My name is Bill Mefford. I'm the Executive Director of the Festival Center. You came and visited us a couple of years ago. You're always welcome back. I prepared testimony. I'll submit it for the written record. I'm going to put that aside, and I appreciate so much what Abril shared as a testimony and what Alana Eichner shared as well. We, all the organizations, there's a lot of organizations that are part of this campaign. We conducted a postcard campaign where we asked folks, residents in DC, to write down why the Healthcare Alliance was important to them. On the message on the postcard says, Dear DC Council, the DC Healthcare Alliance is very important to me, my family, and my community. The Alliance is part of what makes DC welcoming and safe for all residents. The healthcare coverage available through the Alliance keeps me and those around me healthy. The DC Council should restore the Alliance to cover everyone who has been eligible and prevent any further cuts to the program. So a number of these postcards, folks filled out why this is important to them, not only folks who were receiving healthcare through the Alliance, but also folks, just residents of the city. I'm going to set aside my testimony and read some of these postcards because I think, again, it's so important that we center the people whose lives are most directly impacted. William writes, I am a cancer survivor with limited insurance under Medicaid and Medicare. I am in dire need of medical assistance. Catherine writes, as a former school social worker, I can attest to the urgent importance of healthy families for a healthy community. We all lose when parts of our community lose access to healthcare. Cassie writes, healthcare is a human right. It helps me keep my parents safe and healthy as they get older. I need it to make sure they can get taken care of so I can do my job serving DC. Olivia writes, it's the role of our government to promote public health and keep us all healthy. Healthcare for all is a crucial part of that responsibility. Restore the Alliance. Celeste, and some of these I'm going to read as I can. Celeste writes, in my 40 years as a social worker in DC, I saw that access to healthcare literally saves lives. It also saves the city money because it decreases the number of ER visits and hospital options. Healthcare is a human right. And I'm not going to read all of them.
Thank you. Chris?
Good morning, Chairperson Henderson. My name is Chris Gamble, and I'm a behavioral health policy analyst at Children's Law Center. Thank you for the opportunity to testify today about the changes to the district's Medicaid and DC Healthcare Alliance programs. The eligibility changes made to both programs were made to alleviate very real spending pressures. The decisions, however, were reactive and only took into account short-term savings. As a result, people are going to receive subpar health insurance in the case of the Healthy DC plan, or will have no option for insurance at all after the full implementation of changes to the Alliance program. My written testimony contains recommendations for preserving the Alliance program long enough to identify other funding sources, but I will focus today on Medicaid. Most of the clients Children's Law Center serves depend on Medicaid, many with complex needs that require specialized services. While children's coverage is formally protected, we are concerned that DHCF's methods for communicating about the eligibility changes may not effectively inform parents that their children still have coverage. Children losing coverage is an often overlooked consequence of adult eligibility changes, not recognizing the assumptions parents may make when they receive the destabilizing news that they have lost their own coverage. Parents may stop taking their children to appointments or miss renewal periods if they misunderstand the eligibility changes made. Even if children don't lose their coverage, they remain at risk when their parents lose coverage altogether or lose access to specific benefits. A particular concern we have is for those who will lose access to certain mental health and substance use services under the Healthy DC plan. Poorly managed mental illness and substance use are major drivers for child welfare investigations. The subpar benefit package offered by the Healthy DC plan opens up risk for parents whose behavioral health and ability to care for their children is jeopardized by having inadequate healthcare coverage. We urge the committee to explore solutions to close this coverage gap so that parents can get the care they need and children can remain safely in their homes. The financial pressures in the health system are real, and changes to benefits and eligibility are the quickest way to cut healthcare costs, but the district can reduce healthcare costs and improve health outcomes at the same time by focusing on long-term solutions. Furthering integrated care through changes to both service delivery and payment structures can create long-term savings and improve the care people receive. On the service delivery side, high-cost service utilization like emergency room visits can be reduced through co-located behavioral and physical health services and other methods for improving coordination of care. On the financial side, implementing the long-delayed carve-in of behavioral health services can incentivize even more care integration and provide tools for cutting down on fraudulent billing. The carve-in has been delayed multiple times since the initial planning in 2019, but the improved care and long-term savings gained through it are still possible. Thank you for the opportunity to testify, and I welcome any questions you have.
Thank you. Claudia.
Good morning, Chairperson Cristina Henderson and a member of the council. My name is Claudia Sosa. I'm a student at Bria Charter School, Ward 1 neighbor, and a proud DC resident. I'm here today because the recent change to the DC Healthcare Alliance have already impacted families like me. Families who work hard, pay taxes, and contribute to the DC every day. When I go to my radiology appointment, I worry not be available to pay if I receive a bill. For me and for many in my community, losing coverage for services like vision, dental, and other essential care cause fear and stress. We want to stay healthy so we can work, raise our children, and not have to choose between healthcare or paying rent or bill. I share my story today because those changes are not just a member or policy decision. They affect real people. When services are taken away, families delay care, live in pain, and lose stability. Restoring the alliance will bring relief and hope to thousands of DC residents. I urge the council to care the following step. Restore the income limit to 215%, the federal poverty level. Restore all services that were covered before October 1st, 2025. Remove the age cap out for adults 26 and over. Those changes will have cost $43 million in fiscal year 26 and now cost about $70 million in fiscal year 27. But they are necessary investment in our healthier and a stronger city. Thank you, Chairperson Henderson and all council members for your time and for listening to my testimony. I hope you will consider those solutions and make decisions that bring stability to many families like me.
Thank you. Daniela.
Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the council today. I am Daniela Gonzalez Rios, the Health Justice Coordinator at Advocates for Justice and Education. Each year, we assist hundreds of families through direct services training and advocacy in navigating the district's public education and healthcare systems, especially for children and youth with disabilities and special healthcare needs. Beyond my role at NAJE, I come to you today as a former DC teacher, the daughter of immigrants, a proud immigrant of Peru, and a member of Keep DC Healthy. In my conversation with families, I continue to hear deep fear and uncertainty about losing access to healthcare, often without timely communication or clear guidance about what these changes mean. Even when notices arrive, families aren't sure how to respond. Our health and political systems are already overwhelming, and relying on a single mailed letter or online notice to serve as sufficient instruction for something as important as recertification is inequitable and unjust. Across our city, immigrant and mixed status families are struggling to survive while their rights are being stripped away. We are witnessing violent, inhumane attacks, such as people being beaten and forcibly taken from their homes and streets, families left without hearing from their loved ones, Children are already losing parents and caregivers. We cannot compound that trauma by denying their families medical care. I think about the undocumented and documented caregivers who will lose access to critical care, the catastrophic harm this will cause on families' mental and physical well-being. We cannot expect caregivers, especially those raising children with disabilities, to meet their children's needs while their own basic health needs go unmet. These families deserve support, and that strengthens their stability and health, not policies that create new barriers. We must care for the people who have built, sustained, and uplifted Washington, D.C. That means investing in holistic, equitable, and culturally responsive healthcare. Healthcare is a human right. Therefore, accessible, affordable, and quality care must be treated as a top priority. Regarding the Alliance program, we stand with Keep DC Healthy and ask the DC Council to restore the income eligibility limit to 215% of the FPL, restore all services covered by Alliance before October 1st, remove the age cap for adults 26 and over, create an Alliance Advocacy Council, Alliance Advisory Council with appointed members from DHCF, DHS, and the public, including Alliance participants and advocates. Regarding DC Medicaid, we stand with Keep DC Healthy and ask DC Council to seek a 1332 waiver, commit to securing funds for dental and vision for basic health plan recipients, create a continuous enrollment period for the basic health plan, and grace periods for renewal if coverage is lost. Thank you for your time and consideration, and I welcome any questions you may have.
All right, thank you. Thank you guys for your testimony. Chris and Daniela, I want to ask you this. So I've got two different programs who are on two different time cycles, right? In terms of Healthy DC, we've got about 4 weeks before a transition is to occur on January 1. What would you say that healthcare finance, the mayor's office, health benefit exchange needs to be doing in the next 4 weeks? Now, I will say that based on the information we have, some people have already started to transition because their eligibility redeterminations had already come up. So we're not going to wait until January to do that. But tangibly, what should we be doing in the next 4 weeks for the individuals who are still going to be rolling on?
Honestly, I would suggest to continue listening and doing focus groups in the meantime with the testimonies, but also to continue advocating and implementing the recommendations that we are asking for, if possible.
So I know as far as the Healthy DC plan, I believe to make it equal to Medicaid, I think it would be like 60 million. So I understand that is a big ask. But looking at, I think it was the numbers DHCF submitted for this hearing. As far as the people who have utilized behavioral health services, it was around 2,000. I don't know what that cost adds up to, but I think we should look at that number not as a small number, as like it's not important, but here's something we can focus on as maybe something more feasible than the full restoration right away. Because I think those services, as I said in my testimony, these people not receiving things like community support or ACT services can have huge ripple effects. And since we've identified this relatively small but still very critical number of people, I think looking at things in a more focused way rather than saying, oh, fully matching Medicaid is going to cost 60 million, so we can't do anything. Looking at these smaller pieces and making those changes. And then I also just kind of I know you said just these next 4 weeks, but long-term, again, I think we need to focus on long-term versus just short-term things.
Well, I guess, let me clarify. I was talking about from an outreach perspective, because both of you mentioned in your testimony that folks not understanding when they receive the notice, what does that mean in terms of, as an adult, you may are transitioning to a different program, but your child still has Medicaid, X, Y, or Z. So I'm saying from an outreach perspective, what should we be doing? What should the agencies be doing better over the next 4 weeks on that front?
Could I ask you?
Oh, yeah.
Could I ask you, what would you need to see from the agencies when communicating with them? What would lean towards restoring some of the recommendations that we've been suggesting?
Well, I mean, that's what I'm saying. Two different timelines, right? So it is December. We don't have a budget in front of us. So the council cannot restore anything on Alliance today. We can't. We don't have anything before us. that conversation is something for as we go forward for FY27 and whatever the supplemental budget that the mayor is going to submit next year. In terms of Healthy DC, there are a couple of things that we're still trying to figure out as we head into the January 1, specifically as it pertains to dental and vision. There is a trigger, if you will, that's built in on Healthy DC, where all of the folks who are transitioning over to Healthy DC will get dental coverage if the Congress extends the premium health tax credits. Now, I know that's not encouraging to folks because Congress isn't really doing their jobs of late, but that's what that is. We know exactly how much the dental portion would cost. And our conversations with the executive is, okay, let's say they don't act by December 31st. What are you guys doing on January 1 to extend dental coverage, which we know is, we're talking about $5 million maybe here. Not a lot of money, which is something that they can do. So I'm talking about the outreach portion to inform people of what the transition is taking place. That was what my question was more about.
I mean, I would say, so they've been doing, I think even this afternoon, there's another like session that DHCF is holding to explain these changes to people. But in the ones I've attended, you know, the last one I attended, there were hundreds of people in there and people have a lot of questions. Even people who the changes don't apply to, they're just curious, like, am I losing my coverage? So I think these, whether it's those methods or mailing things out to people, you know, we have to question whether that's really sufficient. Are we informing providers so that they can talk to their patients directly about you still have coverage or it's changing in this or that way? And being consistent, staying consistent with it, because there's going to be gaps where people just miss something, misunderstand something. So I think really, you know, engaging in spaces, I think doing community engagement, being in spaces where people are, rather than just doing a webinar that if you're signed up for DHCF notifications, you'll know about it. But going to where people are and notifying them and listening to their feedback.
Okay, yeah, Daniela.
I do also want to add that it's not enough to just hold a PowerPoint presentation and give a little workshop. It's about the one-on-one support, the coaching through guiding families on what these services mean, the changes, and now what those changes are to the services that they are receiving. And on top of that, I also want to add that as we are hosting these listening sessions and putting priority as to how families are learning about this, it's also the material that's being given to families and how it's being addressed and taught. It has to be culturally responsive and also go through the language barriers that are currently existing for multiple diverse immigrant communities, and also at the same time consider the literacy level of DC and how there are so many barriers to currently going on in the education of children, but also the long-term effect that that has caused on families as well and their background. So I do also want to add that it has to be more responsive in that way, but also the data that DHCF is reporting and DHS being able to know transparent data of how many people are getting kicked out, who those people are, and how can we better assist those people. Because at the end of the day, there's also some guidelines of if we can get some people who we know are currently off and notify whether Deputy Mayor Turnage, then they could potentially get some medical insurance, or they can see what the avenues there are. So I think it's really important that we also are transparent about the data.
Yeah, okay. This is helpful. There is a grace period, so it allows for folks to, if you've missed the first notification, to be able to do that. But what we learned from the Medicaid redetermination process that occurred post-COVID, so once everybody was required to start to do that again, is that we had a lot of people who lost coverage for administrative purposes only. Either you missed the form, you didn't see it, you didn't act on it, life happened, all of the different things. And that I feel like is the most devastating part, is that it's administrative. It's not eligibility, it's not anything like that. It's literally, it's a paperwork process that is required, but we have to make it so that folks are able to do that. Okay. Thank you so much for your testimony. Thanks, Bill, for reading some of those cards, and thank you, Claudia, for being here. All right. East Peterson, Trujillo. Ed Lazier. I think I saw Ed. Oh, thanks over there. Elizabeth Falcon. Flora Barica. Okay. And Gabby Salato. Great. All right, Mr. Lazier, when you're ready.
Okay. Good morning, Councilmember Henderson. Thank you for the opportunity to testify. My name is Ed Lazier. I'm the Legislative Advocacy Director at United Planning Organization. UPO is the district's community action agency and has been working since 1962 to improve the economic security of DC residents with low income. Each year, we serve 52,000 DC residents with low incomes. All of them have incomes below 200% of poverty, and most are well below poverty. Our customers typically list housing and food as their greatest unmet needs, and we believe healthcare doesn't top the list because until recently, the district has been a leader in providing near universal access to comprehensive health coverage. We now fear that many UPO customers will list access to healthcare as a top concern as a result of recent cuts to Medicaid and the Alliance proposed by the mayor and included in the adopted 26 budget. I believe that we need to go beyond the thought that this is just that these healthcare cuts were simply a matter of budget necessity in tight fiscal times because because of their dramatic impacts. Some 25,000 adults will entirely lose health insurance as eligibility for the Alliance ends. 13,000 residents currently receiving Medicaid will lose dental, vision, and other coverage as they move to a basic health plan, and 1,600 Medicaid recipients will lose coverage entirely. That adds up to 40,000 DC residents losing health coverage or critical health benefits. This is a shocking figure in many ways, and we urge the mayor and council to reverse these cuts. First and foremost, it's an alarming retreat from the district's 25-year commitment to provide health insurance to literally everyone who has a low income and needs insurance. That led DC to be number 2 in the nation in the share of residents with insurance, with only a few percent uninsured. DC's commitment to healthcare as a human right is admirable, and it's also smart policy since we're all affected when people around us lack insurance. Abandoning that commitment so abruptly is shameful and a dangerous blow to our entire health system. Second, these cuts may be the largest retrenchment of DC's basic assistance in a generation, or perhaps since the start of home rule. I've been working in DC policy issues for 25 years, and I cannot remember a cut that affected so many people so deeply as the cuts that we have approved this year in healthcare. Third, these cuts rival the federal Medicaid cuts adopted by Congress this past summer. Under that legislation, an estimated 30,000 residents will lose Medicaid over the next decade. The number of people losing health insurance due to DC budget and policy decisions is almost as large. And when we count the folks affected either by losing insurance entirely or having the health benefits reduced, it's greater than the impact of the federal Medicaid cuts. We shouldn't be adding on to the deep federal cuts with local healthcare cuts. You've heard and will continue to hear today about how these policy changes already are harming DC residents who cannot get life-saving healthcare. We should not accept such a harmful and shameful retreat from our safety net. UPO encourages the mayor and council to fully restore eligibility and benefits in the Healthcare Alliance and to ensure that anyone transitioned off Medicaid has health insurance that includes dental and vision care. Thank you.
Thank you. Elizabeth?
Thank you, Chairman Henderson and members of the committee. My name is Elizabeth Falcon, and I'm the Executive Director of DC Jobs with Justice. DC Jobs with Justice is a 24-year-old DC-based coalition made up of labor, community, and faith-based organizations. Together, we are dedicated to protecting and advancing the rights of working people and supporting community struggles to build a more just society. Since early this summer, DC Jobs with Justice has staffed the Keep DC Healthy Coalition. Our coalition of health providers, grassroots organizations, policy organizations, unions, and advocates believes that healthcare is a human right and embraces DC's long history of nearly universal access to health insurance. We oppose the elimination of the DC Healthcare Alliance program and the plan to shift thousands of Medicaid residents to a new plan with limited or no access to dental, vision, and long-term care for adults. DC councils should act to ensure these programs fully restore coverage and maintain DC's role as a leader in ensuring that Black, brown, and low-income residents get the health care they need. We call on the council to fully restore the DC Healthcare Alliance to reflect income eligibility and services available in FY25. We further call on the council to ensure that Medicaid recipients who are shifted to a basic health plan do not lose benefits, and to provide coverage for residents who are economically disadvantaged and no longer eligible for Medicaid and do not meet the income eligibility for the basic health plan. DC's history of comprehensive health access and health insurance stands out as a shining example of what is possible when our leaders put people first and make deep commitments to fundamental human rights. Cuts to the Alliance and Medicaid are not only harmful reductions in service, but also an abandonment of our values. Our coalition has had a multifaceted approach to the Alliance changes, which, as we know, came first. We held 2 registration clinics at a church with deep ties in the Latino community in the very few weeks between when the budget was passed and the October 1st changes. And our coalition helped register over 250 patients in the program. Over the last few months, our coalition has collected 1,581 postcards from DC patients and residents who understand the critical importance of the DC Healthcare Alliance. These are from patients, families, union members, service providers, teachers, medical professionals, and parents who live in all 8 wards and are continuing to committed to ensuring care for all DC families. I have a few of their stories in my written testimony, and I think I have time to read one. Es importante para mí porque la salud mía y de mi familia es prioridad. Nunca sabemos cuándo necesitamos ir al médico y sin nuestro seguro a veces tenemos miedo. It's important for me because my health and that of my family is a priority. We never know when we might need to go to the doctor, and without our insurance, we sometimes feel afraid. Thank you.
Thank you. Flor? Oh, you got to turn your mic on.
Oh.
There you go. Thank you, Elizabeth.
Okay.
Thank you.
Good morning, Chairperson Henderson and member of council. My name is Flor Buruca. I am a student at Bria Public Charter School, a mother, and I work for residents. Thank you for allowing me to speak today. I'm here because the recent change to the DC Healthcare Alliance had made life more difficult for many families, including mine. We work hard, we take care of our children, and we try to stay healthy. But when important health services are taken away, it can much hard to keep our family strong. For me, the Alliance is important, not only for my own health, but also for my ability to care for my family. When the program stopped moving this like vision and dental care, many of us started to worry. These services are not extra, they are basic needs. Without them, people skip appointments, live with pain, or wait until their health gets worse. I want the council to understand that these cuts affect real lives. Many families do everything they can to stay healthy, but without support, it's become impossible. I respectfully ask the council to act. Bring back the income limit of 215% of federal poverty. Return all the services that were available before October 1st, 2025. Remove the age cap for people 26 and older. I know this change no cost more about 70 million in fiscal years 27 but healthy family help us see more. Thank you, Chairperson Henderson, council member, for taking this time to listen. I hope you will consider this solution and support families like me who love this city and want to stay healthy here. Thank you.
Thank you. Gabby?
Good morning. Can you hear me? Okay. Good morning, Chairperson Henderson and members of the council. My name is Gabby Salado. I'm the Student Services Coordinator at Brea Public Charter School. Every day I support adult learners in their work towards their education and personal goals. Thank you for the opportunity to testify today. The recent changes to DC Healthcare Alliance are already harming many students and families we work with. In the last months, I have seen students coming to school worried, stressed, and sometimes in physical pain. One of my students has been suffering from severe dental pain, but is afraid to go to the dentist because he knows he cannot afford the out-of-pocket cost for a tooth extraction. Several families have already lost their Alliance coverage due to the new income limitations. Other families still have Alliance, but no longer have access to dental vision or specialty care. They depend on these type of cares, services. So parents have shared that they're avoiding or delaying doctor visits because they simply cannot afford. They don't want to see a bill. These are real people facing real harm. When adults cannot care for their health, it affects their ability to learn, work, and support their families. I see the impact clearly. More absences, more stress, and more barriers to success. These problems were preventable. Respectfully ask the council to take actions to fix the DC Healthcare Alliance. One, by restoring the income limit to 215% of the federal poverty level, so families do not lose coverage when they take extra shifts at work or work multiple small jobs. Two, restore all services that were covered before October 1st, including dental and vision. Three, remove the age cap for adults because adults of every age deserve access to healthcare. These changes would cost $43 million in fiscal year 26, and that would cost $70 million in fiscal year 27, but are necessary investments. When adults have reliable health care, they can work, study, and raise their healthy families. I support creating an Alliance Advisory Council with members from DHCF, DHS, and community members. This would help ensure transparency and allow residents to be heard before major changes happen. For Medicaid, I encourage the council to support a 1332 waiver funding the dental and vision services under the basic health plan and continuous enrollment periods with grace periods like Medicaid protection. Thank you, Chairperson Henderson, for listening to the testimony, and I hope you will consider these solutions.
Thank you. Thank you to this panel of witnesses for your testimony. I don't have any specific questions at this point. You all are saying similar things in different ways, but I got the recommendations. I've written them down. And we'll certainly ask some questions about that. Obviously, this is not a budget hearing, but it is an opportunity as we lead up to the budget process, which is already starting on the mayor's side. So I think it is important to hear from folks, and I appreciate you all being here. If you could make sure you provide your written testimony for the record. Thank you. Okay. Hannah Estefanos? Oh, she did. Okay. Carolina Miguel? Who was on her way? Okay. Ida Varizi? Visri? Okay. Wait, hold on. Are they signed up to testify? Oh, they're all in different places though, but you guys want them all to go together. Okay, how about, why don't you wait? And then we'll do the next panel and we'll pull all of those folks together. They will pull from the list. Okay, so, all right. Isaiah Leibelsberg? Yeah, Isaiah's here. Kirsty Cipolla? All right, okay. Jamie Maggi? I'm sorry? Okay, if Jen is okay with that, because Jen would be next. Great. Okay, we're gonna go back. Carolina. Are you ready?
Good morning, Chairperson Christina Henderson and members of the council. My name is Carolina Miguel. I am a student at Brea Public Charter School and DC resident. I am also someone who currently receives healthcare through the DC Healthcare Alliance. Thank you for the opportunity to speak today. Even though I still have Alliance coverage right now, many of my classmates and friends have already lost their because of the recent changes. I see how stressed and worried they are. Some of them have health problems and are afraid to go to the doctor. Others are skipping important visits because they cannot pay it out of the pocket. It is painful to see people go out without basic health care. I study with people who work hard and take care of their families. For me, the Alliance is important because it helps me stay healthy so I can study, work, and support my family. But I am scared that I could lose my coverage next. What happened to my classmate and could easily happen to me or anyone else in our school community. Those changes are hurting real families. When people do not have access to basic services like dental, visit, and other essential care, they get sicker or no better. And when parents are not healthy, it affects their children too. I respectfully ask to the council to take action to fix the Alliance. The first I ask is return the income limit to 215% of the federal poverty level, so people do not lose their coverage just because they work a little more. Second, bring back all the services that we are covered before October 1st, 2025, including dental and vision care. Third, remove the age cap for adult 26 and older because everyone deserves health care. I know restoring those changes now costs more, but healthy families help create a strong and a stable city. I support creating any Alliance Advisor Council with members for the HCFC, DHS, and the community. This will help prevent student changes that surprise and harm families. Thank you, Chair Henderson and council members for listening to my testimony. I hope you will make decisions that protect families and make sure that people like my classmates do not lose access to the care of they need. Thank you.
Thank you. Okay, now tell me what your name is for the, okay, say it on the mic so they can hear you on, oh, yeah. Here you go.
Sequin Gray.
Sequin Gray. Okay, when you're ready.
Do you want me to go now? Yes. Okay. Good morning. My name is Sequin Gray, and I'm a concerned resident of Ward 1, a native Washingtonian, excuse me, a community organizer at DC Jobs with Justice, and a proud mother of 4 wonderful young men. The reason for my testimony today is to ask the council to restore the key pieces to the Medicaid program. At the age of 21, I gave birth to my first son. During that same year, my mom passed away, and I was taken off her private health insurance. Young, alone, and trying to figure out how I was going to keep my baby and I healthy, I went to apply for WIC. And during that time, WIC referred me to apply for Medicaid at the Department of Human Services. The program allowed me to get quality health care at little to no cost, and I was so grateful for that. I was alone. I didn't have anybody to depend on. So Medicaid does provide coverage for low-income residents like my dad, who is currently not able to work because he sustained an injury on the job. Workman's comp took forever to get him medical, to get him through physical therapy, and they had him waiting, and he was in pain all the time. But because he had Medicaid, he was able to go to find his own doctors and get his own care, and get the surgery that he needed to start walking again. So he had to get back surgery because he damaged a nerve in his back from falling at work. And so, as I stated before, I'm grateful for that because there was no way that we would be able to pay for that surgery out of pocket. It was like $70,000. Now, as a concerned resident and parent, I'm asking the council to please to keep the income requirements for Medicaid, the Medicaid program as is. $2,800 is not enough to live and survive in the District of Columbia. So how are residents going to afford their own health care? Ensure that DC residents have dental and vision insurance coverage. Low-income residents have a tough time affording their own health insurance, let alone dental and vision as an addition. As a result of these changes, 2,000 DC Medicaid recipients may not be eligible for the Healthy DC plan or DC Medicaid. My colleague and I were in the office just doing some numbers like, okay, let's see, if I make minimum wage, we won't actually be eligible for this program. If I'm full-time and I make minimum wage, I make over what the requirement is to get these benefits, to actually get Medicaid. So we thought that was really alarming. So it's just in closing, just a lot of residents depend on this program, and I did for the most of my young adult life is really important. And just urge you to consider to reconsider changing the eligibility requirements for DC Medicaid program. Thank you for your time.
Thank you. Hannah, sorry.
All right. Can you hear me?
Yes.
Good morning, Councilmember Henderson. My name is Hannah Estefanos. I've been a DC resident for over 15 years. And for the past 12 years, I've lived in the district with my husband, who is an immigrant to this country. When we were first married, money was tight. We were living in a rent-controlled one-bedroom apartment. But we were lucky. His green card processed quickly. We had insurance through our employers. We didn't have to worry about being able to go to the doctor if one of us got sick or injured. But for a lot of other immigrants in DC, including friends of our family, that's not the case. Either they're working jobs that don't provide employer-sponsored insurance, or they're not eligible for, or can't afford a DC Health Link plan. And even those who would otherwise be income eligible for Medicaid or age eligible for Medicare have to reach 5 years of continuous residency and legal status in the US before they even qualify. So that's a lot of people. DC Healthcare Alliance for 25 years has stepped in and filled those gaps and been just an absolute lifeline for healthcare for thousands of people. It's been so successful that by 2023, census data showed that over 97% of DC residents had some form of healthcare. It was second in the nation only to Massachusetts, and Alliance has been a really big part of that. But those tremendous successes are now being threatened by the cuts to the Alliance program that have already started. Data from last month showed that over 7,700 fewer adults were enrolled in Alliance compared to the same time last year. And of the 19,000 adults who are currently on Alliance, all of them would lose coverage by 2027 when coverage for adults is fully phased out. Yet the program was originally designed to be a program for adults and working people who couldn't access health insurance any other way. Would respectfully urge the council to restore those cuts, to restore eligibility for adults 26 and over, to restore the services that were formerly available and were cut this year, and to restore the income limit to 215% of the federal poverty line. The Healthy DC plan will cover a very small percentage of former Alliance recipients, but it's got a very narrow income eligibility, and it also excludes undocumented residents and anybody over the age of 64 who used to be able to be covered on Alliance. These changes would have cost about $43 million this year and $70 million next year, but that's just a tiny drop in the bucket of the district's over $22 billion budget. And the costs, if we don't reverse and mitigate these changes, are going to be catastrophic, and they're going to be felt for years to come. I would like to close with the words of Xiomara, who's a fellow Ward 7 resident like me. Her words are on one of the 1,500 postcards we've delivered this morning. And she says, "We all need to have health insurance and coverage. We have the right to good health. We work and contribute to this country that has welcomed us." Thank you very much.
Thank you. All right, Isaiah.
Hi, how you doing?
Good.
All right. Please, good morning, Chairperson Henderson. Thank you for providing the opportunity to testify for the DC Council's Health Committee Budget Oversight hearing today. I'm Isaiah Livelsberger, and I'm a bilingual case manager at Ayuda. Our organization has provided legal, social, and language access services to the immigrant community here for 52 years, mostly to immigrant survivors of domestic violence, sexual assault, trafficking, and other crimes. We believe that healthcare is a right, not a luxury, for all individuals, regardless of immigration status. The cuts to Alliance proposed in this budget, made in the name of cost savings, put my clients in life-threatening jeopardy. The current age cap of 26 especially disregards the medical needs of my elderly clients. My one client, a 71-year-old homeless immigrant who has lived and worked in the district for 5 decades, now must forgo physical therapy for her autoimmune disorder because she simply cannot afford it. Her reality reflects that of our other clients who must already navigate the prohibitively expensive costs of living in the district. And I want you to get an idea of the economic realities of these people. Alliance's old 215% federal poverty guideline cap puts the maximum gross income for a family of 4 at $5,700, just $5,700. After rent, utilities, childcare, transit, groceries, my clients simply have no money left. And they cannot absorb the really expensive cost of private medical insurance. Alliance is a lifeline for them. And it's their only way to avoid being uninsured. And we know this by comparing our insurance rates with those of our other offices in Maryland and Virginia, 2 jurisdictions who did not have programs similar to Alliance for undocumented folks. Before these cuts, our office was the only one who had a majority of our clients enrolled in health insurance. And that was because DC was a leader, one of the few jurisdictions in the country to actually offer a program like the Alliance. Over the past 11 months, I've witnessed this administration disregard the rule of law and manipulate DC's lack of statehood so that they can terrorize and police my clients into fear, all with little accountability or oversight. It's something that's concerned me, and I'm sure has concerned you as well. Yet the DC Council now has an opportunity to fight back and safeguard the lives of those who have been so disregarded by this administration. Saving Alliance not only protects your low-income immigrant constituents, but sends a clear message to this administration that their hateful agenda will not be tolerated. The long-term viability of Alliance is not a question of finances, but one of priorities. This same cost-saving budget freed up $1.1 billion in public funds to redevelop RFK Stadium through creative measures like debt refinancing. It is time for the DC Council to apply that same resourcefulness and dedication to Alliance, a program that is not nearly as expensive, but saves countless lives of your constituents. The Council must restore Alliance by returning the income limit to 215% of the federal poverty level, restoring coverage for vision and dental care, and removing the age cap for adults 26 and older. I urge you to do right by your constituents by giving them the basic necessities they need for a dignified life and to show us that you respond to this administration with action and not complacency. Thank you for your time.
Thank you. Thank you so much to all of these panels of witnesses. Isaiah, I just want to ask for clarification. You were mentioning that your organization has offices in Maryland and Virginia?
Yes, ma'am.
Okay. And so you guys don't just work on healthcare issues, you work on all of the variety of different things.
Yes.
But as you talk to your colleagues, as I imagine you're not just dealing with folks who are might be eligible for Alliance, but also for Medicaid as well. Do you have any feedback in terms of the transitions that are taking place on that program?
You don't really see as many folks in the Medicaid program. I think also like they're also just worried because they're starting to see, just different sort of cuts and, just changes, with their doctors and whatnot. But I would say a vast majority of our clients are those who are undocumented and would not be eligible for Medicaid.
Okay.
Yeah, I would say well over 60% of the clientele that I've seen.
Okay. All right. Hannah, you talked about, well, first off, thank you for being here and sharing your own personal experience. And I could say the same thing for Carolina as well as for Sequinley. Did I say it right? Sequinley. I wrote it down. I really tried. Sequinley. And I appreciate you all uplifting the stories of others and sharing that information. This is kind of one of those This is a tough situation from a variety of different standpoints because on the federal side, we know that there is experiencing of, in some ways, death by 1,000 cuts. Even people who have private insurance, we're already seeing a steep number of individuals who are dropping their private health insurance coverage due to the rising cost of healthcare and also the not continuation of the premium tax credits. And so, Hannah, to your point, our goal should be 99 to 100%. And we were so close. And now, because of a variety of different things, it's a setback, but I don't think we're fully eliminated here yet. And so we're going to work and try to do our best. There were some things that needed to be done in FY27 to make the financial plan balance, but we've already started conversations with the mayor's office about what does that look like going forward as they're starting in this process. And so that's why your voices and your testimony is so important today. So thank you so much for being here. Please make sure you provide your written testimony for the record. Thank you, guys. Okay. All right. Ida Vesri. Okay. Megan Gibbons. Guys. Just give me just a second. All right. All right. And Trina Van. Okay. She'll have to go on the next panel. I'm sorry. Jen Jenkins. Thank you. Okay. Ida, when you're ready.
Good morning, Chair Henderson, and thank you for the opportunity to speak today. My name is Dr. Ida Vaziri, and I'm a resident physician in neurology at George Washington, as well as a proud member of our union, and I live and work in Ward 2. I have the privilege to care for patients across the district, adults in GW and children at Children's National, many of whom rely on programs like the DC Healthcare Alliance to maintain their health and stability. Now, I want to share a story about the impossible choices that patients face when coverage is limited or unaffordable. So last year, I cared for a young father of 2 who had just suffered a major preventable stroke. And during his workup, we discovered that he had an irregular heartbeat, something that we routinely prevent with strong blood thinners like Eliquis. But when his pharmacy notified him about the cost, he and his wife were shocked. They were doing the math in real time: rent, childcare, groceries, and now a medication that was going to cost hundreds of dollars a month. All of this on the day that he was supposed to be going home. They asked whether something like aspirin could be used instead because that was far more affordable. But for his kind of stroke, that's just like putting a bandage on a gaping wound. And as his medical team, it was devastating to have to deliver the news that the cheaper option simply wouldn't protect him. The choice he faced between financial survival and neurological survival is exactly the kind of choice that more patients will face if access to the Alliance is cut. As a neurologist, I see what happens when people can't afford medications or follow-up care. Preventable strokes become permanent disabilities, missed appointments turn into ICU admissions, and untreated symptoms in children become developmental emergencies. These aren't theoretical outcomes. They're daily realities for patients without reliable coverage. The Healthcare Alliance is a lifeline for low-income residents who are ineligible for Medicaid. When people lose that access, they don't disappear from the healthcare system. They reappear in our emergency rooms, sicker and with fewer options. At a time when federal protections are shrinking, DC has the opportunity to lead. Maintaining and strengthening the Healthcare Alliance isn't just a moral responsibility, it's a public health necessity. For these reasons, I urge the council to reverse these cuts and protect the health and dignity of the people who call this city home. Thank you for your time and commitment.
Thank you. Dr. Gibbons.
Good morning, Chair Member Henderson. Thank you for the opportunity to speak today. I'm Dr. Megan Gibbons. I'm a pediatric resident physician at Children's National Hospital and a member of our union. I am here because at a time when the federal government is rolling back access to healthcare, it is even more important than ever for DC to step up and protect its residents. Across the country, we are witnessing a disturbing trend: reduction in safety net programs, attacks on immigrants, and growing barriers to basic health services. These federal rollbacks don't just create policy gaps, they create real human harm. And here in the district, we feel it every day. When my patients lose federal protections or fear of seeking care due to shifting national policies, they turn to local programs for stability. I've sat with parents in their child's room while they're getting chemotherapy, while their child is getting a breathing tube, or while they're praying that their child will live. And at that time, they are too scared to leave the hospital because of these federal policies. To have the rollback of the DC programs is a betrayal. The DC Healthcare Alliance cuts mean that at the exact moment these parents need more support, they are being pushed out of care. As a physician, I can tell you the consequences are immediate and profound. Patients delay treatment because they're unsure what is being covered. Parents bringing in children only when illnesses become emergencies, and individuals with chronic conditions try to stretch medications far beyond what is safe. These delays lead to more severe illnesses, more hospitalizations, and more preventable suffering. DC has long been a leader in health equity and supporting communities that are marginalized at the federal level. But leadership requires investment. If the district pulls back when the federal government retreats, we risk at deepening disparities and leaving our most vulnerable neighbors without a safety net. By restoring the Alliance program, the district can make sure to act in principle, that regardless of what happens nationally, every person in our city deserves care, dignity, and the chance to live a healthy life. This is not only a moral responsibility, it's a public health imperative. I urge the council to reaffirm DC's commitment to health equity by reversing these cuts and protecting the programs that shield our residents from the consequences of federal rollbacks. Thank you for your time and your dedication to the well-being of every community member.
Thank you. Dr. Van.
Good morning, Chairperson Henderson and members of the council. My name is Dr. Trina Van, and I'm a pediatric resident physician at Children's National Hospital. I'm also a Mid-Atlantic Regional Vice President of the Committee of Interns and Residents of SEIU, Local 1957, and a proud Ward 1 resident. The Healthcare Alliance program is a crucial part of our city. There's a very human cost to cutting the program and a crippling cost to our whole healthcare system. When patients lose access to basic preventative and primary care, their health needs don't disappear, they accumulate. Using Medicaid as an example, when coverage for pregnant women in the US was increased by 30%, infant mortality decreased by 8.5%. That means that almost 9% fewer babies died and almost 4,000 families remained intact because of affordable access to health care. Patients who once managed their conditions in outpatient clinics are going to be forced to rely on emergency departments as their only point of care. And as a result, our ERs are more crowded, our inpatient units fill with preventable admissions, and our staff, already stretched thin, are pushed even closer to burnout. The quality of patient care will suffer because of this as well. Children's National Hospital is the only standalone pediatric hospital in the city. So we regularly see patients coming in with complications that could have easily been prevented. Infections that started as minor issues, asthma, exacerbations caused by inability to afford routine medications, and chronic conditions that spiral out of control without consistent follow-up. The district is a melting pot home to many immigrant families, many of whom I see in the pediatric clinic. I treated a 4-year-old boy from Brazil in the emergency department for leg pain. He was diagnosed with osteosarcoma, an aggressive cancer of the bone. His only chance of seeing an oncology specialist was because of Alliance. Without it, he'll go to the ER for last resort care, foregoing preventative measures to manage his treatment. Where will he and other children get affordable access to life-saving vaccines for school or lab work to check for lead in their blood? For our newly arrived children, how will we check them for infectious diseases like tuberculosis and malaria to protect them and our community? These emergencies require more staff time and resources and longer hospital stays, all of which are vastly more expensive than providing routine coverage through Alliance. This is proven by the fact that the federal government recovers 48 cents of every dollar invested in childhood Medicaid and saves almost $2,900 in healthcare costs per insured child every year. I urge the council to fully restore the Healthcare Alliance program and invest in a system that prevents illness rather than simply reacting to it. This investment in healthcare will not only improve, but also save the lives of the children and families of DC. Thank you for your time and your commitment to our community's health.
Thank you. And Jen.
Good morning, Chair Henderson. My name is Jen Jenkins. I'm a Ward 7 resident and I'm a policy manager at Legal Aid DC. I'm here to testify about the serious harms caused by recent changes to the DC Healthcare Alliance program. Before October 1st, the Alliance operated much like Medicaid, providing basic, preventive, and life-saving care. But the Fiscal Year 2026 Budget Support Act drastically narrowed eligibility and coverage. As a result, the Alliance now serves fewer people, excludes essential services such as dental and vision care, and increases the downstream costs for the district as residents lose access to preventive care. These cuts affect roughly 25,000 of our neighbors. Since October 1st, Legal Aid has repeatedly counseled DC residents who previously qualified for Alliance but are now denied due to the reduced income eligibility. I'll briefly share a few examples. A Ward 5 cancer survivor who lives with her partner is in a household that makes her income ineligible for Alliance. Now, she is paid every 15 days, so $700 to $800 net. She lives with her partner who also works and earns about $300 a week less than she does. While she may be eligible for the Healthy DC plan in the future, she does not have the means to obtain the coverage she needs now without access to Alliance. In another instance, Ward 5 parents who are now over income for Alliance have a minor daughter who previously received coverage through ICP and should have her coverage continue. However, it remains unclear how the merger of ICP and Alliance may diminish the services she can access. When we informed the mother that she and her partner were income ineligible for both Alliance and TANF, she said it was very sad to receive this news because her family needs those benefits. And finally, the mother of an applicant from Ward 1 has active Alliance coverage, and she doesn't need to recertify until January 2026. However, her pharmacy has informed her that she does not have active insurance, which means she cannot obtain her diabetes medication, even though she has had the same Alliance card since 2020. These stories are not anomalies. They reflect what thousands of residents are experiencing. To protect access to care, the council must restore income eligibility, eliminate the age cutoff, and reinstate full service coverage. The council should also codify one-year recertification and permanent removal of face-to-face interview requirements. We also urge the council to establish an Alliance Advisory Council this fiscal year. The Advisory Council would be mandated to help improve program efficiency without sacrificing care and prevent abrupt destabilizing changes like we are seeing now. If the council does not intervene in the ways we suggest, eligibility will continue to shrink until low-income adults who do not qualify for Medicaid will have no coverage at all. The consequences for residents and the DC's healthcare system will be severe. Legal Aid urges the council to act now to reverse the harmful impacts of the BSA, to push the CFO to comply with funding the BSA contingency list, and to restore access to essential care. Thank you for the opportunity to testify.
Thank you so much to this panel of witnesses. Thank you for being here. It's always good to see physicians at our hearings. We get quite a few, obviously, the Health Committee on a variety of different topics, but we do find you all to be frontline experts in sort of dealing and seeing the impacts and effects of some of these things each and every day. This might not be a question that you all can answer per se, but one of the things that came up from earlier witnesses is around what is the communication of policies to providers, hospitals being one, around what is covered or not covered. And I don't know if you all have any particular insight. I don't think the Hospital Association is testifying today around what the communication has been like with healthcare finance to hospitals in general of what the changes have been and what they will be in the future. I don't know if any of you have insight into that because you are in the billing department.
I can speak to this a little bit. So on the inpatient side, when people are hospitalized, where we really run into this is when we're trying to figure out where people are going to go or where they're going to be discharged. And this is when we're, working very closely with our social workers Our social workers really get to know like the financial situations of our patients and the barriers that they face to getting care, once they leave the hospital. So I feel like we're running into more issues on that side now, making sure that patients will actually be able to afford their hospitalization and actually continue to get care once they leave and make sure that they're not just readmitted to the hospital with worsening complications. So that's kind of where we see these impacts most immediately.
Okay. All right. And we could probably ask some follow-up questions to the Hospital Association because I would be really interested in that. I think, Jen, you talked about a client who has coverage, but the pharmacy is saying that they don't. Well, first off, at some point, can you share that information of that person so that we can try to figure those pieces out? But how often are you guys getting those types of situations where it's active? We look in the system, it's active, but the provider is saying the coverage isn't there.
I don't have an exact number off the top of my head. I can get you that information later too, but I included it because it's just representative of what we're seeing every once in a while. I don't have an exact number.
Okay. Those are the ones where that was common before as well, whether it be something that happened in the DC access system or something to that effect. We saw a lot of that during redetermination where someone submitted the paperwork. They were supposed to be able to continue even while they were going through the process, but coverage was denied, and we want to make sure that those situations weren't happening. I also want to mention too, I don't know how much Director Turnage wants me to sort of telegraph this, but there have been situations and cases that have arisen where either someone was continuing treatment, they were in the middle of treatment, X, Y, or Z, and Department of Healthcare Finance has been able to provide exemptions for those individuals so that they can maintain their health insurance. I know that that is not the ideal situation where it is one-off as opposed to it sort of being a blanket coverage, but if you all as physicians or if you all in terms of legal aid and clients have those situations, do reach out to us and let us know. We can't always fix it, but in some situations where someone was going through chemo or had a surgery that was already on the books or those kinds of things, we have been able to make accommodations to allow for those services to be able to continue to be covered. The interesting thing about budgets in terms of healthcare is that what we deal with in February or March is truly an estimate, and enrollment changes dictate and those types of things. The types of enrollment changes that we are seeing now on both Medicaid and Alliance are actually what we were seeing in even earlier this summer in August and September. Didn't match what we thought was going to happen. And so that's always sort of the imperfect nature of this. But I also would suggest to everyone involved, and thank you guys for being here. And I don't want you to think that because my colleagues aren't here that they don't find this to be important. There are, I looked this up because I was like, where is everybody? There are 3 other committees who have a hearing right now. So there are colleagues in the building. So if you're looking for them, but Committee of the Whole has a hearing on Special Education Transportation, Business Economic Development has a hearing today, and the Facilities Committee has a hearing on DPR today. So folks are around. But when we look at the whole pie of the budget, the health programs, we take up a lot. I know we do. We take up a lot. We cost a lot. What that means, though, is that when it comes to finding the additional dollars to be able to restore programs, I can't do it within the health piece. Otherwise, I'm robbing Peter to pay Paul, right? I'm cutting HIV funding in order to pay for Alliance or whatever that may be. And so it is a council-wide conversation. It is a government-wide conversation because those additional resources have to come from some other places in order for us to be able to kind of move forward. And I think we're going to have a really difficult conversation about some of that stuff in the coming months. But this is good to be able to lay the foundation. So thank you all for being here. Please provide your written testimony for the record if you haven't done so already. Okay. All right, we're going to go to the next panel. Dr. Kate Sugarman, Catherine Landfield, Fair Budget Coalition. Okay, Saki. All right. Laura Warby. Laura's here. And Lisa Lopez Escobar. Oh, there she is. Okay. Okay. Dr. Sugarman, when you're ready. Oh, hit the button. Yep, there you go.
Okay. Good morning, Chair Henderson, and thank you for allowing me to testify today. We've spoken about this, about the cuts to DC Healthcare Alliance on Medicaid. I'm a family doctor. I treat low-income families in Ward 1. I've been doing this since 2003. I've been a doctor at Unity Healthcare since 2010. And a large number of my patients are recipients, some of them were cut off, of DC Healthcare Alliance. So this is deeply personal for me and for my patients. From the time that the budget reductions took effect, October 1st, 2025, I'm already seeing the devastating impacts on my patients. And I want to share an example. I can tell you in the past, DC Healthcare Alliance is a program that worked. Our patients could live, our patients could thrive. My patients with chronic illnesses such as diabetes, asthma, kidney disease, heart disease, cancer, they were able to receive without cost their medications, and they were able to receive their specialty care. So I'm now seeing the devastation of these reductions. I want to give a specific example. A patient of mine was doing very well on Alliance. She has diabetes. She required life-saving weekly injections, and these injections were really keeping her diabetes under control. She now earns just a little bit too much, so she was kicked out of the Alliance program. And even worse for this woman, or equally bad, is that she has diabetic retinopathy. So her retina, which is the nerve in the back of their eye that allows her to see, is being damaged to the point where she will go blind. But she was able to go to a retina specialist. They were giving her injections, laser treatments, whatever it is they do, and they were preserving her vision. But because she went just a little bit over the income, the retina doctor was not allowing her to come back. I personally, I'm supposed to be seeing patients. I called the retina doctor and I said, can you work out some kind of exception, something? Nope, she cannot come to our office. I said, well, what can she do? Well, she can go to one of the hospitals. She can apply for one of the charity programs. I'm telling you, these charity programs don't work. They're extremely time consuming. You also have to pay. So because of the crime of earning just a little bit too much, she is going to go blind, and her untreated diabetes will ultimately, destroy her kidneys, put her at risk of heart disease. And this was a woman who was really controlling her illness. When the woman got up to leave the room, I saw this poor woman was limping. And, so she has so many problems. My patients with early onset cancer will turn into cancer patients who have metastatic cancer, and then they will die from cancer. My patients with heart disease will no longer be able to see their cardiologist, so they will end up with heart attacks if they can't get their stents, if they can't get their catheterizations. Pumps for asthma are too expensive without Alliance. The ERs will become overwhelmed to properly treat the other patients waiting for care, such as car accident patients, trauma victims, gunshot patients. I urge you to reverse the funding cuts, return the income to 215% of federal poverty level, remove the age cap for adults over 26 years old, and restore the full slate of services covered by Alliance before October 1st. Thank you.
Thank you. Catherine.
Thank you for the opportunity to testify, Chair Henderson. My name is Catherine Lamfield, and I'm a longtime DC social worker, currently serving as the Senior Advocacy Strategist at Fair Budget Coalition. Our members advocate for policies to improve systemic racial, economic, and social inequities in DC. Fair Budget is deeply concerned about the severe budget cuts to Alliance and Medicaid programming this year, and the impact these changes will have on DC residents, communities, and the DC economy overall. We urge you to reverse all the cuts to Alliance and Medicaid passed in the FY26 budget. With the district having among the most extreme racial disparities in wealth and income in the country, and with health outcomes being inextricably linked to income and wealth, it is essential for DC to ensure quality health care for Black and Brown working class and poor residents. While I now work as an advocate, it is my time as a school social worker that most deeply informs my concerns about how badly these cuts will impact communities, like a rock that hits a windshield and the cracks radiate out in all directions. Working poor families experience tremendous chronic stress of living paycheck to paycheck or under the relentless grind of poverty. Sicker workers struggle to keep their jobs and pay their bills, including the rent. They have more challenges with getting their kids to school every day and keeping them healthy as well. The main effect I saw on children in families with inadequate health care was in the form of behavioral health challenges that decreased their ability to learn and thrive at school. Whether hyperactive or withdrawn, irritable or sad, I saw children filled with worry about their family's wellness and economic stability. I even had 2 families lose a parent directly due to insufficient health care. We urge you to invest $70 million in FY27 to return the Alliance income limit to 215% of the federal poverty level, remove the age cap for adults over 26, and restore all services that were covered before October 1st. We hope that you can direct $43 million of the excess funds held by Events DC or of the ample revenue surplus towards these changes for FY26 too. We also urge the council to invest $5.1 million a year to cover dental services and solve the problem of vision and mental health coverage for basic health plan participants. The narrative has been that tightening finances forced leaders to make significant cuts, but the solution cannot be to harm working class and poor residents in the process. In a year when almost $1.5 billion in public subsidies went to billionaire sports team owners, DC policymakers must reverse the rollback of life-saving essential health care. Thank you very much. I look forward to answering your questions.
Thank you. Laura? Oh, you got to turn your mic on, Laura.
Thank you. Good morning, Chairperson Henderson. My name is Laura Warby. I am a retired family nurse practitioner who provided primary care at one of DC's community health centers for over 2 decades. I also worked as a coordinator at another nonprofit clinic in the mid-1980s before the closure of DC General Hospital and the creation of DC Healthcare Alliance. I represented the DC Nurse Practitioner Association on the board of the DC Primary Care Association from 2003 to 2007 during a period of significant reorganization of healthcare delivery and the implementation of the DC Healthcare Alliance. I'm here today to remind the committee about why the DC Healthcare Alliance was created and why it should not be cut back or discontinued today. In 1999, more than 18% of DC residents were uninsured. The DC government managed a public hospital and set of public health clinics that served the uninsured, but was hemorrhaging taxpayer dollars while providing substandard care. Beginning in 2000, the city began a transition from a publicly run delivery system to a system based on purchasing care from the private sector through the equivalent of health insurance. Over the next 10 plus years, this new system allowed a network of charity clinics to begin billing for services through the DC Healthcare Alliance and Medicaid, strengthening and broadening their services and enabling most of them to become federally qualified health centers and medical homes and deliver much higher quality of care. In addition, DC Healthcare Alliance covers specialty care, which is an essential aspect of preventing and treating complications, as my former colleague, Dr. Kate Sugarman, illustrated, to avoid unnecessary and extremely expensive hospital care. As a result, the uninsured rate for DC in 2024 was 4.5% and even lower in 2023. And approximately 1 in 3 DC residents receives care through a community health center. The DC Healthcare Alliance covers patients who are not eligible for Medicaid, primarily due to immigration status. In my years as a primary care provider, the vast majority of my DC Healthcare Alliance patients were working in professions vital to our local economy, including childcare, elder care, construction, hospitality, and maintenance. In fact, according to research by the Institute on Taxation and Economic Policy, undocumented DC residents contributed $73.6 million in DC local taxes in 2022. We cannot go backwards by defunding this program. Primary and preventive care is much less expensive than treating the complications. 8 months of prenatal care costs about the same as 1 day in the neonatal intensive care unit. Think about that. When a person's diabetes or hypertension is diagnosed early, well controlled, we prevent devastating and expensive heart attacks, strokes, kidney failure, and blindness. There may be opportunities to save costs in the DC Healthcare Alliance program, so let's get the stakeholders together and come up with proposals. Let's approve the revenue raisers that have been proposed. Healthy people are essential to the fabric of our communities and our economy. Thank you.
Thank you. Lisa?
Good morning, Chair Henderson, and thank you for the opportunity to testify today.
I am Dr. Lisa Lopez Escobar, and I am the Advocacy Manager at Many Languages One Voice, where we work directly with immigrant communities across the district. I'm here today because the cuts to the DC Healthcare Alliance are already putting people in danger. For many of our community members, taking away Alliance is not an inconvenience, it is a crisis. Some have told us plainly that losing the Alliance would be a death sentence. Our members who are on Alliance are a core part of DC's workforce and culture, as Laura just mentioned. They care for our children and elders, prepare our food, and keep entire industries running. They contribute every day to the city's economy and well-being. Yet, they are also the residents with the fewest options for affordable healthcare. When we weaken the Alliance, we weaken our city. One of our members suffered a serious workplace injury in 2020. She fractured her knee in 7 places and needed surgery, and she still relies on injections every 3 months to manage osteoarthritis. She told us that without the Alliance, she could never have been able to afford the surgery, and she absolutely cannot afford private insurance now. As she put it, if they take Alliance away, I do not know what I will do. Another mother shared that Alliance covered her prenatal care during both of her pregnancies. After her first child, she developed postpartum depression and was able to access therapy. After her second child, she experienced facial paralysis and received treatment that helped her recover her mobility. She told us that without Alliance, none of that care would have been possible. These stories show what we see every day. Alliance is the only lifeline many immigrant residents have to basic life-saving care. We are urging the council to take 3 key steps that have already been mentioned today. First, legislatively restore the Alliance by returning the income limit to 215% of the FPL, restoring all services that were cut, and removing the age gap. And if that is not possible at this time, ensure that outreach is culturally relevant and linguistically accessible so residents can navigate this transition effectively in a way that avoids unnecessary administrative harm. Second, create an Alliance Advisory Council so communities are not blindsided by drastic program changes again. Third, strengthen Medicaid by directing DHCF to pursue a 1332 waiver and ensure dental, vision, and continuous enrollment protections for BHP residents. DC cannot thrive while leaving behind the very workers who keep this city running. I urge you to consider these stories and act quickly to protect the Alliance. Thank you, Chair Henderson, for hearing my testimony, and we hope you will consider these recommendations.
Thank you so much to this panel of witnesses. Some of you I've talked to before, others we're just meeting, but thank you for being here. Dr. Sugarman, I think in your testimony, you're talking about the patient. You more eloquently than I drew the connection of why vision coverage is so important to all the other parts of your body, which is always one of those frustrating things about how the federal government kind of operates or views healthcare, whereas dental and vision is not considered a part of just your health insurance altogether, but is this separate specialty piece. I wonder if you wanted to say a little bit more about that specifically. I know you deal a lot with Alliance patients, but one of the things that we've really been pushing for the mayor is around, okay, I know that we have this trigger for the premium health tax credits, but if it doesn't happen, come January, we need you to take action in terms of the supplemental budget to make sure that folks still have coverage. Do you want to speak more about the importance of dental and vision coverage to the whole body?
Yes, because it's all related. So just like this one patient can no longer see their retina doctor, on the downstream side, if somebody's diabetes or their high blood pressure isn't controlled, that it's going to damage their vision. So, and if you can't see, you can't work and you can't take care of your family and you can't be independent. So it's critical. And, there was the famous case in Maryland several years back where somebody without insurance died from a dental infection. So, the whole body is connected, including the mind, with the postpartum depression. So it's just all critical. And one part of the body can't be neglected. All right, well, your right hand can't get treatment. The eyes are the same way, that these services have to be covered in order for our patients to live and to thrive. You asked a question on the previous panel, and I just want to quickly jump in about how was the communication to the medical providers about the changes. It's been very inadequate. So there's constant discussion over medications that are no longer covered, and then I'll actually call the DC government and they'll say, well, they are covered, but the pharmacy is denying the patients their medicine. So the communication about what's covered, what's not covered is very, very inadequate. And we have to spend hours every day just fighting to get one prescription covered. So, and in the end, sometimes it will be covered. And then we were told after December 31st, 2025, Alliance, the new shrunken form of Alliance, will no longer cover brand name medicines, period. But there are diabetic injections, there are asthmatic inhalers that require brand name medicine. So the communication's been inadequate. Dental and vision are critical. We can't, there's some kind of statistics that when you suffer from dental infections, toothaches, it causes more days of missed work than most other illnesses. So the teeth, the eyes, the brain, they all have to be covered.
Yeah. This has actually kind of been a theme. This was even before we were sort of doing this transition, but when we make other changes on other things, for whatever reason, our pharmacists are like the last to know, even though they are the ones who are usually the first ones who's informing someone like, hey, there might be something wrong with your insurance, because people who have regular steady prescriptions, I'm going to see you every month. I may not see my PCP every month, but I'm going to see my pharmacist every month. And I think we might need to do a better job in terms of how we are communicating with our pharmacy providers in particular, who have a closer touch, or I'm going to say not closer touch. Well, it's closer. And I mean, sometimes probably more frequent as well, because they also are doing a lot of the immunization administration as well. So, okay, we'll bring that back to healthcare finance to see how we can improve on that front. That's very helpful for us to know.
And also, we've talked about in these hearings about having a working group, how we can possibly reduce costs for Alliance without killing our patients. And Laura and I know back in the old days, when you were an Alliance patient, you had to go to an Alliance pharmacy, meaning pharmacies in the FQHCs like Mary Center, like Unity. And we love our pharmacy. I'm at Unity, Upper Cardozo. We've got a wonderful pharmacy. And, if we could go back to that system, have patients go to the Alliance pharmacies. Nobody ever accused CVS of cost cutting, So the Unity pharmacy is far less expensive, and our patients would get the life-saving care that they need.
Yeah.
So let's have a commission. Let's study it.
Let me ask more about that. Catherine, Laura, and others have mentioned that as part of a thing. Now, you guys know I don't like to legislate very large working groups, 22 plus people. It does not work. I already got one of those I'm dealing with now. But what are you envisioning here? Because also in the past with healthcare finance, we haven't had to legislate it. So for instance, our maternal health advisory working group that they had specifically around the work that we were doing on maternal health and doulas, et cetera, we didn't legislate that. Healthcare finance just put it together. What are you hoping for out of that particular recommendation?
I actually didn't lift that up. So.
Oh, okay. Sorry.
Do you want to?
Yes. So when I was part of a group going around, DC Fiscal Policy Institute had recommended this, and it made a lot of sense to me because I always felt that as a frontline provider, I could see things that seemed to make no sense in terms of adding additional cost. Certain kinds of prior approval processing that was required, the frequent need to re-enroll. Some of these things created barriers that to me appeared to be adding extra costs. And I think if you got a number of people from a number of perspectives together, that they could probably find small things that would add up in terms of how to structure a program.
Okay. All right. I'll bring that up with the government.
And reducing pharmacy costs, as we know.
Well, the pharmacy solution piece that you're sort of talking about, I was actually, Laura, as we were talking about sort of the history in terms of Alliance and its evolution from what it was before we called it the Alliance to where it was at sort of the peak. It was a lot of the ongoing conversations with providers, with community around how to make this work and how to make it work better and where were the pitfalls that was occurring, and we need to get back to that. So thank you so much for being here. Please provide your written testimony for the record. for all the people who haven't provided their written testimony. You just upload it these days. So just go to the council website and just, and you're done. So thank you. Thank you so much. Okay. I skipped someone and I apologize. Kirsty Sipola, is she? Okay. All right. Great. My apologies. I overlooked that. Okay. Lisa Queen. No, Lisa. Okay. All right. Melissa Millar. I see Melissa. Patricia Stamper. I didn't see Pat. Okay. Rachel Metz. Rachel's over there. And Rosa Cruz. That's us here. Great. Okay. Okay. Kirsty, when you're ready. Okay.
Hello. So thank you, Chairperson Henderson, for the opportunity to provide testimony for the DC Council's Health Committee Budget Oversight Hearing. My name is Kirsty Sipola, and I am the Social Services Manager at IUDA's DC office. You heard from my colleague Isaiah a few minutes ago. So we at IUDA believe that local elected leaders should not make DC an even more unsafe and inhospitable place for immigrants to live. As you all know, district residents are under attack, being disappeared by ICE. I'm going to give a story about how this is actually connected with the Alliance. Less than 2 months ago, a 30-year-old DC resident, who's also my client, was picked up by ICE, and during the arrest, the agents severely injured him. He ended up in the hospital for 4 days, in and out of consciousness, suffering from a fractured skull, a fractured nose, concussion, and bleeding in his brain. We've been fighting to get him out of immigration detention to get medical care that he desperately needs, that they are not providing him in ICE detention. We are going to put in a habeas petition for him to try to get him out of detention. And he needs appointments with a neurologist and a facial surgeon as prescribed by the doctor who saw him in emergency for 4 days. Due to cuts to Alliance, if he does get out, he will not have coverage for any of this specialized treatment. And because of the insurmountable costs of healthcare in the district, treatment may not be accessible to him at all. As Dr. Sugarman mentioned, a lot of these specialists will just not see someone without health insurance, or if they do, it's astronomical prices. So let me be clear, this will be a second injustice done to him, this time by the local DC government. These cuts to Alliance are cruel, unnecessary, and preventable. District leaders have a responsibility to stand beside immigrant residents as they face an onslaught of relentless attacks from the federal government and not participate in said attacks. The federal government is implementing a cruel agenda and shutting the door on immigrant families. There could not be a worse time to turn our back on them and do the same. Instead, the council must restore the Alliance by returning the income limit to 215% of the federal poverty level, restoring coverage for vision and dental care, and removing the age gap for adults 26 and older. The lives of our immigrant neighbors literally depend on this. Thank you for the opportunity to testify today.
Thank you. Okay, Melissa.
Good morning, Chairperson Henderson, members and staff of the committee. My name is Melissa Millar, and I'm the Policy Director for Zedek DC. We're a small independent law center headquartered at the David A.
So you got to bring
Law
it down.
and Ward 8. Our mission is to safeguard the legal rights and financial health of DC residents with low incomes, dealing with the often devastating consequences of abusive debt collection practices and consumer-related issues. We're grateful for this opportunity to share our concerns about loss of access to healthcare, as well as likely increases in medical debt due to restricted access and coverage. Changes to the Alliance has already resulted in more than 2,700 people losing access to healthcare, and this reduction will only continue in the out years as the percentage of the federal poverty level that residents must fall below to receive coverage shrinks. We recently published a report noting that 90,000 DC residents already have outstanding medical debt, and of those, 13,000 are in active debt collection for specifically medically related costs. And these numbers represented DC prior to the changes being discussed here today, when fewer than 4% of folks, or 17,500 residents, were uninsured. With thousands in DC now losing coverage, not only will people end up needing care they can't afford, but some will be forced to seek care that they cannot afford and will end up in medical debt. The district, which just last year canceled more than $42 million in medical debt for 62,000 residents, is now implementing policies that will harm these same people. Residents with medical debt cut back on food, take out loans, and refuse medical treatment due to cost concerns and struggle to meet basic human needs on top of their limited to no access to address health concerns. We note that the district's recent revenue forecast indicated additional funds and that only $20 million is needed to address these specific Alliance concerns. Without a policy correction, we can expect increases in financial stress and medical debt, depression, psychological stress, and diminished well-being, as well as increased feelings of hopelessness and/or suicidal ideation. These stressors will extend outward from individual to family and to community. Thank you for the opportunity to testify. I'm happy to answer any questions.
Thank you. Rachel?
Good morning, Chair Henderson. I'm Rachel Metz, testifying on behalf of DC Action.
Rachel, hold on. We're gonna start the time over. Yeah, we can't hear you.
Sorry. Good morning. Thank you for the opportunity to testify. First, we want to thank the committee for some of the changes that you were able to make during budget season, particularly ensuring that recertification in the Alliance would remain annual and not require burdensome, risky in-person interviews. We also appreciate the work DHCF has done to elevate information on the CHIP from conception to end of pregnancy option so that pregnant individuals and the children they birth can benefit from the coverage for which they're eligible, even as other programs are no longer available. We encourage continued work to ensure fast enrollment, particularly given the district's persistent racial disparities in first trimester prenatal care. That being said, we very much share the concern of the many community partners who you've been hearing from today. You've been hearing about how changes to the Alliance have resulted in people not able to access life-changing and life-saving care, and we echo that. For youth and adults alike, the expansion of Medicaid has proven to improve access to care, decrease mortality, and reduce reliance on emergency services. And as you've heard, when adults are struggling, they can't support their kids in the same way. So we know both from the research on Medicaid and from what we're seeing already from providers and community members that cuts to the Alliance aren't just impacting those who lose coverage, but their children and whole families. In addition, parents who lose coverage, as you've heard, may not realize their children are still eligible, and even if they do, there's a lack of clarity about what that actually means. For example, while there's one portion of the DHCF website that states that Alliance Children's benefit is identical to the Medicaid benefit for children, it isn't clearly conveyed everywhere. In the handbook, in the Alliance resource guide, there's this grouping together of children and adults that says that children also, or that implies that children also don't have benefits for non-emergency transportation, vision, podiatry, and some other services, even though the handbook does list out a couple of those, but not all of them. So with that potential ambiguity, we're worried that providers may deny coverage. We're worried that parents may not know, oh, actually, my kid is eligible for this. So, you were talking about areas where we can improve the communication. This is a clear one where if kids do have the coverage identical to Medicaid, that should be clearly communicated. Last but not least, we're also concerned about those who lost coverage from Medicaid and aren't part of the new basic health program. Again, loss of healthcare can create wide-ranging harm to individual, family, and community health. Thank you for your attention to these issues.
Thank you. Rosa?
Good morning, Chairman. My name is Claudia Belloso from Brea Public Charter School, and I'm a Student Services Coordinator, and I'm representing our student Rosa Cruz today, so I'll be speaking on her behalf. Good morning, Chairman, Chairperson Henderson, and members of the committee. Thank you for the opportunity to testify today. My name is Rosa Cruz. I am a mother, a student at Brea Public Charter School, and a DC resident who depends on the DC Healthcare Alliance. The recent changes to the Alliance have brought fear and stress to many families like mine. We work hard, we raise our children, and we try to build a better future. But without healthcare, it is very hard to stay healthy, study, and keep working. I am a Ward 4 resident. We love DC. It is our home too, which is why I am here to advocate for healthy families in the district. I am asking the council to restore the Alliance in 3 ways. First, return the income limit to 215% of the federal poverty level. Many families work multiple small jobs and still cannot afford private insurance. They should not lose healthcare. 2, restore the services that were available before October 1st, 2025. Cuts force people to delay care, skip medicine, and wait until illnesses become serious. And the third one, remove the age cap for adults 26 and over. Adults of all ages, especially parents, need access to healthcare to keep their families stable. I understand these changes now cost about $70 million in fiscal year 27, but this investment is worth it. When families have healthcare, we can work, study, and contribute to DC. A healthy community benefits everyone. I respectfully ask you to act and restore the alliance so families like mine can live and grow in DC without fear. Thank you for listening and investing in keeping DC healthy.
Thank you. Thank you to this panel of witnesses for your testimony on these issues. Rachel, I want to ask a follow-up. You talked a little bit about the communication specifically, if an adult has not been covered but a child is still covered. What's a best practice on sort of communicating those kind of unique situations, which I'm sure other jurisdictions have a similar case because their eligibility looks different for children in a lot of different places than it looks like for adults. Is it about placement, right? Like, okay, if I'm going to send a notice, do I put the information about your child first and then about you so that you keep reading? Or I don't know. Any thoughts on this?
So the best practices and outreach isn't something that I've looked at, but I think there are folks here who do that direct community work who would have better insight.
Okay. All right. Melissa, thank you for being here, for the work that your organization has done specifically around the medical debt issue. And, we have legislation that you all worked on with us that we'll have a hearing on shortly, I guess, this month, talking about this particular issue. But I don't know if you wanted to say more about what you all are seeing even now.
We just continue to see people kind of falling into crisis, and we're greatly appreciative of the bill that you've introduced and look forward to our hearing in a few weeks. But to the extent that some of the people that I mentioned in my testimony who are going to need healthcare and are not going to be able to avoid it because of whatever their condition is, and then will result in medical debt, depending on where that person goes and gets care, even with the bill that we're looking to discuss in a few weeks, there could still be ramifications and people could still be left with medical debt. So as we look to fix an entire system that is not serving people, the folks who are, as people have testified today, they were getting coverage, they were addressing their medical concerns and now can't because their coverage is lost. They are still going to likely be stuck in a system where they're going to need to seek out care because of what is happening to them. And if we're only looking at like large hospital facilities who are providing care, that is not going to sufficiently address the medical debt issues. We need to really consider all of the various providers, as we were talking about today, dental providers and vision providers. We've seen a lot of issues with those providers specifically, with people ending up in medical debt. And so with that coverage now being pulled away from them, it's just creating additional problems for them.
Yeah. Obviously, I don't want to turn this into the medical debt hearing, so we'll talk about this more in a couple of weeks. But I hear you when you're talking about we're looking to address a problem, but we're also might be contributing to it by some of our same policies at the same time. So definitely heard. I mean, on that front, I think we could say the same thing about the federal government in terms of the Consumer Financial Protection Bureau feeling like, a few months ago, they didn't think that medical debt needed to be on your credit report because it's not a strong predictor of your ability to pay on other types of things. And now all of a sudden it's like, no, nobody can take that off. Guidance. not law. So nonetheless, okay. I appreciate you all testifying today. Thank you for sharing Rose's remarks so that we have that on the record as well. If everyone can provide their written testimony for the record. Thank you guys for being here. Okay, I need to make one little change. Nancy Ban from Mary Center. Okay. Rose Whalen. Sharad Worthimer. Sophia Ballman Spencer. Okay. And Vanessa DeVillibus. Oh. Okay. All right, Nancy, when you're ready.
Good morning, Chairperson Henderson. My name is Nancy Ban, CEO of Mary Center. Thank you for the opportunity to testify. This morning, I want to speak briefly about dental care, not as a standalone service, but as a vital part of managing chronic diseases and improving health outcomes for our residents. In 2024, Mary Center cared for a number of Alliance participants living with chronic diseases such as diabetes, hypertension, and cardiovascular conditions. For individuals with multiple chronic conditions, oral health is directly tied to daily stability and long-term well-being. We saw that when dental care is accessible, Mary Center patients use it. In 2024, 40% of our Alliance participants with diabetes and 38% of those with hypertension received at least one dental visit. To put this in context, nationally, only about 20% of low-income adults on Medicaid receive any dental care in a year, and about 65% of adults in the general population get an annual dental visit. Our experience shows that when preventative care is accessible and connected to primary care, high-risk adults engage with it. In addition, the clinical evidence is clear. Poor gum health worsens blood sugar and blood pressure, increases inflammation, and raises cardiovascular risk. Treating gum disease alone can lower A1C levels by 0.3 to 0.4%, similar to the impact of adding another diabetes medication. Beginning in October of this year, adult dental benefits were no longer part of the Alliance program. I understand the cost pressures behind the shift. Therefore, my goal today is to offer practical, affordable approaches we may want to explore together to support oral health for residents. Across the country, cities such as Boston, Salt Lake City, and Tulsa, Oklahoma, have adopted simple, low-cost prevention models. One evidence-supported approach is integrating a brief oral health check into medical visits. A member of the care team can take a moment to look for signs of gum inflammation or infection, and if something is noted, the patient can be connected to preventative care already available in the clinic. That preventative care is limited and focused: cleanings, gum care, and early infection management. Services can be delivered by hygienists where available and by early career dentists eager to build experience. This prevention-first approach uses the dental chairs and staff we already have, helps avoid expensive emergencies, and supports better chronic disease. And of course, even with a prevention-first model, there will always be a number of residents that will still need more extensive dental care. While those needs fall outside the scope of my discussion today, it underscores why prevention is so important. The earlier we intervene, the fewer residents will reach the point of needing complex, costly treatment. With prevention-focused solutions, we can strengthen chronic disease care, avoid costly complications, and improve health outcomes across our city. Mary Center stands ready to partner with the district, and I thank you for my testimony today.
Thank you. Rose?
Good morning, Councilperson Henderson. I'm Reverend Rose Whalen, pastor of Sixth Presbyterian Church at 16th and Kennedy Northwest in Ward 4. It's a congregation with about 10 different nationalities and represents people from the city across racial and economic lines. But I thank you for taking time to listen to the people's concerns today. I'm here to just simply add my voice to those who are asking that funding to the Healthcare Alliance be restored, recognizing that even with what was done, there were people already falling through the cracks. You've heard many stories, and you may hear more. I could add more about my friend who had breast cancer that would have only been found if she was only found because of her healthcare coverage, which is now threatened because her premiums have gone to $1,300 a month. My sister has no coverage, struggles with chronic illnesses, and my own experience is because with excellent care, my vision is being saved from a retina disease. What I know is that good healthcare saves lives and allows people to remain productive members of society. If we have learned nothing else from the most recent pandemic, we know that we all are at risk at any time of a health crisis. My faith calls me to participate in building a better society, or as we say in my tradition, getting closer to that kingdom of God here on earth. We are commanded to care for the sick, and so health care for all is imperative for a strong society, for a country, and for our city. And until we can somehow manage to get a more national, universal healthcare system for all, please, please, let's do what we can to provide for the people here in our own city. These are the people who, in fact, keep us running in critical ways, even though we don't always see them, and they are so vulnerable without healthcare. I can hear from your questions and your being here today that you do wish to find ways to provide this coverage. I want you to know that the people of faith, at least from the Presbyterian tradition, are behind you.
Thank you. Sophia.
Good afternoon, Chairperson Henderson and staff. My name is Sophia Boulimian Spencer, and I'm the Employment Policy Counsel at the National Domestic Workers Alliance. NDWA represents over 9,000 domestic workers in the district, most of whom are immigrant women and women of color. These workers provide the caregiving and cleaning services that make all other work possible in our city. Nearly all of our DC members rely on Alliance, making the program's stability essential to their well-being and to the strength of the district's care economy. Alliance is most of our members' only access point for essential health care. They describe it as the difference between catching a problem early or ending up in a crisis, between affording medication or going without, and between staying healthy enough to work or losing the ability to work entirely. Domestic workers rarely receive employer-provided health insurance. When working in private homes, they are usually the sole employee and have to work in multiple homes to reach full-time hours. This means that household employers fall far below any thresholds that trigger legal obligations to provide their workers with health insurance. For this workforce, Alliance is not supplemental, it's the only path to preventative and emergency care. The recent cuts have already harmed domestic workers. Our members report losing coverage, reduced services, and delaying or foregoing care because of new barriers. Many face out-of-pocket costs they cannot afford, and others fear losing access to the services they rely on to remain healthy enough to work. The new income threshold also fails to reflect the realities of domestic work. Many of our members fall just above the cap while still being considered low-income workers. They are not losing eligibility because they can now afford private care. They are losing it because the income limit no longer aligns with wages in this sector. Moreover, domestic workers are an older workforce with a median age of 45 years old. Reducing age eligibility will significantly impact this community. As my colleagues have already expressed, we urge the committee to, 1, restore the Alliance program by returning eligibility to 215% of the federal poverty level, reinstating previously available services and eliminating the age cap. 2, create an Alliance Advisory Council to ensure accountability and meaningful community input before future changes. And 3, stabilize long-term access by expanding eligibility for the basic health plan, securing dental and vision coverage, and establishing continuous enrollment protections. Domestic workers already face inequities due to gender, race, and immigration status. Many depend entirely on Alliance for their health and financial stability. We urge the committee to restore and protect this essential program and to listen from testimonies directly from our members and Chapter Director Alana Eichner. Thank you for the opportunity to testify today, and I've also submitted a written testimony.
Thanks, Sophia. Vanessa?
Good morning, Chair Henderson. Thank you for this space. My name is Vanessa de Vilbis. I'm a DC resident from Ward 1 and a care manager and mental health provider at Bread for the City Medical Clinic. I'm here before you deeply concerned about the recent changes to the DC Medicaid and Alliance programs. These changes may look like cost-saving measures on paper, but they come at a devastating human cost. These are decisions that are already causing and will continue to cause real harm to real people. I want to remind the council that behind every statistic, there's a person. These are our neighbors, our coworkers, our elders, and our children who deserve to live with dignity and health. When people lose access to preventive and routine care, the consequences are predictable and pernicious. From a human perspective, all the recent changes are unacceptable. But even from a fiscal standpoint, it's unsound. Preventive care is far less expensive than emergency care. Like the physicians here today have said before, better than me, we all know that covering a dental cleaning is cheaper than covering an abscessed tooth that turns into a hospital admission, and that providing access to the right medications can prevent expensive ER visits and long-term disability. As a mental health professional, I must emphasize that mental health is a key component of preventive medicine. Emotional well-being is directly linked to physical health. Chronic stress, anxiety, and trauma are all well-established risk factors for conditions such as hypertension, heart disease, digestive disorders, weakened immunity, and even type 2 diabetes. Because addressing mental health prevents these physical manifestations, expanding access to mental health services should be an essential part of the council's plan to improve health in the district. I'm seeing more and more people stressed and anxious about losing their medical insurance, and it's taking a real toll. These cuts leave patients without care and create a community that is sicker, more stressed out, and dependent on providers and FQHCs who are already stretched past capacity. We have to ask ourselves, is this really the type of community we want to build? The district's budget should reflect our shared values, that healthcare is not a privilege, but a foundation for human dignity and community well-being. And it should reflect good financial stewardship because investing in prevention saves money and keeps our residents healthy and able to contribute to our city. I urge the council to restore comprehensive coverage, including vision and dental to the Alliance program, to include access to mental health services to Alliance members, and to revisit the lowered income level qualifications for both programs. The cost of inaction will be paid by all of us. Thank you for your time. Thank you for caring, and thank you for your commitment to the health and dignity of the residents of DC.
Thank you. Thank you to this panel of witnesses for your testimony. And this is the hard part when folks from the same organization have testified multiple times because, but I think it reinforces. And if some of my colleagues who weren't able to listen at the beginning are now here, hopefully they can hear some of this testimony. So thank you both for being here and for the work that you all do. And I guess I should say separately too for the folk at Bread's medical clinic, I would love to have the opportunity to come visit. I've been making my rounds to our health providers and things like that. And I didn't realize that you had such an extensive medical clinic available at Bread for the city. So I'd love an opportunity to come and talk with folks there. Great. Reverend Whalen, thank you for being here and for the advocacy and the work that you all do in the community, but also helping to be a safety net and a lifeline for folks in the community, particularly up in the Ward 4 area. Ms. Ban, thank you for being here. It's good to see you last month. What is time? I was at Mary Center. What is time? And certainly appreciated your testimony on dental. I don't know if you were here when Dr. Sugarman was here to provide some information in terms of that. And obviously we talked about that while we were at Mary Center. Can you say more about, you listed 3 cities, Boston, Tulsa, and Oklahoma City. Are these supplemental programs that they're providing, or is it just a change in how they are approaching care in the clinic operation?
It's considered primary care, so it's not separate. To your point earlier, where we look at it as an ancillary or a specialty care, in those cities, they look at it as checking your blood pressure, you're checking gums. And so they're able to make interventions quicker because it's part of that natural check and it's not seen as an ancillary separate service.
As it pertains to insurance?
Correct.
Okay, so but if you needed
wrapped around in there, it's added into that bundled rate.
Okay, but if you needed a referral,
that would be something separate. Something more complex would be something separate.
Okay, I was having this conversation with an organization who does the vision checks at schools. I was having a very similar conversation, right? Of like, okay, vision is important for you to see the board, for you to understand and read whatever is being provided to you. But if in their model, they're able to do everything at the school, they just need the permission of the parent. So they do the initial screening. If there is something that, a red flag that checks back, or, I guess when you cover your eye and you're reading and a young person is having difficulty, then they are able to do the follow-up. If they determine that the child does need glasses, they do all of that at the school, and then they deliver the bifocals to the child at the school, so that there's never this additional one, you got to come out of school to get an appointment and do this and that and X, Y, or Z. And frankly, it's that sort of community health model of let me meet you where you are, which I think is super helpful, but they don't bill for that. They fund it via grant, which is something separate than what we're kind of talking about here. But I think someone said earlier, our needing to sort of think outside of the box in terms of traditional modes of how we provide healthcare to help the preventative pieces. I don't know if you wanted to say more. There were a couple of other FQs who testified earlier about what you all have been seeing at Mary Center in terms of patient volume.
We have definitely started to see a dip in patient volume. And I think my concern, and there's the obvious reasons why we're seeing that dip. And my concern is added to this testimony is that the longer we delay care, that at some point, just like COVID and everyone delayed care, we're going to see more emergencies and people that are in a lot worse shape than had they received the care in the beginning. And so I know that you're also taking a look at remote monitoring. I think there are other applications and technology that we can do to keep making sure that we are attached to the patient, that we know what their glucose levels are, if there's fear to come into the clinic, so that we can have a strategy to help them if they need it.
Yeah, we have a bill on patient monitoring this month. Got a lot of hearings this month. They wanted to pilot in right before we left for the holidays. But these are important conversations, particularly before we head into the budget. Because what I don't want is for the executive to say, we didn't know. Oh no, let's talk about it early and soon so we can sort of be thinking about some of these things as we kind of plan on that. And I do want to say, because I don't feel like we've said it in a hearing setting, but folks who do the community health work, particularly in DC, in August and September, did yeoman's work to try to make sure that folks were able to stay connected, like even delivering medications to folks' homes because they didn't feel safe going to the pharmacy. So the community health workers were actually going to get that and drop it off and sort of doing all of those things. And so I don't know if we ever talk about the community health worker in the same way that we talk about a physician or nurse or some of these other pieces, but they are super, super important in terms of our public health ecosystem. Anywho, that was a tangent. I apologize. Thank you all for being here. Thank you for your testimony. Please provide it for the record. And we'll obviously have an ongoing conversation with your organizations as we go forward. So thank you. Okay, William Young. Right. I think Fari Gamia is testifying on behalf of Yvette. Okay. Now I got like 4 more people on this list. Let me telegraph now. I'm hoping to take a break because I've been sitting here since 9:30. Okay, Noemi Platero. She's here, okay. Guillermina Luano. Okay. Allison Miles Lee. Okay, Allison's here. Wait, Allison, I was supposed to go back. Is Sharad here? Okay. Hey, if y'all want to be paired up with a virtual person, that's fine too. Okay, and Chioma, I saw you here. All right, Mr. Young, when you're ready.
Good morning, Chairwoman Henderson. I am Reverend William Young, Senior Pastor at Covenant Baptist United Church of Christ in Ward 8, and also a resident of Ward 8. I'm here to testify against the severe budget cuts to the DC Health Alliance in the name of savings and its impact on the 8,000 residents of Bellevue. As a pastor who regularly provides pastoral care to families within and beyond our church walls in the community, I see firsthand the blessings and the possibilities of a city government that cares enough about all of its citizens to provide access to health care that eases the burden of life in one of the most expensive cities in the nation. I care for them when they are in the hospital, and I care for those families when they pass away. Our church health ministry, which is led by a registered nurse and the director of global health for the NIH, they regularly accompany the pastoral ministry with health care to the neighborhood. Our church also runs a food pantry and community garden to provide healthy options for our residents in the community, as well as a counseling ministry. And so our church is deeply rooted in providing tangible hope in response to the challenges in our community. And we consider the DC Health Alliance a partner and a guide. And we worry that the severe cuts to what has only been a lifesaver to the 8,000 residents of Bellevue will cause undue suffering, undue illness, and undue death. When I heard that the cuts were going to begin so quickly in October, our congregation joined the movement to write many of the postcards that have been presented here today by Mr. Mefford. They tell of stories of healing and care by a system that cares and that should not die out. I'm here because all people deserve good health care, and I know at your heart you know this. You yourself have said, Madam Councilwoman, that the significant cuts to the Alliance is only an issue that would be entertained by this council so swiftly because of the threats by Congress and in order to align with the enforcement of the big, beautiful bill. But that does not stop the fact that every human being in a free society deserves good health care. And it is the responsibility of our leaders to, by hook or by crook, salvage what is a human right. Now, others will give statistics and ground stories, but as a pastor, I have too many that I can name. But I'm going to invite you to do something that pastors don't normally do. I'm going to ask you to be selfish, because the thousands that may die because their counsel here would not support them, no stories will be told about them. But someday, somebody, some historian will want to tell your story. And so do you really want it to be said when the history books are written about you, about how the District of Columbia survived a time of tyranny, that you aided and abetted in the decline of healthcare in a city that you served, that you yielded to Caesar and did not fight back for God's children? The story that could be told about this council could be glorious, that it resisted in the face of tyranny, that it fought for the ones that Jesus called the least of these, that it was the model of righteous governance in a time of normalized racism and xenophobia. That story could still be told about this council. Keep the Alliance fully funded, return the income limit to 215% of the federal poverty level, remove the age cap for adults 26 and over, restore the services covered by the Alliance. Thank you.
Thank you. Ms. Platero.
Thank you. Good morning, Chairperson Henderson. My name is Noemi Platero. Thank you for giving me the opportunity to speak today. The recent change to the DC Healthcare Alliance have made life very difficult. The cost of life in Washington, DC has gone up by a lot. So the DC Healthcare Alliance is the only way I can get healthcare. The income limit is now so low that many people, including me, we worry we will lose of health coverage. Even if we keep the Alliance, we lose dental, vision, and special care. Those services are important when people cannot get glasses or dental care or see a specialist, their health gets worse. For me, going to the doctor is already stressful. I worry about the bills. I worry that one emergency will cost more than I make in a month. I work hard, but I still cannot pay for private insurance. The Alliance is the only support I have. I ask the Council to please help families like mine and restore the Alliance in 3 ways. Number 1, bring back the income limit to 15% of the federal poverty level. Number 2, restore dental, vision, and special care. Number 3, remove the age limit for adults 26 and older. I work, I contribute to this country, and I take care of my family. I am only asking for the chance to stay healthy so I can continue supporting my community. Thank you for listening and for support DC resident like me. Thank you.
Thank you. Allison. Oh, hold on. Okay, there you go.
My name's Allison Miles Lee. I'm a managing attorney at Bread for the City. At the intersection of our legal and medical programs, I've witnessed firsthand the catastrophe that struck our many patients who have lost their alliance. Immigrants are already fearful. In spite of this, on October 22nd, a group of mothers made their way through the council building to share their stories of loss of insurance coverage. They said, "Nuestra sangre está en sus manos," or "Our blood is on your hands." One council member advised them to tone down the rhetoric, pointing to the women one by one and saying, "You're not going to die, you're not going to die, you're not going to die." Several of the women in that DC council walk around have diabetes. Dr. Sugarman already talked about this some today, but I'd like to walk you through what their lives may look like without insurance, as explained to me by one of our medical providers at Bread for the City. Diabetes is not rare. In DC, 8% of the adult population has already been diagnosed with it. Additional 29% of the adult population is pre-diabetic. A patient who loses alliance will immediately lose access to her diabetes medications. Even though clinics like Bread for the City would continue to see the patient for primary care, we're not specialists and we cannot provide free medications. We often refer uninsured patients to Walmart, which offers a formulary of 2 oral medicines for diabetes for $9 a month. This treatment, though, is only adequate for new or mild cases of diabetes. It does not work alone to control blood sugar for people who have had diabetes for a longer time. Without access to injected insulin, patients will grow sicker and sicker. An uninsured diabetic patient would also lose access to regular eye and foot exams by specialists, which are a critical way to monitor for complications. Over time, nerve damage often causes diabetic people to lose sensation in their feet. These patients are also prone to skin infections that, if left untreated, can progress to deep bone infections. Patients may need to have toes or feet amputated. Without monitoring and medication, high sugar also causes damages to people's kidneys and nervous systems, including, as Dr. Sugarman said, nerves that go to their eyes and that can lead to blindness. For immediate emergencies, patients will be admitted to a hospital where care will be provided free of charge. But the goal of the hospital is to keep patients from dying right then in that moment, not to help them with long-term health goals. As diabetic patients go blind and lose toes or feet, they lose the ability to walk and to work. This is a significant quality of life problem, a slow spiral that ultimately leads to a premature death. So yes, though we did not see people dropping dead in the streets on October 1st, and we may not see that happening on October 1st of next year when the eligibility criteria for Alliance falls to 19% of the federal poverty line, taking Alliance away from people will lead to many preventable deaths. To the council member who told our neighbors that they were not going to die, who are you to tell them that, and how do you know?
Thank you. Chioma?
All right. Good morning, Chairperson Henderson and other members of the Committee of Health. My name is Chioma Rue. I'm the Health Justice Project Director at Advocates for Justice and Education. Before my work, I am a daughter, a sister, a mother, and a disability self-advocate. My family immigrated to the U.S. from Nigeria when I was 9 years old. On May 9, 2000, my entire family became U.S. citizens together, a day my father called the happiest of his life. 20 years later to the date, on May 9th, 2020, my father died of COVID-19 after years of struggling to access services as a stroke survivor with dementia and depression. His care was fragmented, often delayed, and heartbreakingly denied. On April 16, 2022, my oldest brother, Izenwa, died from complications of unmanaged mental health needs because despite working his entire life, he was denied full health care and blocked from disability benefits. His death and my father's were preventable. Both of these losses happened during the global pandemic. They were avoidable again with functioning healthcare systems. My question to you and to other members of this council that will hear this, have we not learned anything from that period of time, of that collective trauma? Today, we face a new political pandemic through the One Big Beautiful Bill and drastic policy changes that will devastate access to care. As a neurodivergent mother of 2 neurodivergent sons, I've fought for evaluations, therapies, insurance, care in the home, in the community, in schools, and safety. This fight has cost me employment, housing stability, food security, and my own mental health. Without community support and access to DC Medicaid, my family would not have survived. According to the DC Health Benefit Exchange, which has been submitted to this body, and we are able to see it on the website now, it reports that 1,630 residents lost Medicaid as of November 1st and did not move into the new basic health plan, leaving caregivers of disabled children uninsured and at risk of losing medications, specialists, preventive care, and mental health support. According to DHF's Department of Healthcare Finance's submission to this council, it reports that the Alliance program drops income eligibility from 250% to 138% of the federal poverty level. Bars enrollment, and well, we know what it says. We stand in solidarity with some of the other partners that have made recommendations here to restore this income limit to 250, 15% of the federal poverty level, restore all services before October 1st, remove the age of 26 enrollment cap, create an Alliance Advisory Council. And for DC Medicaid, we ask that you pursue the 1332 waiver so residents losing Medicaid but not eligible for the basic plan can still receive subsidized care. Thank you, and my full testimony submitted. Here for any questions.
Great. Thank you. Thank you to this panel of witnesses for your testimony and for your perspectives, which are all, you guys presented 4 unique stories, although all on the same topic and certainly all on the same theme. I don't have any specific follow-up questions at this particular time, but I do want to just sort of reiterate, we're down on my list in terms of the things in addition I want to talk to the executive about, and one of them is around the advisory council, which I feel like actually could be just very helpful just in general in terms of communication and decision making, so it doesn't seem abrupt. It seems transparent, and that's been helpful in some other regards, as well as some more other specific things as well. As I mentioned at the top, right, this isn't a budget hearing, so I can't make any sort of determinations or decisions on that front. But this is the ability for us to start that conversation as we head into the next budget cycle. So I thank you so much for being here. Please make sure you provide your testimony for the record. Thank you. Okay. Now, I have on my list that there's like one more person to provide in-person testimony. And then we're going to take a nice little 7-minute break, just 7. And then we'll get to the other stuff. I have Sheila Escamilla, who I think had signed up virtual but is here. Okay. Is there somebody else? Speak now. Oh, hey, girl. Come on. All right. Okay, when you're ready.
Good afternoon, Council Member Henderson. Thank you so much for having us here today. And thank you for the space that you have provided for all of us to gather and hear stories from all over the city. I think it's so important. My name is Sheila Escamilla, and I am a Student Services Coordinator and the McKinney-Vento Liaison, supporting our unhoused population at Brea Public Charter School. I have also served as an early childhood educator at Brea for 8 years, and I have met children as young as 4 years old needing dental care, which were paid for by DC Healthcare Alliance, and so thank you for that. DC has always been a mecca for community resource, and I am proud to serve this city alongside all of you. Here is what DC Healthcare Alliance means to many of our young adult students. By the way, BRIA is a 2-gen education program that provides education for adult and young children. And we are working in partnership with Mary Center that provides the healthcare and the social services for our families and everyone in the city. So it is a holistic education. So for our students, I can recall several of our students who were living in transitional housing who are grateful for the opportunity to bring their children for a well visit to the doctor for the very first time at no cost. Thanks to Alliance for that one. I can recall pregnant mothers who did not have other support systems and were able to connect with other organizations while they were at their pregnancy checkups. So you see, DC Healthcare Alliance is not only providing medical care, it also serves as a bridge to the community. They are one of the many families that we supported to apply for healthcare coverage here in DC. I have also met residents who suffered from cancer, some who received regular blood transfusions, or children with severe disability relying on Healthcare Alliance. I know that the Children Alliance is not effective. However, the parents that are caring for them needs to be healthy as well. So I'm mentioning them. Many of the students who utilize the DC Healthcare Alliance insurance would have not been able to afford this healthcare cost. Even at the very most basic price level, they work 2 or 3 jobs every day with very high cost of living. This will make it very impossible for the parents to prioritize health, which is our basic human right to exist in this world. One story I want to share with you today specifically is a student that I have supported who had stage 4 renal disease, which meant he had to have his blood transfusion 3 times a week. This student is also unhoused, meaning he is in constant stress physically as he does not have a home to claim. To the minimum, we had healthcare that allowed him to live a normal life for as long as he had Alliance. He often said, "If I have my health, I will have my life." I am very concerned about the student and how his future would be shaped if there was no healthcare available to those who are vulnerable, such as he. Why must you join us in this journey of protecting human health? Many of the researchers already tells us that health is wealth. Maslow has told us that from a long time ago, and I think we all know and understand this. As a mother to 3 boys, ages 16, 19, and 25, I cannot imagine not having my health, and so this is very important. We urge you to please continue to allow DC Healthcare Alliance for all DC resident, and thank you.
Thank you. All right. You just got to turn your mic on. Just hit the button. There you go.
Okay, John Bob Warner, so good to see you. You are definitely one of my healthcare heroes, childcare heroes. Well, I'm Fariga Mina Tumpe. I'm a native Washingtonian. And today I am a parent ambassador with Advocates for Justice and Education, but I'm also here with my Spaces in Action family. I'm a member of PAVE, Disability Rights DC, and all the organizations that help eradicate the pitfalls that bedevil my family. I'm also a 2-gen caregiver of 3 differently abled grandchildren that I had to raise since birth for the past 16 years because my daughter, Angel, suffers from co-occurring disorder. She has schizophrenia and frequent bouts of psychosis that have been primarily treated with sedations, restraints, and seclusions. My 4-year-old, Daniel, my autistic genius, was born in the freezing rain on the corner of North Capitol and Florida Avenue, head first on the cold, wet, freezing ground because my daughter that has schizophrenia was denied access to APRA. I know this because I took her there myself. Daniel depends on two very expensive medications every morning and night. He feels so proud when he's able to focus and play with his friends and explore our community. But without his meds, it's like watching someone being tortured. And too often we experience going without his medications for prior authorizations or suggesting that we try a more affordable medication, which has never worked and also has caused many side effects. We need a comprehensive and pervasive system of care that prioritizes persons with disabilities because they are our most vulnerable citizens and deserve compassion and first-rate care medically, mentally, socially, and emotionally. I too have come to rely on SSI disability and Medicaid after working for decades. I have had many incidents of being denied authorizations for my life-saving insulin and mental health medications for my diabetes and other autoimmune diseases. For the love of Daniel and everyone who relies on public health, I implore you not to make cuts to health care. Thank you.
Thank you. Thank you for being here and for the vulnerability of sharing the stories of yourself as well as the students that you worked with. Sheila, I thought the part where you said, if I have my health, I will have my life was pretty powerful and important. And I think that's the case for all of us, is why we're here, trying to figure out how do we make this work for as many residents as possible in the face of some pretty difficult headwinds and challenges, not just financially, but just from a policy perspective from the federal government. I don't have any questions for you all in particular, but thank you guys for being here. Yes.
I would like to just mention something about
Okay.
about the communication of the notice for the residents.
Sure.
Because I support our students for their renewal, I think oftentimes the notification is addressed to the head of the household, which is family assume that because when you do the renewal, the head of the household is first. And so when the whole family is renewed, basically when that head of the household is renewed, the whole family is renewed. So I would suggest that in the future, the cutoff should be specifically stating the names of the persons that are being removed and separating the child, and specifically saying Children Healthcare Alliance continues as it was, or something to that effect, to help families, because the language barrier is there and the literacy barrier is existence, and that's where we try to help our families to understand. Thank you.
No, that's very helpful. Thank you for raising that, because we raised that earlier around like what does the notice look like and what are some ways to improve and make that better. So we'll certainly raise that with the executive. So thank you for being here. Okay, for the people who are watching at home, we're taking a 7-minute break. We're going to come back. We've got some virtual witnesses, and then we'll get to the government after that. So thank you. All right, so we are back. It was a little more than 7 minutes, back a few seconds, but nonetheless, we try to stick to it. All right, so we're going to our virtual public witnesses. If you haven't done a virtual hearing with us before, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up to the screen that says, would you like to be elevated to be a panelist? And you gotta affirmatively accept that in order to speak. We're gonna do panels of 7, kind of see where this takes us, and then we'll go from there. So Andrew Patterson from Legal Aid DC, Bianca Palomino. I added too many syllables there. Apologies, Bianca. C. Nickel from First Shift Justice Project, Catalina Alvarado, Cynthia Spencer, Dora Cura, and Gustavo Javier Anguelo Olivero. Just a note as well, we cannot promote you if the name on your Zoom is iPhone A or Joey's whatever. If Joey, go by the legal name for which you signed up on. That's what we're gonna see. So check your display. Okay, there are only 4 from the group that I called, but the other folks might hop on. So we'll just go with what we got. All right, and at the top, I see Andrew. So Andrew, when you're ready.
Thank you, Chairperson Henderson. My name is Andrew Patterson. I'm a senior counsel with Legal Aid DC. Thank you for the opportunity to testify today at this roundtable. Today, I want to make several points about the changes to Medicaid and creation of the Healthy DC insurance program. First, Legal Aid urges the exchange and the council to include dental and vision benefits as part of the Healthy DC benefits package. Healthy DC currently only provides coverage for the essential health benefits required by the federal exchange. So the population that will move from Medicaid to Healthy DC will lose all access to dental coverage except for medical emergencies. This means people will put off care until it becomes a true emergency, leading to poorer health outcomes and more expensive care down the road, as others have testified in more detail today. The current estimate for providing dental coverage is $5.1 million, which is a very small fraction of the district's $20 billion plus budget, and eliminating dental coverage for this population is a significant step back from the district's longstanding commitment to providing comprehensive health insurance to all of our residents, regardless of income. Legal Aid also strongly urges the council and the exchange to maintain a continuous enrollment policy for the duration of the Healthy DC program, and not just for the first year as is currently planned. As written, the blueprint for Healthy DC will switch to the exchange policy of open and special enrollment periods after 2026. This is important because those federal exchange rules will require Healthy DC enrollees to report any change of circumstance, including income, within 30 days, and dictate that such reports may trigger a redetermination of eligibility. So an hourly wage worker with Healthy DC coverage whose income happens to go above 200% of the federal poverty level for a month or two would be required to report that change and will likely be terminated from Healthy DC coverage. Under a continuous enrollment policy, that person could reapply for and regain access to coverage if their income goes below 200% of FPL again. But under the federal exchange rules for open and special enrollments, that person would likely have to wait until the next open enrollment period to reapply for Healthy DC. The federal exchange regulations do not trigger a special enrollment period for a reduction of income alone. Although the regulations do have some flexibility around optional special enrollment periods, some of which include a reduction of income among other factors, the Healthy DC blueprint does not appear to include any special enrollment periods beyond those required by the federal rules. The Healthy DC population will have an income between 138 and 200% of the federal poverty level, and we anticipate this will include many hourly wage workers whose income may fluctuate from month to month, depending on the number of hours and shifts they are able to work. Maintaining a continuous enrollment policy after the first year would ensure that those folks who qualify for Healthy DC can obtain timely access to coverage when they qualify and avoid the delays, the hassle, and the bureaucratic confusion of waiting for open enrollment or hoping to qualify for a special enrollment period. I know I'm out of time. I just want to briefly mention that we also strongly support a 1332 waiver to increase the income limit for Healthy DC to, at the very least, match the current income limits for Medicaid. There are about 1,600 people who are going to lose all coverage and will probably not be able to afford exchange coverage at this time. But I will submit the rest of my testimony for the record. Thank you.
Thanks, Andrew. Bianca?
Hello, Chairperson Henderson. Thank you very much for the opportunity to testify about the cuts to DC Healthcare Alliance and Medicaid. My name is Bianca Palmisano. I'm a Ward 1 resident and a nurse who's served thousands of patients who receive coverage through DC Medicaid and Alliance. The cuts to DC Healthcare Alliance was one of the most distressing elements of this year's budget season. I am truly scared for my patients and for the future of healthcare in this city. I started my career as a nurse at Mary Center, where I had the honor of caring for many immigrant families who receive coverage through Alliance. About 60% of my patients did not speak English. Mary Center registered them for coverage, made their first primary care appointments in the city, scheduled their specialist appointments, arranged their prenatal ultrasounds, vaccinated their kids, connected them to mental health support, and ensured that their prescriptions were organized. 2,800 of those patients now have no way to pay for these services, and that number will grow year on year as Alliance is further rolled back. This, for me, is devastating news. At a time when childhood vaccine rates are falling across the country, cutting Alliance makes it harder for families to access preventative care. In a country with the highest rate of maternal mortality in the developed world, cutting Alliance will cause more childbearing patients to forgo prenatal care and seek emergency care for delivery, which, as studies show, means those individuals will suffer higher rates of preventable complications and death. Let me be incredibly blunt. Our city's healthcare system cannot absorb more emergencies. The average wait time at MedStar Washington Hospital Center's ER is over 6.5 hours, nearly 3 times the national average. When I worked out of this ER, I saw the staff pressed to the breaking point by their workload. Patients had to be kept on gurneys in the hallway while nurses attempted to manage multiple critically ill patients waiting for ICU beds. Each of these patients should have been receiving the safe ICU patient-nurse ratio of 1:1, but that's completely impossible with the number of unstable patients waiting to be seen. The software system which tracks ER patient load was constantly blinking bright red, a warning that the facility was dangerously above capacity. Cutting healthcare coverage through Alliance means more reliance on emergency rooms, which are already teetering on the edge of collapse. Cutting Alliance is not the cost-saving measure you believe it to be. Emergency care for a heart attack without surgical intervention is estimated to be about $21,500, but it could have been prevented with meds costing pennies to Alliance. It costs approximately $56,000 to replace a hospital RN when they leave the field due to burnout from caring for an overflow of emergent patients who couldn't afford preventative care. Loss of Alliance coverage will send shockwaves through our healthcare system that are impossible to absorb. I implore you to reverse the funding cuts, return the income limit to 215% of the federal poverty level, remove the age cap for adults over 26, and restore the full slate of services covered by Alliance prior to October 1st, 2025. Thank you so much for your time.
Thank you. C. Nickel? CWC.
Sorry,
there we go. Okay, great.
Great. So Councilmember Henderson, thank you so much for the opportunity to testify today. My name is C. Nickel, and I'm the Community Health Outreach Manager of First Shift Justice Project, an organization that assists DC workers in asserting their health-related workplace rights like job-protected leave and DC paid family leave. I'm here today to urge the council to restore the DC Healthcare Alliance and to take action to support DC Medicaid. Without access to healthcare, people will get sicker and stay sicker, and they may also lose their jobs. Lack of access to medical providers prevents workers from exercising their rights at work, which could lead to health complications as well as job loss because their health is not protected at work. In order to access their rights, like job protected leave, workplace accommodations, and DC paid family leave, workers are required to provide documentation from a medical provider, or else they could be fired or may have to take leave without pay. Once they lose their job or have their income cut, they might again become eligible, but it will be too late to prevent impacts to their health, such as loss of housing, impacts on nutrition, and long-term complications from their condition being left untreated. This perpetuates the cycle of poverty and poor health. I know the importance of Medicaid and Alliance benefits, not only from a professional standpoint, but also from personal experience. When I first moved to DC, I relied on DC government subsidized health insurance to seek care. And one of the ways I used those benefits was to seek dental care, which is an important benefit for folks. In addition to the actual benefit of having access to care, having health insurance contributed to a sense of security. What I remember most about the first few weeks of my move was a sense of fear while I waited for my application approval. Without benefits, if I got sick, if I got hurt or got into an accident, I would have to decide between seeking care, paying rent, or going into debt. By cutting health insurance programs, we're increasing fear at a time where many communities' sense of security has already been damaged by political and policy decisions. Alliance and Medicaid tangibly demonstrate how DC cares for our community, especially the most vulnerable members. Providing options for residents who traditionally fall through the gaps despite their contributions to the community is part of what makes DC a great place to live and work. To protect the health, dignity, and livelihood of DC residents, I urge the council to take steps outlined in my written testimony to protect both Alliance and Medicaid. Restoring income limits and services will ensure that fewer people will fall through the cracks and will protect people's health, their jobs, and their futures. In the words of Francisca, a resident of Ward 1, quote, "The Alliance program has been and continues to be a great opportunity for me and my family to stay healthy. As an immigrant community, medical coverage is very necessary because of all the diseases that exist today, or even just for my annual checkup and those of my loved ones. I ask that you have compassion for the entire community because we are all human beings. Thank you very much. Thank you for your time and for all that you do to advocate for continued commitment to improving health in the district."
Thank you. Catalina?
Yes. Good afternoon, Chairperson Henderson and member of the committee. Thank you for the opportunity to testify. My name is Carolina Quinteros Alvarado. I am a student at Brea Public Charter School, DC resident, and a mother of 2 children, one with special education needs, and an advocate for many families in the community who rely on Medicaid and the Alliance for their essential health care. I am deeply concerned that recent and upcoming changes to these programs will increase barriers to care for thousands of residents. The recent shift in the Alliance program has already created significant confusion surrounding coverage services, increasing wait times, and widespread fears among families who worry about losing their doctors or not understanding the new rules. Vulnerable families cannot afford interruptions in coverage or systems that are difficult to navigate. The upcoming Medicaid eligibility reduction from 210 federal poverty level to 135 federal poverty level in January will force many working families out of the coverage they depend on. Transitioning to the new plan will lead to disruption treatments, higher costs, and the loss of trust providers for families with children with chronic conditions or mental health needs. This disruption can be dangerous. I am respectfully urging the council to pause or consider the Medicaid eligibility reduction, strengthen communication, and ensure clear language, accessible guidance for both programs, protects community of care so families do not lose access to the doctors or essential treatment. These policy changes will impact real people, parents, children, seniors, and immigrant families who are doing everything they can to stay healthy and stable. We need a system that supports them. No assistance that increases fear and hardship. Just remember, we cannot build a healthy city by pushing our vulnerable families out of care. Thank you for your time and leadership.
Thank you. I don't see Cynthia, but I do see Dora.
Thank you, Chair Henderson.
I am a resident of Ward 3 and a lay faith leader. I have co-chaired the Washington National Cathedral Sanctuary Ministry for nearly 5 years. We strive to live up to our baptismal vows, to love our neighbors as ourselves, and to respect the dignity of every human being. The current attacks on our most vulnerable neighbors and their families poses a momentous challenge. As part of the Episcopal Diocese of Washington and in partnership with other faith communities, we support our neighbors with food and other basic necessities, as well as assistance in family preparedness planning. On this occasion, we advocate for their access to health services. The DC Alliance has been critical for the health and well-being of the families we have supported. The Alliance provided care for the birth and subsequent growth of healthy babies, and the family coverage has given parents the level of health and well-being to take advantage of work opportunities to sustain their families and contribute to our communities. We've been inspired by their perseverance, resilience, and faith in the face of tremendous obstacles. We've seen the historic and familiar pattern repeat itself, with hardworking newcomers representing a younger demographic than the resident population, fueling our local economy in a myriad of ways, including as caregivers and construction workers. This is a case where spiritual values coincide with cost-effective use of tax resources. The argument that DC Alliance cuts are needed for the sake of savings seems to undervalue the real human and social impacts of these service cuts on our neighbors. Some of these impacts have been so eloquently presented in testimony here today. We join others in calling for the Council to fully fund the Healthcare Alliance. We support the recommendations provided by others to restore the 215% of the federal poverty income limit, the coverage of services offered prior to October 1st of this year, and the coverage of those 26 years and above. And second, to establish an Alliance Advisory Council to increase transparency and accountability. I want to thank you very much, Councilmember Henderson, for your leadership and providing this opportunity for us to testify. Thank you.
Thank you. I don't see Gustavo. But we are joined in person by Sharad, who is a resident and so just got here. But when you're ready, you hit your button on your microphone. Here you go.
Is it on?
It's
Hi.
on.
Hi, my name is Sharad Wertheimer. I'm a medical student actually at GW. I just wanted to share a couple quick stories about why I think it's so important to restore the funding for DC Healthcare Alliance. Before I was a medical student here in GW, I worked as an EMT up in Rhode Island for several years. And there were so many times that I saw people become seriously ill or die because they didn't have access to health insurance. And those same people would be alive if they were here in DC because they have coverage by programs such as Alliance. So a couple examples. There was a patient that we transported to the hospital to get open heart surgery because they had a dental infection, which could have been easily treated with antibiotics if they actually had coverage, that spread to their heart and infected the walls of the inside of their heart, causing them to go into heart failure. And that guy was 32 years old. There's a 50-year-old man who was left paralyzed on one side of his body and barely able to talk because he suffered a stroke, which could have been easily prevented with antihypertensive and cholesterol-lowering medications if he had actually had any health insurance to be able to go see a doctor. There was a young man, maybe 22 years old, from Guatemala who we had to take into the psych ward because he was suffering from schizophrenia, which could very easily have been treated if he actually had prescription coverage and the ability to see a psychiatrist. But instead, he was paralyzed with horrifying terrors that demons were chasing him and trying to kill him. And he had spent 3 weeks in the emergency department, taking up a bed and screaming at everyone because he couldn't get a very basic drug that he needed. One one last one, there was a 35-year-old mother of 3 who I took to hospice because she was dying of brain cancer that could have been treated if she had actually access to the surgeries needed to intervene early. She was able to, they had found it early, but because she had no insurance and no way to pay for it, she had to just wait over a period of a year where she started having seizures, lost the ability to walk, and then slowly lost the ability to talk to her 2-year-old child because of the growing tumor. So these are all people that I will see in the next 2 years, potentially, when I go into my clinical rotations as a medical student. We have the ability to stop this. We have the ability to prevent these kinds of deaths and horrible illnesses from occurring. So I ask you all to take seriously our oath to do no harm that I will have to take in 2 years, and restore funding for this incredibly important health coverage program.
Thank you. Thank you to this panel of witnesses. Thank you for making the time to be here and present your testimony on all of these various issues. I do have a couple of questions. Come on back. I'll first start with Mr. Patterson, if you're still there.
Yes, I am.
Okay. I think you were probably the first one to talk about today in a sort of more extensive testimony around continuous enrollment coverage beyond a year. I don't know if you wanted to say more about that. Because I feel like for most folks, they would say, okay, having continuous enrollment coverage for the first year that we do this program would be super important, right? To do it for 2026, which is planned. But you're making an argument to continue beyond that. Say more.
Yes. So I think the population that is shifting from Medicaid to Healthy DC, they've always had access to continuous enrollment. And so they've always been able to, if their circumstances change and they find themselves eligible for Medicaid, not bound to a open enrollment period, they can go and they can get that coverage. And I think that will be key for the first year of Healthy DC to let, as there may be some administrative hurdles or confusion, but I think those administrative hurdles and confusion don't go away after the first year. And in particular, an open and special enrollment period is going to be, just a new sort of scenario for this population to navigate. I'm concerned too about we at Legal Aid are concerned about the federal exchange rules and how they define special enrollment periods and how they define reporting requirements. In my testimony, I mentioned that if someone's income goes above 200%, which is the income limit for Healthy DC, under the rules as I read them, and I'm getting up to speed myself on all of the federal exchange regulations, but I've gone through them, and as I read them, they're required to report that change. That will trigger a redetermination, and that person could then lose their coverage. If their income then goes down, those rules do not dictate that a special enrollment period is triggered just for a reduction in income. So they may be waiting until open enrollment to get their health coverage back. And I think that dynamic creates a situation in which a lot of people may lose their Healthy DC coverage, but not be able to get it back immediately when they qualify again. That would not be a problem with a continuous enrollment policy. Under continuous enrollment, they would be able to re-enroll if their income goes down. But I think we don't want to create a situation, and I don't think the council or the exchange want to see a situation in which people would have to lose their income because they honestly report a change. Lose their health insurance because they honestly report a change in their income, and then aren't able to get it back. And I will just point out too, the Healthy DC, of course, is a basic health plan under the Affordable Care Act. There's only a few other states that have those. I'm aware of New York and Oregon and Minnesota. All 3 of those blueprints do have continuous enrollment, not an open and special enrollment period. So this would be the first time that I'm aware of a jurisdiction creating a basic health plan and requiring an open and special enrollment period after the first year.
Okay, thank you. That's helpful, and we'll certainly ask about that. Mr. Whitmither and well, Mr. Patterson also talked a little bit about this too, right? The importance of the dental, vision, and the full comprehensive sort of look at care and coverage. Now, I apologize for calling you the physician outright when you're still in medical school, but that's okay. You're in training. You're a physician in training, and I appreciate you being here and being part of that conversation. I wonder if you want to talk a little bit about, well, I'm going to ask that question, but I kind of already sort of know the answer to it. It doesn't really work. In terms of when people are uninsured and they're seeking various procedures, et cetera, right? There is the clinic model, but that doesn't address some of the things that you talked about in terms of surgeries, pharmacy, and other matters. I don't know if you want to expound on that more.
Yeah, sure. So when I was up in Rhode Island, I worked both as an EMT, but then I also was volunteering as an interpreter at the Rhode Island Free Clinic. And so that clinic was one of the few options that was available to people who weren't insured otherwise. And I think that, it's comparable to what many other states have that, available for people who aren't covered. The free clinic, had been able to negotiate some very basic medications from different pharmacies, like Overstock and other things like that. And they were able to, create, some kind of charity care options through building relationships with local hospitals. But it was so challenging to actually connect people to any services beyond the most basic primary care services. That it was effectively impossible for most people to actually really get the specialty care that they needed.
Got it.
So we would be able to, do an assessment and say, okay, you really probably need surgery for this, and you're probably going to be on a waiting list for 3 years to get it. And by that time, your liver will probably be failing and it'll be too late. And that was the situation for most of these patients. And that's why it's so critical here that we do, still provide that comprehensive coverage beyond just primary care. Of course, primary care is so important because it, you're able to catch things early.
Yeah.
But then if people aren't getting that higher level of care, then you're still getting people who are very ill and who are costing our healthcare system way more money and resources because, that person who could have just had to take an amoxicillin for that dental infection now needs hundreds of thousands of dollars open heart surgery, Yeah.
Okay. All right. Well, thank you so much for being here. Thank you to the panel of witnesses for your testimony. If you didn't provide your written testimony for the record, please make sure you upload it for us. We're going to go to the next panel. We'll kind of see where we go. There might be about 2 more panels here. So that's actually, you're good. That's a telegraph to Director Turnage. I think you're the only one who's not here. So I hope you're in this building, is my hope, that you're not coming from anywhere but downstairs. All right. Jabron Eubanks from 1199 SEIU. Kate Coventry, although I saw her in the hall, but Kate, if you're in the hall and you just want to come inside, that's an option as well. Kate Denson from Capitol Hill United Methodist. Kurt Gallagher from DC Dental Society. Mark Lavota from DC Behavioral Health Association. And Nick Lewinoff. Okay, all right, I see Jabron. When you're ready.
Yes, good afternoon, Chairperson Henderson. Thank you for the opportunity to testify today. Yes, my name is Jabron Eubanks. I'm the political organizer with 1199 SCIU, United Healthcare Workers East. We represent 400,000 workers across the healthcare continuum up and down the East Coast with thousands of healthcare workers in hospitals, clinics, skilled nursing facilities within the District of Columbia. And I'm here today testifying on behalf of 1199 and our members to discuss the impact of changes to Medicaid and DC Healthcare Alliance. As we are all aware, these are critical times for working families. While the federal government imposes massive cuts to Medicaid, we need our local government to identify ways to balance these changes when and where they can. Over 40,000 DC residents are estimated to lose their health coverage, along with an estimated 2,000 jobs lost. I want to talk a little bit about the impact that these changes will have on workers. Hospitals in DC are severely understaffed. As the amount of uninsured DC residents increases due to loss of health coverage from eligibility changes to Medicaid and phasing out DC Healthcare Alliance, more residents will be forced to visit hospitals for services. This will cause a strain in the emergency department, triggering long ER wait times and harmful delays in care. DC already has one of the longest ER wait times in the country, and a contributing factor to this is short staffing, which will worsen with the estimated job loss. We're going to see an influx of people visiting the emergency department where they could have just gone to their primary physician if they had health insurance. We need to be practicing prevention by providing quality insurance to residents so that they avoid these hospital visits. We represent workers at Whitman Walker who are tasked with identifying affordable health coverage for patients, and many times these patients are referred to DC Healthcare Alliance. Since many residents are barely ineligible for Medicaid, they are dependent on Alliance. They tell us that the impact of eliminating this program will be extremely detrimental to our community. Therefore, we're asking the council to fully restore, fund, and even expand DC Healthcare Alliance. Return the income limit to 215% of the federal poverty level, remove the age cap for adults 26 and over, and ensure that dental and vision services are provided through the basic health plan. As basic costs of living increase, people simply cannot afford to add any additional financial burdens to their lives. Thank you for your consideration.
Thank you. Kate?
Thank you,
Oh,
Councilmember.
sorry, Kate Coventry. Sorry, there are two Kates.
That's okay. Sorry about that. Thank you so much for the opportunity to testify today, Chairman Henderson and members of the committee. My name is Kate Coventry, and I'm the Deputy Director of the Legislative Strategy at the DC Fiscal Policy Institute. DCFPI is a nonprofit that shapes racially just tax, budget, and policy decisions by centering Black and Brown communities in our research and analysis, partnerships, and advocacy efforts. My testimony today focuses on the Healthcare Alliance and the Healthy DC Plan. My time is brief, so my written testimony will go into more detail, but DCFPI wants to applaud the Health Benefit Exchange for the thoughtful and swift design and establishment of the new Healthy DC Plan, which will provide free or low-cost healthcare coverage to a large portion of adults losing Medicaid due to the FY26 budget cuts. But unfortunately, we have more than 2,000 residents who have lost Alliance coverage and have fewer inadequate options because lawmakers reduced the income threshold from Alliance from 210% to 130% of the federal poverty line. Newly ineligible neighbors will struggle to pay for health care, may avoid or delay needed care, and even die from diseases that could have been successfully treated if the individual received timely care. And this program change comes as the federal government escalates deportations and targets immigrants for other benefit cuts. Congress has recently excluded more lawfully present immigrants from Medicaid, and federal agents are rounding up immigrants, including those with legal statuses. Alliance changes will primarily hurt DC's Hispanic and Black residents, including immigrants who are living in the United States legally, as well as those who are undocumented. In FY 2020, 50% of Alliance recipients were Hispanic and 20% were Black, with just over 2% were white. We're asking the council to do three things. One, to create a task force to identify savings and delay further cuts. The Deputy Mayor of Health and Human Services has argued that Alliance costs are increasing too fast, but hasn't been able to fully explain the various factors that are driving up costs. We should reach out to stakeholders for ideas how to contain costs rather than just eliminating the program altogether. So we suggest the council form a task force of experts, including current alliance recipients, to identify potential areas for savings. Particularly federally qualified health clinics sometimes receive medications at a discount. An inhaler that costs more than $500 at a retail pharmacy is less than $30 at a FQHC. We could maybe get more patients to fill their prescriptions at FQHCs, driving down costs there. We also urge the council to urge the chief financial officer to certify revenue growth so benefit cuts can be reversed. The CFO is supposed to certify if there's enough revenue to expand the Alliance benefit package back to where it was in FY 2025. We should urge the CFO to act quickly so benefits can be restored as quickly as possible. And then lastly, we ask the council to work to reverse harmful cuts in behavioral health services. Alliance patients used to have coverage for severe mental health issues through the Department of Behavioral Health. Even though that wasn't part of the insurance coverage, DBH cut the services for those who exceed the income eligibility. Thank you so much for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Kate Denson.
Hi, good afternoon. Thank you, Councilman Henderson, for having this hearing and allowing so many stakeholders to speak into the process. My name is Kate Denson. I'm coming on behalf of myself and many of my and underinsured friends here in the district. I'm a licensed minister in the district and a committed volunteer and host for the daily free breakfast program at Capitol Hill United Methodist Church in Ward 6. We help provide breakfast and fellowship 7 days a week to unhoused and food insecure Capitol Hill neighbors. Our breakfast program hosts a nurse practitioner from Unity Health Care Clinic twice a month. I'm a Ward 6 resident and have lived in DC for almost 20 years. I'm here because I'm concerned about the severe cuts to Healthcare Alliance that have already taken place and the coming cuts that will take effect in the next couple of years. Many of our breakfast friends rely on district health programs such as Healthcare Alliance for their health needs. Some are completely unable to work and others earn a very small income. I am most concerned about the dramatic narrowing of who can use the program, as well as the complete erasure of dental and vision benefits for the small amount of people who will be allowed to stay. These changes will result in many people falling through the gaps in our healthcare system and becoming even more or underinsured. Many of our breakfast friends lack regular access to hygiene products and clean facilities. As such, their teeth are in very poor condition. Regularly, I'm asked to bring ibuprofen or something to help with tooth pain or obvious tooth decay. Others struggle with vision needs. Most of our friends are older adults who benefit from eyeglasses and need regular eye exams to maintain their overall health. These district residents matter. Even if they don't generate much income, and even if the president sees many of them as an eyesore or a danger he'd rather see disappear. Many have lived in the district their entire lives. They are parents, grandparents, veterans, and good neighbors to others they see struggling even more than themselves. The good news is that the cuts made in the Alliance can be fixed. The Council should legislatively restore the Alliance in 3 basic ways. The income limit should be returned to 215% of the federal poverty level. Second, the services covered by Alliance before October 1st should be restored. And third, I'd like to see us remove the age cap for adults 26 and over. The total cost of these 3 changes would have been $43 million this fiscal year, and they will cost more in fiscal year 2027, but they should be adopted. I served as a hospital chaplain at Washington Hospital Center during the height of COVID. Hospital chaplains attend every arrival at the Trauma 1 unit and also spend ample time in the ER. Places like Hospital Center will become primary care every time we make cuts like this. Finally, I urge you to change your posture towards the district vulnerable residents. The Healthcare Alliance cuts were made in anticipation of significant federal cuts. Anticipation, not mandated. This administration is cool towards those that my holy scriptures call great and blessed. Please don't mimic their actions. Stand strong for the people of our city, fight back, and remember the value of every life. Thank you.
Thank you. Kurt?
Good afternoon, Chair Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Kurt Gallagher. I'm Executive Director of the DC Dental Society, and I'm here to keep oral health top of mind. I heard the comments from several witnesses, and I'm warmed by their comments and how they've elevated the oral health connection to overall health. It's something that's really important. I also want to set the record straight, though, because I also heard some comments from some of those witnesses that were a little bit inaccurate. So we expect come January that there'll be a significant uptick in patients going to emergency rooms and other emergency care clinics to seek help for dental emergencies, abscesses, other health infections. And I heard comments from several witnesses suggesting that all they need is antibiotics. Well, I conferred again with our member dentist just in response to those comments. I just want to set the record straight. In cases where antibiotics may be helpful, which is essentially all an emergency room can provide, they can provide antibiotics and a referral to a dentist, the antibiotics likely are not enough to resolve the situation. And in fact, IV antibiotics may be needed. An abscess may need to be lanced, which would be likely by a dentist. But ultimately, after the infection resolves, the tooth is probably going to need to be removed, or a root canal would need to be performed. So even after the infection resolves, to prevent it from reoccurring, they would still need to see a dentist to have dental surgery performed. I'm speaking on behalf of those 25,000 DC residents who are likely to lose their Medicaid coverage, or and will be part of the Healthy DC plan, but will have no oral health coverage come next year. I know that the council made some very difficult decisions in terms of funding and what would be included in Healthy DC. We in the community, the DC Dental Society, we're trying to figure out what we can do. We're in discussions with FQHCs and other community clinics, but really this is a scope that I don't think we can handle ourselves. It's going to create a huge challenge if there's thousands of patients who have no ability to provide payment for their care to meet their dental needs and prevent these types of emergencies. And we've also heard from witnesses that these dental emergencies can result in tragedies, including loss of life. So it's those tragedies that I'm here to try to help make sure we keep in mind, that we avoid, we provide appropriate care. And one of the programs that we're exploring, and we're trying to figure out how we can make this work, Mary Center has a program that diverts dental emergencies into their clinics to receive care. They had a pilot program running that just expired at the end of November. In 11 months, they treated 750 patients. Now, that was a mix of patients from both DC and Maryland, but that's when, in theory, everyone had dental coverage. We know come January, 25,000 adult patients won't have any dental coverage at all. So that challenge is probably a small, would be magnified by several factors come next year. And again, these are volumes that I don't see how the community can take care of without the support of the DC government, DC Health, whether it's expanding the Healthy DC program to include dental coverage, providing grants to provide coverage for those who come in with dental emergencies, but also providing long-term care to make sure that those oral health issues that can resolve into chronic and systemic conditions, whether it's heart disease, diabetes, dementia, that those illnesses are prevented as well. So thank you for hearing me, and happy to answer any questions you may have.
Thank you. All right, Mark.
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole-person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents our 35-member organizations serve annually. In my testimony today, I'll focus on a serious gap created by upcoming Medicaid changes and effects outside the Alliance and Medicaid programs in response to those programs changing. I also want to acknowledge the importance of the new Healthy DC Basic Health Plan, but express concern about coverage limitations and the long-term fiscal viability of the structure. Due to Medicaid eligibility changes, 26 individuals enrolled in assertive community treatment will not have coverage for those services on January the 1st. ACT, the district's highest level of community-based behavioral health care, is designed to prevent people with serious mental illness from requiring indefinite hospitalization. Less than a month out, the Department of Healthcare Finance has not informed ACT providers who those 26 individuals are, and the Department of Behavioral Health has stated repeatedly that no local funds were allocated to continue to pay for ACT services for those individuals once their Medicaid coverage ends. The council should ask DBH to reconsider making local dollars available to meet this coverage gap. through formal reprogramming if necessary. The district government also needs to consider costs being shifted but not being eliminated. People without insurance place greater demands on other services, including first responders, programs offering income, food, and housing supports, other services for people who are disabled, and resources from the criminal legal system. The district's entire healthcare provider network also faces significant lost revenues. Other district agencies, again, like the Department of Behavioral Health, are curtailing local dollar services by tying eligibility for those services to Medicaid and Alliance eligibility standards. Costs that are shifted may become hidden, but that does not mean any less that they are real and substantial costs. The new Healthy DC Basic Health Plan is a substantial but only partial solution to the Medicaid cuts. The plan does not offer coverage for vision, dental, or intensive community-based behavioral health services. So far, no risk corridors or reinsurance are in place, and carrier reimbursements may be unsustainable, all risking long-term viability for the entire Healthy DC plan. While the intense fiscal pressure from the DC Medicaid and Alliance programs had to be addressed, we now have early indications of which corrective measures have already gone too far and are scheduled to go too far. The long-term sustainability of the district's overall budget and of the healthcare provider network must outweigh evaluation of DC Medicaid and the Alliance as standalone programs. Thank you for the opportunity to testify today. I look forward to answering any questions you might have.
Thank you, Mark. Nick?
Good morning. My name is Nick Lukianov. I'm a caregiver for a young lady in DC who spent several years living as a hospital inpatient, but now receives home care because it is far cheaper. Home care is far more cost-effective than inpatient care, and yet, in the name of savings, it has been cut from Alliance programs. I'm a data scientist by profession. This means that I look for evidence-based solutions and fact-based answers. To me, cutting home care is neither of these things and adds to costs instead of subtracting from them. This is like cutting off your nose to spite your face. The young lady in question was brought to the US by the military for life-saving surgery. This surgery resulted in her being unable to eat by mouth, only via an intravenous tube implanted in her chest. A special nutritional mix is required for this, and she administers it herself, saving on costs. Home care was created for this very purpose, to avoid paying high hospital prices and free up hospital space. Home care can lead to cost savings through lower direct costs compared to institutional care, and reducing indirect costs like transportation and hospital readmissions. These are not small costs, and home care should be the first program that any cost-saving measure should implement instead of eliminate. On a personal note, I'm at the hospital right now with the lady in question. The hospital is charging more per day of her stay than it costs for an entire week of home care. The nurse here told us that there are 3 other people in the same situation, just on this floor alone. This hospital has 7 floors. I'm asking Chairman Mendelson and all the DC Council members to restore full funding to the home care program and protect patients who will otherwise either go without life-saving care or end up in the emergency room. I would also like to thank you, the chair of the Health Committee, Christina, for holding this hearing. It's my hope that this testimony will return funding for home care, one of the most cost-effective treatment plans, to the list of approved Alliance billing codes. Thank you.
Thank you. And thank you to this panel of witnesses for your testimony and for the information that you all have provided. Kurt, I was wondering if you might want to speak a little bit about what some of your members are already seeing in terms of patient volume or not. So I'll give you the opportunity.
Thank you. I actually have anecdotal information. Talking with some of our members who work at FQHCs, they're seeing the volumes going down, as we heard from the representative from Mary Center earlier. I think we can all suppose what that cause is, which is alarming because we're then likely to see a flood of dental emergencies and other oral health conditions down the road as people postpone care.
Okay. Mark Lavoda, there was conversation earlier about can there be a system by which DBH and behavioral health have a different set of eligibility rules or guidelines in order to make sure the maximum number of people are able to maintain coverage for truly life-saving care, substance use disorder, et cetera. What are your thoughts on that?
Well, by rule, DBH has historically had different income and eligibility thresholds and requirements, and DBH also enforces clinical criteria for evaluation of whether or not services are medically necessary. So there are two mechanisms to think about, both the income eligibility conditions as well as the acuity of need. I think the assertive community treatment example that I provided in my testimony is an excellent example of the kind of thinking that DBH is going to have to do about extremely vulnerable people that might not meet those income guidelines anymore, but the alternatives are far worse. So I really want to encourage DBH to be thinking a little more broadly about when coverage gaps are extremely important for them to address. We may not be able to offer as comprehensive of coverage as we historically have, but I think there are some levels of acuity that particularly need attention, and those shouldn't just be determined by people's income.
Okay. All right. Well, thank you so much to this panel of witnesses. I don't have any further questions. I appreciate you being here. And if you can, please upload your testimony for the record. That would be super helpful. All right. We're at our final panel.
Thank you.
Hallelujah. All right. O'Donna Daniels, Reverend Karen Curry, Ruth Pollard, Swapana Urley Ricks, Tangela Hicks, Veronica Cervantes, and there's one person who we called very early on, Jamie Madaji, who has arrived. So, Jamie, if you want to come up to the table, it's okay. You're the last one. You made it. It's all good. It's fine. All right. Anybody else? Going once, going twice, because everybody after this, I'm swearing them in, and they are government witnesses. Okay. Hold on. I'm not seeing everybody on my panel here online. Again, you have to affirmatively accept our invitation to become a panelist. And so if you're in the waiting room, we've sent you a invitation. All right. I don't see Miss Daniels. I do see Reverend Curry. Reverend Curry, if you're speaking, you're on mute.
Yes, I am here. I'm not sure what's happening with my camera though, but I'm here.
Okay. Well, when you're ready, or if you want to work on the camera, I can go to someone else and then come back to you.
Okay, yeah, give me just a moment.
Okay. All right. Ruth? Great.
I'm here.
All right. When you're ready.
Thank you. Good afternoon, Chairperson Henderson and members of the Committee on Health. I'm Ruth Pollard, President and CEO of the DC Primary Care Association. Thank you for the opportunity to discuss the impact of changes to the district's Medicaid and Alliance programs on community health centers. DCPCA estimates our member health centers serve about 16,000 adult Alliance patients and 63,000 adult Medicaid patients in fiscal year 25. Based on DHCF reports, roughly 1,400 health center patients may lose Alliance coverage this year due to income eligibility changes, and up to 7,000 health center patients may move from Medicaid to Healthy DC by January 2026. DHCF reports that Alliance enrollment overall has dropped by 25%, and we know that Healthy DC does not include dental and vision coverage. DCPCA is certainly grateful for our collaboration with the DC Health Benefits Exchange to stand up the new basic health plan, Healthy DC. Our partnership ensured that eligible residents have access to all of the district's federally qualified health centers, maintaining continuity of care for those patients. We also appreciate the efforts of the Department of Healthcare Finance to be responsive to needs of community members losing coverage as we seek a path forward to secure access to care. We will track changes in coverage, utilization, and revenue, but the full impact will emerge in fiscal year 27. What we do now know is that coverage loss and benefit changes are disruptive, especially for patients with chronic conditions. Health centers also face administrative burden, helping patients navigate these transitions. DCPCA has begun review of cost data for Alliance patients seen at health centers from September 2024 to September 2025. We are working with DHCF to understand the true cost of the Alliance program and opportunities for cost containment. Our goal is to identify the extent that community health centers can provide more robust preventive and primary care services that better meet patients' needs while also containing costs. Beginning January 2027, about 31,000 health center patients may need to meet Medicaid work and education requirements or prove exemptions to keep coverage. National estimates suggest 36% of all Medicaid adults could lose coverage under automated verification, translating to 22,000 health center patients and 32 million in lost revenue. The cascade of local and federal cuts threaten the sustainability of community health centers. Our message is clear: protect Medicaid, protect access to care for all DC residents, defend sustainability of community health centers. We ask policymakers to work with us so health centers and the patients they serve can thrive. Thank you.
Thank you. Reverend Curry?
Yes, and again, please excuse my video challenges today. Okay, good afternoon, Councilmember Christina Henderson and members of the DC Council Committee on Health. Thank you for this opportunity to address the council today. I'm Reverend Karen Curry, a proud Ward 7 resident and ministerial leader at the Pennsylvania Avenue Baptist Church, where my husband, Reverend Kendrick Curry, serves as pastor. I'm also a passionate community advocate, serving as co-convener of the Ward 7 Faith Leaders, a member of the Mayor's Interfaith Council, and the MPD Faith Advisory Council, a health navigator, and most recently a member of the DC Health Benefit Exchange Authority's Basic Health Plan, BHP, Advisory Council. The BHP Advisory Council was established to support the successful stand-up of the new Healthy DC Plan, a quality health insurance option designed to ensure continuity of care for individuals who will no longer have DC Medicaid or the DC Healthcare Alliance coverage due to eligibility requirement changes. The council is chaired by Linda Elam, who's a former DC Medicaid director. It's vice chaired by Claire McAndrews from DCHBX's Standing Advisory Board and includes doctors, community health clinics, consumer advocates, community leaders, the faith community, carriers, and others from across the district. The BHP Advisory Council first met on June of this year, just 6 days after the mayor proposed the 2026 budget, and that became public. During this first meeting, we were provided, an overview of the BHP option for states and how DC was planning to implement it and where the Advisory Council's input was needed. I found it was important to join the Advisory Council to help ensure residents have an alternative health plan to meet their needs and not be left in a lurch. And I firmly believe it's imperative that people are at the table who can speak on behalf of those that they serve. The voice of the community should be heard and clearly understood. The Advisory Council met weekly through the summer, and we moved to bi-weekly meetings in the fall, discussing and providing input on the Healthy DC Plan implementation. We engaged on topics ranging from policy and operations to plan name and logo and outreach and community engagement plans. We reviewed notices, consumer emails, and other communication materials to try to make sure that the messages would resonate with the DC residents. And so far, we've hosted or participated in more than 55 community briefings with faith-based organizations, community groups, government agencies, neighborhood associations, medical societies, hospital teams, unions, and social service organizations, being proactive, transparent, and providing consistent and clear materials. And so I do see that my time is running out, so I want to thank you for this opportunity to testify and for your unwavering commitment to safeguarding the health and dignity of our DC residents.
Thank you. Swapana?
Hello, I'm sorry, I'm just having an issue with, okay, thank you. Good afternoon, Chairperson Henderson and members of the DC Committee on Health. I'm Swapna Yuluri-Ricks, the Senior Attorney with the Economic and Healthcare Security Practice at Legal Counsel for the Elderly. For 50 years, LCE has defended, protected, and empowered DC's vulnerable older adults. Earlier this year, Congress changed requirements to Medicaid that will have a significant impact on DC residents. and I appreciate the opportunity to testify today and will focus on a specific recommendation to mitigate some of the negative impact on adults 60 and older in the district. The district must prepare for a shift from Medicaid to the basic healthcare plan. Currently, DC offers Medicaid coverage for adults whose income is up to 218% of the federal poverty level. However, as of January 1st of 2026, adults whose income is between 138% and 200% of federal poverty level will have to obtain coverage through the DC Basic Healthcare Plan. And people between 200% and 218% with Medicaid will lose complete coverage. And these changes will have an impact significantly on Black and Brown district residents between 60 and 65 who already experience higher burdens of chronic illnesses and barriers to care. And the loss of stable and affordable coverage could lead to delayed treatment, increased medical debt, and a widening of existing health disparities across the district. And beyond the new work requirements, which we'll address in written testimony, seniors will lose coverage in areas including dental care, vision care, and non-emergency transportation on the basic healthcare plan. These services are important for the overall health of an aging population. Given the gap in coverage between Medicaid and the basic healthcare plan, people will have to make difficult decisions about whether to see a dentist or go to preventative appointments or even be able to attend any medical appointments, as these will now result in an increased out-of-pocket cost. As the overall cost of living has been increasing, DC seniors are forced to choose between going to medical appointments, buying food, or having to pay rent. If people do not go to preventative visits, the district will incur the cost of unnecessary emergency care, which for moderate to severe visits costs about $2,056 in the district. As the council moves forward in this new world where district residents must struggle and scrape for healthcare, it should consider mandating that the basic healthcare plan cover at least what Medicaid covered. And there's still time to adjust, ensure that the health of the DC low-income residents does not suffer further. LCA fears that the coverage gaps between Medicaid and the basic healthcare plan will only increase the health disparities. LCA will work with the council to provide information needed during performance oversight and to develop any necessary legislation to ensure access to higher quality healthcare and health disparities. Thank you for the opportunity to testify.
Thank you. Tangela Hicks.
Can you hear me?
Yes.
Great day, beautiful people in attendance. My name is Tangela Hicks. I am a Ward A resident, DC advocate, and member of Legal Aid DC Community Advisory Council. I'm truly grateful for the opportunity and ability to have Medicaid for me and my family. But a true lifesaver has turned different cheeks throughout the years, and as I'd engage more into how things are established through budgets, it seems to have fit into the gambling pot more instead of humanity focused. In the last 4 years, I have had issues with finding a doctor or clinic who accepts my type of Medicaid. I have had my prescriptions as well as my children's prescriptions denied coverage during serious diagnosis. I even had to get legal help to fight for partial dentures. And now I'm at greater risk of denial if I'm enrolled in the new Healthy DC plan. I'm not understanding how more local budget cuts will also contribute to an estimated 25,000 residents being removed from Medicaid. How are we cutting budgets but giving money to billionaires? What about all of DC's people? If health is wealth, why is having insurance so hard to obtain and keep without hardships and hassles? Even with the changes made to Medicare, where is the love for our elders, our seniors? A lot of elders are not going to be able to afford certain changes. Some say changes for the better, but is it really? Thank you for taking the time to read my testimony. I hope everyone has an awesome day.
Thank you. And finally, Jamie. Oh, if you could just turn your mic on. There you go.
There we go. Thank you to the chairwoman and the council. My name is Dr. Jamie Majdi. I'm a family doctor at Unity Healthcare. I see prenatal patients, I see infants, I see adults, I see the elderly, I see everybody. I just want to echo what Ms. Hicks said about what about DC's people? And I wanted to share 3 stories about patients that I saw in the last couple weeks who have been affected by the changes to DC Healthcare Alliance. The first was on Monday. I saw a beautiful 4-month-old baby, and her mother recently lost coverage on October 1st. This time she was just asking about like a cream for vaginal infection, and she could afford that, and I was happy to prescribe that. But I think about, what if something else happens? What if she were to develop an autoimmune condition? How is she supposed to be able to continue to care for her beautiful baby in that situation without access to care? The second situation is an elderly patient who I have who's a caregiver in our community. She was recently diagnosed with Parkinson's disease, and thankfully they caught it pretty early, but she requires medication and she requires specialty care. And as you know, like in DC, there's not really a way without insurance to access specialty care. So right now she has Alliance, but we see that changing going forward. And I don't know how I'm going to continue to be able to support her, help her to prevent her disease from worsening, and enable her to continue working like she wants to be able to. The third case is a patient who is young. She's in her early 40s, and she has an autoimmune liver condition, a condition that, like, if untreated, will lead to her developing cirrhosis and liver failure. It's also a condition that I don't know enough about to be able to treat well. She needs to be seeing her specialist. And without access to insurance and without access to Alliance, she is unable to do that. I just wanted to echo everyone else's concerns, having conversations about how to use Alliance funds better. We're happy to have those conversations. Thank you so much for your care and for making sure that pregnant women were included in the Alliance changes. Thank you.
Thank you. All right. Thank you to everyone who testified. Dr. Jamie, I would just start. The first patient that you talked about, the one 4 months postpartum, would still have coverage.
And once again, like, she needs to talk to our social worker about that, but also, like, and it's still how much postpartum now?
12 months.
Still, like,
I know that's not the full.
Yeah.
I know for in this particular
But thank you. I
stage of,
appreciate it.
and I was going to say, like, obviously that's your patient and you have that kind of information, but if she needs to get connected with someone, we can certainly do that. But she is still covered 4 months postpartum. But thank you for being here, for uplifting the stories. And the things that you sort of talk about too, right? There's only so much that primary care can manage and take care of. And at some point, somebody's going to need to see a specialist to be able to sort of go further. And so as part of one of the reasons we're having this hearing, to kind of lay the groundwork for those future conversations. So I appreciate you being here and those talks. For everyone else, again, thank you so much for being here as well. All sort of bring different perspectives, particularly the attorney from legal counsel for the elderly. Obviously, when we're dealing with long-term care, that's in a completely separate bucket, or not separate, but it's a special bucket and population. And so we just want to make sure that we're getting it all right. But thank you all for being here. If you could provide your written testimony for the record, I don't have any further questions. We'll move to our government witnesses. We're gonna take like 3 minutes so we can all stand and stretch, and then we'll really get into it as they move to the table. So thank you, guys. All righty, and we now have our government witnesses, Deputy Mayor for Health and Human Services and the Director of Healthcare Finance, Wayne Turnage, the Director for the Department of Behavioral Health, Dr. Barbara Bazaron, as well as the Executive Director for the Health Benefit Exchange, Mila Kaufman. I do want to mention for folks who are watching, we did submit pre-hearing questions to Rachel Pierre, who's the Director of the Department of Human Services. They do have a role in sort of the processing piece as far as DCAS is concerned. They did respond to those questions, so she is not here at this hearing, but we did upload their responses, which you can find on the council website if you are looking for a full record to follow along. Okay, before we begin, I have to swear in our government witnesses, so I ask that you, as well as anybody on your team who might come to the table to phone a friend and answer a question, if you could raise your right hand. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
Yes.
Great. All right. So, Director Turnage, you're going first, and you have 10 minutes.
Good afternoon, Chairperson Henderson. Thank you for the opportunity to address the committee to speak about the steps that DHCF took in implementing the partnership with the DC Exchange to effectuate the changes to the Medicaid and the Alliance programs. As all are aware, these changes were proposed in the mayor's fiscal year 26 budget and approved with some modifications by the council. My remarks today are not designed to relitigate the necessity or wisdom of the policy changes. As you know, both the mayor and the council will have the opportunity with budget formulation for fiscal year 27 and the 4-year financial plan, both of which unfold over the next 5 months. While I cannot speak to the mayor's pending budget plans, nor address how the council might receive and modify her budget once submitted, one aspect of this challenging process will be unchanged, and that is the exigent and ubiquitous demand that the process conclude with a balanced budget. To illustrate what that means from that critical perspective, I have included the cost of full restoration in my presentation today for both the Alliance and Medicaid programs. But in sum, and we can discuss that quickly and later, but in sum, returning both Alliance and Medicaid to its 2025 policy structure for fiscal year 27 would require new spending of roughly $300 million annually, which amounts to about $1.2 billion across the 4-year financial plan. Despite the many well-meaning comments to the contrary from some of our public witnesses today, the budget implications of these policy changes cannot be responsibly or legally ignored. As for the matter before us, I'll begin by acknowledging the extraordinary efforts of my staff at DHCF, especially those who have worked under the aegis of Melissa Bird and Eugene Sims to implement the Medicaid and Alliance changes required by law, while widely engaging the community about these changes. Similarly, I do not have sufficient praise to describe the efforts of the exchange staff working under Mila Kaufman's direction to help make the transfer of Medicaid patients to a basic health plan on January 1, 26 as seamless as possible. From their work with actuaries to cost out coverage for this new population, to their interactions with CMS to seek approval for the health plan, to their recruitment of health plans to participate in the program, the DC Health Exchange team has simply been phenomenal. So at this time, I would like to turn your attention to slide 2, which illustrates the reductions made to the Medicaid program and the Alliance and what restoration would cost under the same program structure. Slide 2 should be a table. Yeah, that's slide 4 on yours, 2 on mine. Yes, and I can't see. The first, the red column represents the column to the far left represents the reductions that were made in the mayor's budget and modified by the council. Total cuts about $290.6 million in local funds, obviously. So if you wanted to restore those in 27, 28, and 29, the figures would roughly hang around $300 million, all the way up to roughly 310 or close to 310 by the end of the financial plan. So the total cost of restoration under the current structure, that includes managed care, not fee for service, would be about $1.2 billion. That is not an insignificant amount of money, as you well know. And a lot depends on what happens in the revenue forecast that is to come both in December and then again, I think one in February. If you turn to slide 3, this sort of briefly summarizes what we really came to discuss today is what's happening as we try to implement the changes that were mandated by the budget and legislation. As you can see on slide 3, there will be 18,000 former Medicaid beneficiaries headed to the exchange on January 1. 90% of that group will be eligible for the basic health plan, we estimate, and the other 10% will be eligible for a qualified health plan on the exchange. As will be discussed later by Mila, the benefits will be somewhat different. We cover the major healthcare services that people routinely need, but there are others that are also, one would argue, are also quite important. But at present, we don't have the dollars to pay for them, and so you won't get a broad-scale community-based mental health service, dental, vision, long-term care services and supports, and non-emergency Medicaid transportation, non-emergency transportation in the exchanges system. And there may also be some out-of-pocket costs, including premium and co-pays for those who are in a qualified plan as opposed to the basic health plan. As for Alliance, on the next slide, as you can see, the changes that have been widely discussed this morning, so I won't repeat them, are well underway. And my team has been working to make sure that the beneficiaries, the providers, and anybody else who has an impact on service delivery for this population is aware of what's happening and proper notice is being submitted. Informational notices have been sent to residents. They were sent in late July, and adverse action notices were sent, I think, September 1. We have done a lot of outreach, and HBX is doing more, and they can talk about that. And we've had DHCF staff at various outreach events. We have a bi-weekly stakeholder meeting that we routinely discuss the transition in the Alliance program. We have monthly beneficiary meetings, have copious Alliance resource documents that includes frequently asked questions. There are other activities underway, all designed to make sure that we inform as many people as need be about the changes that are upon us. On the last slide, there is one complexity, one of a number of complexities to this process that has been foisted on us by the federal government. There was a recent federal legislation that was passed that eliminated basic health plan funding for people who are lawfully present. Those who are lawfully present and under 100% of the federal poverty level. But in eliminating their funding, they forgot to change the eligibility provisions in another piece of legislation. So we're sitting here with a requirement that we serve that population, but they give us no money for it. So that clearly is a misalignment, and we are therefore expecting some flexibility from CMS to allow us to essentially keep their population in Alliance. Their cost is already in our baseline budget. So if we can keep them in Alliance, that cuts down the complexity of having to move them to the exchange and figure out how to pay for their services. Now, I will say that once that problem is solved, we will face several others in 27 and 28 because they will further expand the definition of people who are lawfully present but don't qualify for a federal subsidy in the exchange. So with that, I will conclude my comments. I'll wait for your questions after the fact and turn it over to Mila.
Director? Oh.
Thank you, Deputy Mayor Turnage, for offering to run the computer. The assist is always welcome. Thank you, Chairperson Henderson, for hosting this hearing and allowing me to testify on our progress in implementing the Healthy DC plan for district residents. For those who are not familiar with the Health Benefit Exchange Authority, as a way of background, we are responsible for the Affordable Care Act online health insurance marketplace called DC HealthLink. And we have a record of success. We were one of 4 state marketplaces that opened for business on time back in October, on October 1, 2013. We established a first-in-the-nation partnership with the Massachusetts Exchange, where we replaced their IT and provide operational support for their small group marketplace. Most recently, we designed and quickly implemented Healthcare for Childcare, which is now a national model. We were designated and given the significant responsibility for implementing a new coverage program under federal law called the Basic Health Plan. When we last met with you in June during our budget hearing, you made it clear that we cannot call the program Basic Health Plan. So with extensive input from stakeholders and others, the program is called Healthy DC Plan, which is very much indicative of the comprehensive nature of this program. It did require federal approval. So we received our federal approval from the federal government to establish Healthy DC Plan in September of 2025. The federal government pays for the health insurance coverage. What they do not pay for is our operational expenses, IT, administrative expenses, personnel, et cetera. We are funded by an assessment on health carriers, and that's how we're able to operationalize and run this program. Residents, to be eligible for the Healthy DC Plan, residents have to be under age 65, not be offered affordable coverage or have affordable employer-sponsored coverage or have other coverage. I want to spend a few minutes talking about lawfully present changes you just heard from Deputy Mayor Turnage. But for U.S. citizens, any resident who's a U.S. citizen with income between 138% of federal poverty level and 200%, those residents will qualify. Undocumented residents do not qualify for any Affordable Care Act programs, and that is also the case for the Healthy DC Plan. Now, for lawfully present residents, so these are residents who have different types of visa statuses. There have been changes as a result of HR 1, also called OB3 or One Big Beautiful Bill Act or Reconciliation Law. HR 1, all of those labels are, I refer to the same changes. What is clear is there is no federal funding for most people who are lawfully present, with a few exceptions. That is clear. What is less clear is obligations on states that have basic health plans in terms of the coverage that must be offered to people in the lawfully present category. We are waiting for federal guidance on that, and once we receive it, I'm happy to come back to you and share what the federal government tells us on that. So Healthy DC Plan, and you heard a lot from public witnesses. I just want to make sure you have all the correct information. We designed this plan to have no monthly premiums and no out-of-pocket costs for care. So there's no copay, no deductible, and no coinsurance when you go see your doctor. Participating, all of the community health centers currently participating in DC's Medicaid program are also participating in the Healthy DC plan. And the hospitals participating in DC's Medicaid program are also participating in the Healthy DC plan. Covered benefits are all Affordable Care Act benefits. Things like primary care, specialists, urgent care, emergency services, hospitalization, mental health, imaging, prescription medication, preventive care, all of those benefits that people with private health insurance have under the ACA, all of those benefits are covered under Healthy DC plan. What is not covered, because it is not required, is adult dental and adult vision. We designed the program to automatically trigger those should Congress extend the health insurance tax credit. And that way, if that happens, there will be funding to fund adult dental and adult vision. Behavioral health is covered differently, and I just want to make sure that's clear. Behavioral health is covered. It is just covered differently than what Medicaid covers. Another benefit that's not covered is non-emergency transportation. So when you have an emergency, you call the ambulance, they take you to the hospital, that is covered. But if you need help paying for rideshare or bus service for a non-emergency, that is not, to go see your doctor, for example, that is not covered. Back in June, I promised you that we would make the transition from Medicaid to Healthy DC plan as seamless as possible by automatically enrolling residents. And that's exactly what we've done. We've automatically enrolled over 13,000 residents, and we plan to automatically enroll another group of residents later in December. And we automatically enrolled those residents into a similar health plan or the same health plan that they have under Medicaid. Although the benefits are different, I just want to be clear about that. Over 13,000 residents have been automatically enrolled. And we do have some new customers, about 150. We believe that number will dramatically increase as more residents find out about this program. We've done significant outreach, but I just want to be clear, none of us believe there's ever enough outreach. And so even though we've done significant outreach, formal notices, informal notices, presentations, we know if we build it, no one will come. We have to go where people are. And we're committed to doing that. Those are some of the most important lessons we've learned implementing the ACA. And those are the lessons we're applying to implementing this program. I just want to say how extremely important our partnership has been with our sister agencies. Director Turnage has made implementing Healthy DC plan a top priority, and our teams are constantly in communication, more than once a day meetings. Without his help, his team's help, we would not have a successful implementation. I also want to call out our partnership with DSB and Commissioner Woods and her staff. Working together, we eliminated regulatory barriers with pre-approved model forms where all of the 3 participating carriers were able to use those. Otherwise, it would have taken a significant amount of time and resources to meet regulatory requirements to implement this program. As I mentioned, we have planned additional automatic enrollments later in December. I also want to make a plea for help. We've identified 1,100 applications where we have some data issues. We've already notified those households. The easiest way to fix the data issues that we're seeing is for those folks to come back in and just complete a new application. What we're doing manually is looking at each application and manually entering the information after we figure out the data issues. So far, we've gone through 1/3 of those, but it is a very time-intensive process, and we need help from the folks affected directly to just come back in and complete a new application. There are also 1,600 residents who don't qualify for the Healthy DC plan, and we are very committed and devoting significant resources to get those residents enrolled into our commercial coverage with lower premiums. I do want to mention the important work of the 3 Healthy DC plan carriers. They've completed all of their legal, IT technical, and operational work. So we were able to launch on time on November 1. Coverage will start January 1. All of the carriers have websites already for consumers. By January 1, all 3 carriers will issue either electronic medical ID cards or paper ID cards or both. In addition, all 3 carriers would have sent welcome letters, texts, or paper packages or electronic communications to all of the enrollees. And by January 1, all 3 carriers will have updated their portal for their network providers, enabling the network providers to check electronically coverage status, which is really critical for clinicians, for hospitals, and others to know that a patient is covered by Healthy DC plan. And I'm very appreciative of all of the incredible work the 3 carriers have done to date. And I just want to wrap up by saying thank you to Mayor Bowser for having the confidence in HBX to implement this critical program for DC residents. A huge thank you to Deputy Mayor Turnage for your confidence and daily support, and especially problem solving and just diving into the deep end of the pool and looking for solutions as we've encountered obstacles. Thank you, Chair Henderson, for your support, and DC Council members for your support of the Healthy DC Plan program. I also want to mention the extensive work that our Healthy DC Plan Advisory Council did. You know, when you ask someone to review a gazillion draft emails and they actually give you good feedback, that is commitment, and they did a lot more than that, but just very appreciative of every step of the way on this. DC Hospital Association and DC Primary Care Association helped us with making sure that the hospitals and the community health centers did what they needed to do on provider contracts that needed to be worked through. As I mentioned, we received incredible help implementing this from our sister agencies. And I just want to close out by saying thank you to our amazing HBX team for your unwavering commitment and 24/7 around-the-clock work to get this program operationalized, designed, and up and running by November 1. And now DC residents have continuity of coverage and continuity of care. Thank you.
Thank you. All right, so Dr. Bazaran doesn't have testimony. She's going to be answering questions. For those of you in the room, we have been joined by Councilmember Brianna Nadeau from Ward 1, who is on, well, she'll be on the screen. Councilmember Nadeau will do 10-minute rounds, if that's cool.
Great,
All right. And if other members join us, we'll certainly feed them into the process. I want to start with a follow-up on a couple of things that you talked about, Mila, in your testimony. In particular, the 1,100 applications that you all have flagged thus far that is in need of some additional data and some help, some manual help, if you will. Let's say for some reason that those residents don't get back to you guys by January 1, will they still have the opportunity to participate in what's their deadline or what's the process?
Yes, so we will continue to work those cases manually. It's just there's not enough staff to actually get everything done by January 1. And in some cases, we need additional information from the resident. In many cases, just by looking at all of the data sources, we can figure out the right information and get it in. And then in that case, the resident is all set. But in some cases, we do need some additional information. If the worst case scenario, the resident doesn't get back to us by January 1, but let's say January 15th, then we can still get the resident enrolled. It's just they may have a small gap in coverage. So if they have a medical need in those first 2 weeks, there might be a gap. We're trying to avoid all of that. That's why I'm asking everyone who works with this affected population to help spread the word that if a resident is getting information from us in email or text saying, please call us back, or please go into your account and provide additional information, to do that quickly.
Okay. Well, I guess then I wonder, Director Turnage, you all sent pre-notices to folks, I think maybe in August or September, to inform people like, hey, you are in the group that we believe is about to transition. Did we tell folks in that messaging to expect a notice from Director Kaufman's team? Okay, all right. Because I'm wondering, there's, for individuals for however long they might have been on Medicaid, they are used to receiving communications from one particular source through DCAS or the DC access system, et cetera. And now they would be getting emails from something completely different. And so I'm wondering if, for some people, they're like, I don't know this, spam or whatever, but we provided the heads up on that front. Has there been a feedback loop sharing? So for instance, Director Kaufman, if the additional information that you need is an address or something else, have you been able to say back to the folks at Healthcare Finance, hey, I think you guys might have this information at some other part of your system?
Yeah, so we have access because our systems are connected. We have access to everything that Healthcare Finance has.
Okay.
And so it's not a matter of a caseworker getting us more information. We can see everything in the system. It's just sometimes the data in the system it doesn't make sense.
Okay.
In many cases, like if, for instance, a child is showing up as the head of household, we know how to fix that because then there's an adult there. And so we don't need any additional information from a consumer. It's just a weird data issue we can resolve ourselves. But sometimes it's more complicated where we need information that's not in any system.
Okay.
And that's when we make the outbound request to the resident for additional information. But for these 1,100 applications, it's quicker. Even, if we can figure out how to, manually input the information, because it's in my example, wrong child, child is not the head of household. We can fix that. It just takes time. That's why it's so important for residents, if they're hearing from us, to just go in, complete the application online. We have our call center waiting to help as well. We've made it pretty easy. Our application is slightly different than the application for Medicaid. It's more like I call it TurboTax version. So it's pretty consumer friendly.
Okay. Director Turnage, when you all sent out the original notices, or even now as people are starting to evaluate, have you all received any appeals of people who still believe that they do indeed qualify for Medicaid and should not be transferred over? You gotta use your mic.
I take personal calls from people who believe that they have been wrongly terminated. And when I get those calls, they go directly to Eugene and they are addressed either to confirm that they have been correctly terminated or indicate that they were wrongly terminated and we fix it. As for an official appeal to OAH, I don't know that I've not had my finger on the pulse of how many appeals that they normally receive now include challenges to our eligibility determination. Maybe we can get that number if it does exist.
Okay. I think that would be interesting to, I want to understand better if there's some people, obviously, there's been a bit of a financial turmoil that has taken place in the last little bit as we're also transitioning what's going on in our region with the federal government shutdown that lasted for longer, et cetera. There were income changes and people might believe that they are still indeed eligible for Medicaid and want to keep that coverage. And so we want to make sure that they.
And I will say, we do encounter people whose we believe their income still qualifies them for coverage, and they have either not adjusted their income or just assumed they were no longer eligible, and we correct that when we can.
Okay. All right. Are there any other notices? I know that we're doing a rolling basis of adding folks over to HBX, but are there any other notices that need to come out from healthcare finance to Medicaid beneficiaries?
Melissa and Eugene are.
No. Y'all want to phone a friend?
She's shaking her head no, as opposed to coming up.
Yeah, come on. If you just introduce yourself for the record. It's okay. It'll be musical chairs.
Yep. Good afternoon, Melissa Bird, Senior Deputy Director at Department of Healthcare Finance. Our adverse action notice for those impacted by the Medicaid eligibility changes should have been in the mail on Monday. So that's the last official notice.
On Monday. Okay. All right. So there might still be some people who are figuring that out. And in terms of redeterminations, are we still doing that on a rolling basis?
Just our regular
Medicaid
yes,
redetermination.
Continuing as is.
Okay. So there could be, I guess I was just trying to get to the, if you heard the conversation I was having with Andrew Patterson from Legal Aid, one of the things that he was advocating for was continuous enrollment eligibility under healthy DC plan, which I'll ask you some questions about that in a minute. But what I'm just trying to get at is if on Medicaid, we are doing our continuous ongoing redeterminations, there might be determined that someone no longer meets the eligibility requirement at that next check-in. What will be the process for those folks if they do meet the eligibility requirements for Healthy DC to make it there beyond our very focused heavy lift that we're doing right now?
I can't say 100% we have done this, but my expectation will be that in those cases going forward, we will have a similar notice that you may have coverage options, which is typically what we include, I believe, in notices when someone is losing coverage, that you may qualify for this. And we can continue the communication with HBX if there are folks that we know that are likely eligible for the Healthy DC plan.
Mila?
If I can just add to that, and the notices that DC Medicaid does is very helpful to us because our systems are connected. And so as soon as a person is no longer eligible for Medicaid, the Medicaid system notifies our system that, oh, we have a new customer likely eligible for our coverage. And it's always worked that way, or for many years it's worked that way. So even though right now we're just taking big batch enrollments and automatically enrolling people, our normal process is anytime a person loses Medicaid and looks like they're likely eligible for our coverage, our system generates information, automatic notice to those residents, and gives them options in
Okay.
how to get themselves enrolled.
And they would be able to enroll even outside of a special enrollment period.
Correct. So, so we have many qualifying life events
Okay.
that make residents eligible for our commercial coverage. In the case of Healthy DC Plan, we also have the whole calendar year 2026 so a resident does not need a special enrollment period. They can just come in.
Okay.
In addition, I just want to note, last night at our board meeting, our board adopted a special enrollment period for the entire calendar year for folks losing Medicaid. They can just come in whether they qualify for Healthy DC Plan or commercial coverage. And so there are many ways that people can come in. If someone reports an income change to us and they're covered under Healthy DC Plan, if their income goes down, our system automatically transfers that information to DC Medicaid. It's I don't want to say it's seamless. It's a little bit higher than seamless, but it works very well back and forth.
I love it. A little bit higher than seamless.
Yeah. But not always seamless is what I meant to
That's
say.
an honest assessment. A little bit better, but we're not gonna call it exactly seamless. Okay, I'm over my time. Let me be a good person. Councilmember Nadeau.
Thank you. I was engrossed, so it was okay that you were over your time. Thank you both for your testimony. I'm going to focus on some questions about the Alliance for, well, I think it's more for Director Turnage, but we can see. So I want to ask a bit about the Alliance enrollment numbers. Based on the data that you shared, there are around 9,100 fewer enrollees today compared to November 2024 and way below the initial 2026 projections, which is very concerning to me. I know that the pre-hearing responses do note the enrollment numbers are preliminary and likely to change. Do you have an estimate of how much you expect to see them rise? Any sense of that?
You say expect to see them rise?
Yeah, or how they will bear out. I guess you said they might change.
If I had to-
maybe to me that means they'd be going down.
Yeah, if I had to predict, I would state that they will probably continue to go down, maybe at a different rate. The enrollment declines, that 9,000 figure includes people who started coming off the program before the eligibility changes were executed. Some of it, frankly, was born of fear of possible arrests by ICE and maybe deportation. So people, became less visible and less active in the community. And unfortunately, that probably also meant some of them were disenrolling from Alliance. And then obviously some were moved off after October 1 based on their income. So I think based on the trends we saw prior to October 1, that the enrollments for Alliance will probably continue to go down.
Okay. You estimated that 2,200 of the adults no longer enrolled lost coverage due to the changes in eligibility requirements that went into effect on October 1st.
Yeah.
How much did DHCF estimate that enrollment would drop due to all of the FY26 changes to Alliance?
What was that number? I don't have it in front of me. Was it 2,800? Yeah. You mean that was the final number, right? For people who would be left in. Yeah, I think we had projected that after the changes took place in October 1, there would be 28,000 people in the program. And that was before we had captured the decline that we saw post-budget formulation. So in other words, we were predicting prior to the January of this year, we were predicting that there would be probably about roughly 5,000 more people in the program that are now currently in the program. So those numbers are very fluid because of the very volatile nature of enrollment decisions that we're now seeing in the Alliance program.
So that'll be the lowest enrollment we've seen in a decade, right? I mean, you've been here that
Yeah.
whole time, so you would know.
Yeah, the lowest number I remember in Alliance was about 16,000. That was very early on. And as that number began to increase, I think it was then Mayor Gray who directed us to establish a face-to-face review. And the rate of growth began to slow. So this number is getting close to the program when it was near its nadir. I suspect that as we get further into 26, headed to 27, we may hit that the original number that used to represent a high, 16,000. Probably we could hit that number.
You also noted that Alliance saw enrollment reductions beginning in February 2025, in part due to new active renewal requirements.
Yep.
How much did DHCF estimate that enrollment would drop due to the new requirements?
I don't know if we parsed it that way. Did we? Yeah, I don't think we parsed it that way. The way we typically do enrollment projections, and I wish April were here, we look at trends and we say, okay, once we have enough data points to believe that a trend is reliable, we estimate based on that trend. I'm not sure it is possible to decompose the reason for that trend, but we have not done that typically. We note the factors that are involved, but I don't know if we quantitatively assign a specific number to a particular factor. We just say, this is the enrollment trend. It is decreasing at this rate, and we expect it to be at X on date X.
At the June 9th budget oversight hearing this year, your presentation included a projection of 37,024 enrollees in the Alliance by 2026. I know there's already been some discussion today about estimates and how they aren't perfect and they change, but with the data we have before us today, Alliance was already seeing a drop in enrollments, and I'm curious why this projection was so high when you were already seeing that drop.
Okay, you're throwing a lot of numbers at me. So timing, when did we project what number?
June 9th, June 9th, you predicted a projection of 37,024 enrollees by 2026.
On June 9th of 25?
Yeah. Mm-hmm.
Yeah, that's pretty easy. A lot of things have happened since then that we wouldn't have been able to account for in that initial budget projection. For example, we had no way of quantifying what the impact of ICE and the presence of ICE would be. That is clearly a factor in the declines, and so that number would probably be a little significantly higher than we are now seeing because of that unexpected impact.
That doesn't make sense to me completely, because by June 9th, I think you would have been thinking about ICE.
No, we looked at, again, we do projections based on historical trends. In other words, we look at what the numbers are at a certain point, and then how they are changing over time. And irrespective if we're thinking in our head, and I don't remember thinking that certainly in June of 25 that ICE would be doing what it's doing in the city, irrespective of that, if the trends are showing an increase, then we'll have to project an increase. It would be very difficult to convince our data scientists and the CFO that we want to project a decline when everything historically to that point is showing us an increase. We can't budget that way.
Okay. So based on the numbers we're hearing today, Alliance has 14,000 fewer enrollees than projected. Do you have an estimate of how much cost will be reduced due to this enrollment drop?
I don't have it with me. We will certainly do all of the budget estimates and analysis we need in budget formulation to figure out the 27 cost of the Alliance program. But no, we have not done those things yet. We're in budget formulation now.
I guess one of the reasons I'm asking is because if costs go down substantially right now in this fiscal year, are there eligibility requirements that are newly added that could be rescinded?
If you go back and look at this table in the on slide 2,
I'm looking at it.
The reductions we put in place were $290 million. We are not seeing declines at that level that would allow us to restore, those kind of reductions. As I stated, we will take a hard look at the Alliance program trends as we do budget formulation, but we can't just isolate a particular program component and say that number is going down, so let's change the mayor's budget and the council approved budget to put more money in without respect to what's happening in the other components of other programs like Medicaid. So if we said, okay, we can put 15 million back in Alliance, the AFO is going to rightfully say, yeah, but you have a pressure in some of your Medicaid components, and you can't just expect the city to give you more money for Alliance when you're sitting here with a potential spending pressure in the Medicaid program. It all works together in terms of whether or not we are above or below water.
Okay. I understand that. But it would be good to know.
We will.
I know you're going to do it as part of budget formulation, but it would be good to see it sooner. Yeah, because of course we don't get to be privy to budget formulation, so it would be nice to see it sooner. I'll do another round later since I'm over time. Thank you.
Okay, thanks, Councilmember Nadeau. I did want to just pick up on one thing, Director Turnage. So in the pre-hearing I'm gonna call it hearing. Pre-hearing responses, it showed that healthcare finance spent roughly the same amount on Alliance claims so far in FY26 as it had by this same point in FY25, even though you have about 8,000 less claims and less enrollees. So is our reading on this right, that some of this is because we're doing fee for service, which is a higher reimbursement rate than the MCO?
No, we have yet to figure out what the impact of the net impact of fee for service is.
Okay.
I think what you're seeing are two things. There are typically three factors that explain an increase in a healthcare insurance program. One is enrollment. Well, enrollment is going down, as you stated. The other is the unit cost for the people who remain. What you may have is some selection bias in the Alliance program now. People who are, even if they are afraid to engage, if they're really sick, they're going to keep their insurance as long as they can, and they're going to use it as they rightfully should. So their unit costs are probably increasing. The Alliance population, from the time it is established, is getting older, and we're seeing the kind of chronic diseases that we did not used to see in the Alliance program. The other factor is healthcare inflation. Hospital care is very expensive, and that number is increasing. So even if you have a no-growth enrollment position, you're still going to face increased costs from the providers, because we are pumping, in many cases, we're increasing the rates in some places. The hospitals themselves have paid for a significant rate increase with the provider tax. It's a combination of, I think, member illness and member utilization and overall healthcare costs in the system.
So at what point will we be able to kind of shake it out? Because I'm also seeing, we spent 1.4 million more on outpatient hospital and other facilities. There were about 1,200 more claims. So I think people are like searching for a story in the data. But what it sounds like you're saying is that the narrative can't be written yet.
No, it's way too early.
So
Way
when?
too early. What one is this? We made a change October 1. I would like to see at least 6 to 8 months of data.
Okay.
And you also have to remember, there's a, with claims, when you're measuring expense by claims, there's a run-out period. Providers have time to submit claims. I think on the MCO side, it's 3 months. I'm not sure what we do on fee-for-service. But they don't have to submit the claims right away. So to look at anything now and try to extrapolate a narrative that it's more or less expensive by going to fee-for-service, or it's more expensive because we're only dealing with people who are chronically ill, it's a bit too early. But we will do that. It is a rich field for analysis.
Okay. All right. Let me go back to Healthy DC real quick.
Thank you.
Which I wanted to, I'm gonna get to Alliance, but I was trying to stay focused here. Okay. So, Director Kaufman, you talked about in your testimony, there's about 10% of folks who no longer qualify for Medicaid, who also don't qualify for Healthy DC. I guess they do technically qualify for a qualified health plan, maybe, possibly.
That's exactly right. About 1,600 residents whose incomes are above 200% of federal poverty level. They do qualify for our commercial private health insurance coverage in DC HealthLink. And because of their income, they also qualify for some lower premiums.
Okay.
And reduced cost sharing. And so we're working very hard. Our outreach effort mirrors what we did with Medicaid Unwind, a population who lost Medicaid. And so we've done lots of emails and texting, and our DC HealthLink assisters are calling residents. I think 3 to 5 calls is what we've asked them to do. We're also thinking about new strategies, like maybe a text message with an assister's name to connect the resident quicker to a particular assister. So we are fully focused on making sure that as many of those of the 1,600 residents know about affordable coverage, and we help them get it.
How many of these 1,600 have we been successful in converting?
So remember, their Medicaid doesn't end until December 31st, but I can get you our current enrollment for, I don't have it at my fingertips.
That'd be helpful to know. I mean, I think that all of you would share in this, right? A year ago, we were, second in the nation in terms of health insurance coverage, 97%. And because of physical constraints and other policy challenges to no fault of our own, I fear we're hustling backwards. Now, how backwards we go, I think that's up to us in terms of the work that we do on the outreach side to make sure that people who do qualify for other programs are able to make those connections. And I think that we're working on that to make it as seamless as possible. But this is part of it. How many assisters do you have right now? Assisters, not a sister, but
staff at assister organizations that we're providing grant funding to. I can get you the exact number. I don't have that at my fingertips. But our grant funding to our assister organizations have been, we haven't decreased it over the years. It's been we've actually had a small increase a couple of years ago, I believe. So we've maintained our commitment to providing grants to mostly community health centers on the ground who can help us get folks enrolled into coverage they qualify for. So our sisters not only help people into private health insurance, they'll be helping into Healthy DC plan, but if someone qualifies for Medicaid, our sisters help them enroll in Medicaid as well.
Okay. You mentioned, Director, in your testimony that 15 residents switch plans. Do you know why? Did you guys ask why?
No, it's all online and we just look at the data. I'm surprised.
I'm curious.
Yeah.
You know, consumer choice, do what you want, but I'm just curious why someone would. Why?
Yeah, maybe, yeah, I don't want to take a guess. Out
Okay.
of the over 13,000, having 15 switch tells me that people.
Well, you haven't done all of them yet.
We've automatically enrolled over 13,000. Those are all set, automatically enrolled. They were all, I think, 13,200 or so, were all in that first batch enrollment file that we did in
Oh, I
October.
see. Okay.
And out of that category, 15 switches. To me, it says people are relatively happy with the health plan they had or they're in.
That speaks a lot to your MCOs, Director Turnage.
Were they switched to them?
No, only 15 people wanted to switch. That means that folks were pretty satisfied with the MCO that they were currently with.
Oh, well, that's one interpretation.
Trying to be positive here, because our insurance carriers are also doing a lot. Okay, Director Bazran, I want to bring you in on this conversation. When we were making some changes in terms of the eligibility splits, I guess the question really is did DBH have to also follow the eligibility changes that we were making on Medicaid, or was there flexibility for you all to keep your eligibility levels higher?
For many years, we have, because of parity and other concerns, we have adhered to the Medicaid eligibility requirements, and we still do this. And we plan to do that moving forward with one exception.
Okay.
And that is, for example, we know that there are currently 21 individuals who are receiving ACT services, assertive community treatment services, which is the highest level of care within our system. And we will continue to pay for those services.
Okay. For those existing individuals, but what if someone new is in need of that service?
Then we will also consider paying for them too.
Okay. All right. Are you concerned in terms of, one particular area in the behavioral health space has been really important for DC is around substance use disorder. Are you concerned at all that the reduction in terms of eligibility going from 221 to 135 leaves a lot of people out? Because is substance use disorder coverage on?
Yes.
But it's in the same sort of breadth and scope, or is it more limited?
I want to say almost everything, but not everything is covered.
Okay.
So not exactly the same, but most benefits are covered on the private side.
Have we done the work to determine where the anomaly lies? Because I could just see in my future if one of the anomalies is around, like, let's say, medicated assisted treatment and the types of things. I know there is a physician who will send us an email every morning about this.
Well, I think that the majority of substance use disorder services are covered. However, services like our recovery support services are not included in the plan as I know it. But outpatient treatment services and other residential services, hospitalization, management services.
Okay, I'm over my time. I'm trying to be good. Oh, go ahead, Melissa.
Well, I will also just add to that. I mean, we did reach out to our managed care plans and ask them to identify the, codes at the code level, what we cover today in Medicaid and what will be covered through the Healthy DC plan. And it's maybe 10-ish codes out of pages of it. And it's mostly on it's like the housing support services, the sort of community treatment that we've talked about, but largely the SUD related services are covered.
Okay, let's come back to the housing piece. Like, nobody's losing their housing.
Housing supportive services is largely a function already provided by the Department of Human Services. This was our ability to have that kind of case management component supported by Medicaid funds.
Okay, I'm sorry. I'm over my time. Councilmember Nadeau.
Thank you. Director Turnage, are there any other coverage changes for Alliance planned this fiscal year?
All of the changes that are planned for Alliance this fiscal year were those enumerated in the mayor's budget and then modified by the council. We don't have any mid-year changes planned for Alliance that I have been informed of.
The one thing I would just say that we've extended not generic, on the pharmacy side, we extended the ability to have the brand name pharmacy or prescription drugs through the end of the calendar year. And then that was a kind of a bridge period to get us to the generic only policy that will be, that we transition to. So that was anticipated with the changes for Alliance. It's just that component won't be fully effectuated until the first of the year, calendar year.
That was actually going to be my next question, so thank you. So what is the thinking with that change? Why are we doing that?
We're moving to generics largely to support the cost savings that we need for the program. So it's a way to still allow access to pharmacy, but at a lower cost to the district. And we do have exceptions for when there's something that's medically necessary and there is no alternative generically that we will review and most likely approve as needed.
How long do you anticipate that review process taking?
I'm going to let our chief medical officer respond to that.
Good afternoon, Dr. Shemaine LeBert, internal medicine and lifestyle medicine board certified. At this time, my team is actually reviewing what drug classes we need to actually consider so that the change will be seamless. There are some medications that we recognize that are important to continue for patients' health and safety that are branded only. And so we're in the process of doing that. In addition to that, I have made the rounds of the federal qualified health centers as well as spoken to individual physicians to get from them an understanding of those medications that they're using on a daily basis that are branded that they deem as medically necessary so that we have insight as to prescribing methodology to be able to cover as much as we can for those patients.
Do you anticipate there will be physicians who are recommending a branded drug as a medical necessity even when there is a generic? And how would you approach that?
Yes. In patients that have been on generic medications that have failed therapy and a branded medication has improved their care, that's something that we will likely approve, yes.
Okay, great. I'm glad to hear you say that. I wasn't sure. The way we were discussing it, it sounded like only if there wasn't a generic. So thank you. And you mentioned talking to the FQHCs. Is there direct outreach being done to enrollees as well about this change?
Yes, we will be sending a letter explaining to them that there may be a change in their medication in the near future so that they understand that if the pill looks differently, they understand why.
That'll be in the mail?
Yes.
Thank you very much.
Thank you.
I do have some questions about Medicaid. During the budget discussion, DHCF estimated that 25,000 people would lose Medicaid coverage by the end of this year. But you said that you now expect this to be around 18,000 people. There's been discussion today about how these estimates aren't perfect and things change, but can you explain more about why the estimate changed for Medicaid?
It is similar to the discussion earlier, as you alluded to, council member. It was at that point of time and based on and trends, and it also is based on the enrollment, which fluctuates month over month. And so it's, likely it can change again in the next month or so when we have the final list, but that's largely what drives those changes.
Thank you. Director Kaufman, you said that you have already automatically enrolled around 13,000 people, and there'll be another group that's enrolled before the end of this year. Do you know how many people this next group will include?
No, we're waiting as long as possible so the automatic enrollment can include the biggest possible group to make it, in this case, seamless for the transitioning population. I also want to clarify that we run our own eligibility. And so if by chance the Medicaid eligibility shows someone no longer eligible for Medicaid and eligible for healthy DC plan, and in our run, we show that, nope, we think they're Medicaid eligible, those cases get worked through. So people are not losing coverage and being reinstated. All of that is being worked through by the two teams.
Do you anticipate the enrollment to match the 18,000 estimate from DHCF?
I can't answer that question accurately because folks are losing Medicaid and are becoming eligible for Healthy DC plan. And we know that 1,600 losing Medicaid are only eligible for our DC Health Link coverage, which has premiums. So not all 18,000 will be eligible for Healthy DC plan. Also, residents' circumstances change. And so once we have better data on who transitioned into which program, I can provide the updated data to you.
And what I can add to that too is that we will have another data file going to the Health Benefits Exchange, I think in a week or so. But I think you're speaking to that delta between like the 13,000 or so and the 18,000 or so. We have individuals who are still going through that renewal process, like October, November, December. Those individuals were not included in what we initially shared with the Health Benefits Exchange because we knew as they go through the renewal process, they might provide us new information. Maybe they had an income change, so there would be no need for them to be shared with the Benefits Exchange. So that's why you see some of those discrepancies. But in the conversations between the teams, we estimate 18,000, and once we get through all of the renewals and enrollment at end of December, we feel like we'll be fairly close to that.
Okay. Director Kaufman, I think you also, you were just talking about the 1,600 people, I think, who aren't transitioning over to BHP because they aren't eligible. What caused their eligibility to change?
So their incomes are above 200% of federal poverty level, and to be eligible for BHP, you have to be between 138 and 200. Anyone above, which is that 1,600 number, they are eligible for our commercial coverage with lower premiums and with cost sharing reductions, but they will have out-of-pocket costs.
Got it. Thank you. Well, thank you all very much for your testimony. Thank you, Madam Chair. That's all I have today.
Thank you, Councilmember Nadeau. All right. Since we're still on Healthy DC, let's just talk a little bit about network adequacy for a second. And this would be the same on the behavioral health side of things, but all of it. How did you all work with, well, I don't know. Did you work with DSB on determining what the network ratios needed to be, or adequacy ratios?
Yes, so DSB has very clear standards under the insurance code that apply to commercial coverage. We worked very closely with DSB to provide a transition period for the three carriers as they're finalizing their networks. We required by October 1 for each of the three plans, health plans, to provide us with detailed information about how they were going to, within the year transition, meet all of the requirements under the insurance code. All three provided us with their transition plan. Those plans were reviewed by both my team and the DSB team, and all three carriers are on track. We did prioritize making sure that community health centers are all in, as well as the hospitals participating in the Medicaid program. And I just want to note that, just to be clear on reimbursement rates for this, the Healthy DC plan is not reimbursed like a commercial product. So when you go see a physician or you have a hospital stay, what the plans reimburse for that is not what is reimbursed commercially, because commercial reimbursement rates are a lot higher and there wouldn't be enough funding. So we required that the reimbursement rates mirror what they are under Medicaid negotiated contracts. In some cases, it's Medicaid plus. In case of, in situations of hospital reimbursements, it's whatever the MCOs have negotiated. In the case of community health centers, it's fee for service based on site location. So those are the reimbursement rates. And for other providers, physicians, specialists, it's whatever they've negotiated for their Medicaid reimbursement population is what the health plans are supposed to be reimbursing on the Healthy DC plan. So essentially, there shouldn't be a loss of revenue, because it's whatever you accept for a Medicaid patient reimbursement, you will be getting for that same patient as they're covered under a Healthy DC plan.
In theory, that sounds great, except for I know that for some of our NCOs, their network adequacy on certain types of services wasn't that strong to begin with. Now we can get into that for some of the things like pediatric dental, which is, we'll put that to the side because we need to have our conversation about dental. But I hear you on the rates piece of things. But
And they have 1 year to get themselves into full compliance with commercial standards, which are different than the Medicaid network standards. I just want to make sure that was clear.
Okay. But that does bring up a question for me around, and this is for both situations of how are we communicating with providers? Because this kind of came up in the public witness testimony where, you know, physician A or pharmacist B, oh, I heard about there were changes in terms of Medicaid. They might not have read the management alert from healthcare finance or read the alert, but they're making grand assumptions about who's eligible, who's not, what's covered, what's not. And one area or group that kept coming up was around how we're communicating with pharmacists who are generally on the front lines of telling somebody whether or not their insurance coverage is active or not. And so Medicaid and Alliance is one thing. For Healthy DC, did you all send a separate communication to providers about what this new health plan is? Or would that have been the responsibility of, say, Care First, Amera Group, Amera Health? MedStar. Wow.
MedStar Family Choice.
Yes.
Amera Healthcare, TAS DC, and Care First Blue Cross Blue Shield Healthy DC plans. Yes, so we, on the commercial side, we don't have a direct payment relationship with providers. That's what the health plans do. As we were setting up Healthy DC plan, Dr. Bennett from DC Health put information about the new program into her newsletter to all of the clinicians. And she sent, she and I signed a letter specifically to a group of, I think there were 600 or 700 providers, encouraging them to essentially participate.
Okay.
We are relying on the 3 health plans to communicate with their participating network providers. And as I mentioned earlier, a tool that's really helpful, I think, to clinicians is the automatic eligibility lookup tool. It's a portal that carriers have for their providers where you can just put in patient information and find out, are they covered under Healthy DC plan, or are they covered under Medicaid or commercial coverage?
Okay.
So that's going to be a very useful tool. Since you mentioned pharmacies, I do want to note that our formulary is commercial required formulary. It is different than the Medicaid formulary.
Okay. Doctor.
In regards to physician notification, I convened an advisory council in August, and we did several meetings in which providers were invited to hear all the changes that were going to occur, in addition to MCAC and several other avenues that we use to provide that information, along with the managed care company. So everyone was made aware of the changes from a provider perspective. In terms of the pharmacy, we have quarterly meetings that are for all pharmacy, regardless Medicaid or Alliance, and that there was a fall meeting September 23rd and 24th, and the winter one is December 16th and December 17th. In addition to that, we've had email communications sent out to the pharmacists, making them aware of those changes.
Okay. I mean, I don't know, maybe you all at Healthcare Finance want to team up with DC Health and Dr. Bennett to send out something specifically to the pharmacists, because those are always the ones that keep popping up as oh, I heard something different, or my system is saying your Medicaid is not active, when in fact, you know, I think one witness said, no, but the woman had her card with her and the card hasn't changed.
One issue that we found is that there are several pharmacies that are not enrolling as fee-for-service. And so when the patient arrives at the pharmacy, their medication gets denied. What we end up finding out when I made the phone calls is that they're not enrolled, so they're not going to be able to fulfill that. They've remained in managed care, or they're just not enrolled at all in DC Medicaid.
Is that mainly independent pharmacists, or?
It was both CVS as well as some of the smaller. So I made calls to some of the outlying pharmacies, because that's where patients are going. They're not coming into DC. Both in Virginia and Maryland, a lot of them said, we're not going to enroll.
Got it. All right. Okay, we're going to unpack that. Don't go anywhere. Go ahead, Dr. Bazaran.
You asked about to what degree and how we have been working with our provider community. The Department of Behavioral Health and the Department of Healthcare Finance, we hold monthly meetings with our all of the providers that are certified to provide behavioral health care. One of the things that DHCF did is they also sent a list of all of the individuals, the specific recipients who would no longer be eligible for Medicaid, and what their eligibility might be. There were a total of 2,259 individuals, and of those, 2,000 will be transitioned to the Healthy DC plan, and 259 who are 200% over FPL will be transitioned to the Health Benefits Exchange. And we have, we've also invited, Mila came and actually spoke to our providers about any of the changes that were going to happen. And Director Byrd is there on a monthly basis, and we have that discussion to ensure that behavioral health providers have information regarding the changes that are occurring.
Okay. Though, so that's for the Healthy DC population, but obviously we have a lot of individuals who were receiving behavioral health services under Alliance who have since lost coverage. Have you all done that same type of analysis with that population?
Yes, actually, we have. In terms of the Alliance population, we have 611 youth who are in the Alliance program, and 2,114 adults who are in that program. And they will qualify for continued benefits consistent with the DC Department of Healthcare Finance requirements.
I'm sorry, can you break that down? What does, for the person who is watching, when you talk about they would qualify for continued health benefits, what do you mean by that?
So for example, if someone is within the Alliance, and which is a part of a local benefit, and they meet the eligibility requirements in terms of income, then they will continue to receive those services.
Even if they exceed age?
Even if they're what?
Well, age is in the future. It's coming. Never mind.
I'm sorry.
That's 27. You're good. I'm thinking ahead. Apologies. Oh, Have you all run the numbers to determine how many people have lost coverage have you all run the numbers to determine how many people who were seen last year who are no longer covered right now?
Those are the numbers that I talked about, the 2,000.
So the 2,000 adults and the
2,000,
600
those are
youth?
people who've received at least one behavioral health care service within the past year who no longer meet the Medicaid eligibility requirements.
Okay, that was
2,259, yeah.
Oh, that's the other number. Got it.
Right.
Wait, no. Hold on, I'm confused. You gave me the 2,259 number. I thought you were referring to individuals who no longer qualified for Medicaid who is switching to Healthy DC.
There are two pieces of it.
Okay.
The total number is what I said, and there are two parts. 2,000 of those individuals qualify for the Healthy DC plan. 259 who have incomes over 200% of FPL will transfer to the Health Benefits Exchange, will be eligible for the Health Benefits Exchange.
Okay. It's in the. No, I know, but it sounded like the exact same number. Okay, so the Alliance population in total would be a little bit higher. I guess what we're trying to determine is how many people who are receiving behavioral health services on Alliance, let's say in February of this year, as of October 1, were no longer eligible.
In terms of people who will no longer, if somebody is in the Alliance right now and they meet the eligibility requirements, then they will continue to receive those benefits.
No, I know, but I'm saying the eligibility requirements for Alliance changed on October 1. So what was the shift? That's what I'm trying to get at.
Oh, I see.
How many people shifted on that front? But while
I can get back to you with the
okay,
specifics.
all right. I did want to sort of follow up on something you talked about in terms of dealing with our neighbors to our north and our south, for whom folks are getting services from as well. There were two witnesses, public witnesses. Laura Warby and Dr. Sugarman. You guys are familiar with Dr. Sugarman. Anyway, one of the things that they suggested was around when the Alliance program first started, there were specific pharmacies that were, I guess, considered Alliance pharmacies, and you do that. Have you all thought about that as a way to kind of deal with some of these other issues that are arising? Now, obviously, convenience is convenience, right? Although, if you're going to a pharmacy in real Virginia, it does beg the question of why. But you could work out there, but convenience is convenience. So, yeah.
Understood. Yes, as I've looked at the spend and to ensure that we have sufficient funds to ensure coverage, one of the things that our team has talked about is how can we ensure that we've got coverage? And looking at the cost of medications, utilization, and then trying to figure out the best ways to do it. So considering the FQ's pharmacies is one area, looking at specific programs in which managing those costs entails really taking a look at classes of medications that are being used, how they're being used, managing those patients, and talking to the physicians and asking them to specifically look at medications to help us manage those costs. So one of the things that another thing we've done is considering using those pharmacies as a possibility. We have not talked to them as of yet, but it's something that we can consider.
I mean, look, I'm here for all options of us thinking outside of the box, Director Turnage, in terms of what we do kind of going forward. I recognize, I guess, based off your slide too, right? And this is why I asked you that question of How much does it cost to put Humpty Dumpty back together again like we never did anything? Because every hearing, every meeting, every email, somebody has a different number. And I'm like, where you get your number? Where'd you get your number? Where'd you get your number? And so I feel like we all need to be sort of working off the same set of facts so we can understand what is the issue that is at hand, right? Hold on one second. So in terms of putting all these pieces together, I'm going to get to in terms of my question is that Director Kaufman, you pulled together a task force. She was like, I can't do this all by myself. And I think it has worked very well. What I see in front of me amongst all of you is an excellent representation of the collaboration of our government to solve a problem. There are a couple people missing from the table, Commissioner Woods, Director Pierre, but all of you came together and said, hey, this is costing too much. We don't want all these people to lose coverage. How can we creatively sort of think about that? And I think we have to have that same level of collaboration as we think about what happens in FY27. So we don't have, 16,000 more people all of a sudden lose health insurance and flood our hospitals in that same regard. One of the suggestions from the coalition was that, they said that the council needs to require a task force, but Dr. Bazarang, you know how I feel about task force of large sizes. And I also feel like in the past, healthcare finance, you guys have done this without the need for legislation when you are pulling together thinkers around let's creatively solve a problem. What are your thoughts on that as you sort of head into this budget formulation process? Now, I recognize that requires a lot of trust on whoever you bring to the table to be forthright with them around what the real financial challenges are here. But I don't know, what are your thoughts on that? You turn your mic on.
A couple of points. First, if anybody is bringing numbers to the council about the fiscal impact of what we have done or what it would take to restore the program, I would distrust those numbers, not because those folks are inherently dishonest, it's because they simply don't have the data that we have and use to estimate what these impacts will be. They miss major portions of, is this a projection or is it a present day number? What inflation factor do we use? They often don't use any inflation factors because they don't think about this stuff every day. A few do, but typically their numbers are not going to match what we have to basically get certified through the CFO. So I would treat those with the appropriate suspicion. I am similarly task force sometimes can be useful if they're small and they include people who are, committed to, finding a solution that sometimes does not align with, their ideology that they bring to the table. I was having a discussion with a group outside just before we came in, and one lady, very informed, was haranguing me on why we would make these cuts when we could just raise taxes. And I said, DHCF does not have tax raising authority. And it was like she completely kept just putting that aside. But you make recommendations to the mayor. I said, but we have to come up with a budget that reflects our contribution to keeping the budget balanced. So when if you can get people to the table who understand that, and then look for solutions within those parameters instead of telling us to go to the mayor and the council with a request for $1 billion tax increase over the next 4 years of the financial plan, then yeah, I think task force can be good, but it's very hard to find those people. There are a lot of smart people in healthcare. You heard from a lot of them this morning. They have great ideas. And so we are not taking the position that we have the market cornered on how to efficiently come up with solutions that deal with situations where your revenues are stressed. So yeah, we always would like to talk to people, but it has to be in a manner and a setting that's productive. Official task force, large in nature, that, you got to go through all these formal procedures. We just rather roll up our sleeves, sit with 4 or 5 well-known, well-educated, smart people in the corners of our office and try to figure this thing out.
I'm good with that.
Yeah.
That's fine. You do that for the maternal health. Well, the maternal health is a bit more of a formal structure and, minutes and whatnot. But what I'm saying is that I do feel like it will help to bring in some providers to have a conversation about, okay, where are some saving measures? And if everybody is coming to the table with the same goal, save the program, right? Understanding the financial challenges that we currently have. I recently had a conversation with the city administrator, and he was like, well, I don't know, Christina, we spending $700 million more now than we are budgeted for to spend in 27. So we all need to talk about, what are we doing? And I think that sort of frankness of like the reality of bringing other people into the conversation can help a little. And also, so folks don't necessarily feel blindsided by some of the decisions, recognizing they don't have the final say.
Correct.
The one thing I think it's important to note, though, because I did hear a lot of good ideas earlier through the testimony, there's a difference between cost savings and controlling cost growth. And, you know, we've had to find savings to meet a budget, right? To be a balanced budget for our agency and obviously for the city writ large. So that's different than how can we control utilization and have some control the cost of growth versus the overall cost of the program. And those are two different things in my mind.
Yeah, because I think what people don't understand, I heard a lot this morning, as did Melissa, people were saying, well, if you do this, you're going to increase emergency room costs to the city. And some of what they say is accurate. You're going to have more, avoidable hospital admissions. You're going to have more low emergency use of the emergency room. You're going to have more return to the hospitals after a discharge within 30 days. You're going to have more of those things. Those things are true. But you cannot quantify those things and then count that against a spending pressure. If you said, for example, if we keep service A, we know that we're going to avoid, $100 million of costs in the future, as based on, theory or, maybe even some evidence. The AFO is not going to let us take that projected $100 million in savings and count that as a benefit against a spending pressure that we have to solve. It's just not, it's not going to work like that. And a lot of people don't understand that. And because we get it all the time, well, you're doing this, it's going to cost you more in the long run. I say, yeah, but we have to pay for the service now. And we cannot pay for it on a promise of future savings. There's just the district's budget and just doesn't work like that.
Understood. But I'll go back to my question, which was around whether or not you all can commit to having, I'm certainly not saying 21, because we've backed off of that in the past. But I don't want to pick the people. You know who the people are. You all know who your people are, who understand the Alliance program, can make some strong recommendations, and can help. Bring them in.
Yeah.
What ideas do they have around both program savings and curbing the growth?
We will identify, for that very purpose, we will identify people that we've worked with for years now who are, genuinely smart. We don't always agree with them. They don't always agree with us, but they're smart and they might have some ideas. So I'll charge Melissa with rounding up those folks, and I'll be more than
Melissa, I have to
happy.
keep advocating for you to get a raise, my friend. Because you just be adding other duties as a side.
I'm more than happy to participate and sit in and listen to what some of these ideas might be, because we know the CA was very accurate. We $700-800 million in the hole. We know what's coming, and then if the revenue projections in December and then February aren't what we think, it could be another really, really difficult and challenging budget, and it makes you, it makes you fear what you would have to do to balance the budget, because you have no choice but to balance it. I'm very open to hearing some of the ideas of things that we might do to save the program.
Okay, I'm just asking for us to do that. And I think even, I went out to Mary Center, spent some time with Nancy Van and her team, and they're trying to think creatively around payer mix and some other things and conversations that they're having with hospitals to bring some services to them. And so I feel like if everybody is sort of in this innovative mindset, I think that we can come up with something here. Just a follow-up, as I'm going through the follow-ups of things that were raised, Director Kaufman, lots of people testified about a 1332 waiver to increase the eligibility for Healthy DC. I don't know if you had a response to that. I don't know the
So New
realistic
York-
nature of it. I'm just wanting.
Yep. So 1332 waivers are available for states under the Affordable Care Act. And many states that have that, the focus has been to fund reinsurance and locally and generate enough local and federal funding to bring costs down for commercially covered population. That's how most of the 1332 waivers have been used. New York is a good example where they used a 1332 waiver in combination with other waivers to expand eligibility for their basic health plan. That with the federal law changes is no longer, that's not where they are. They've actually recently applied to the federal government to modify their program to essentially go back to the traditional basic health plan. They've submitted their paperwork for approval. I, like Director Turnage, we're always looking for great ideas. We just got approval for our Healthy DC plan, and it required. It's not like snapping my fingers. I wish it was.
Remember that text? It was like, it's about to shut down the government. Do we got it yet?
It was significant, but we simplified that process by essentially saying, we're just going to use all the commercial rules. We know how to do that. It's simple. It's private coverage. And we were able to have those discussions, with political folks, with career folks, to get to a yes. And I should mention, Director Byrd had significant, provided us with significant help in getting us to a yes on that. So to now go back so soon to request a waiver, I'm just not convinced this is the time to do it. We're happy to look more into it, but we need to really make Healthy DC plan work. Develop an evidence-based case where we need to modify it, and then consider whether 1332 waiver is the right way to do it.
Okay. I wasn't saying one way or the other, but this was something that came up that we need to definitely talk about. The other thing that we definitely need to talk about is, what about dental? I don't know what they're doing on the other end of Pennsylvania Avenue. We were supposed to have a ACA alternative plan like 2 weeks ago that got scrapped, and we haven't heard them mention it yet again from the White House or the Congress. And so I don't know what they're planning to do on the premium tax credits. So what conversations, Director Turnage, are you all having on the mayor's side around the 5 million for dental? Is it still 5 million, or did it go up?
We would need to look at the enrollees, the numbers, and give you a better estimate. The initial estimate would just, it's very dated based on older assumptions. So I'm not sure what the current assumption is, but
And I think it's probably based on a higher estimated population. When we talked about the $17 per member per month, if I recall correctly, that was where we thought there was like upwards of 25,000 people who would be transitioning. There's less now.
That's correct. And it was also based on utilization of those services. It was before DHCF revised their rates. I'm not that familiar with what happened on the dental side for the new fiscal year, but I don't want to confirm that's the correct number, because I would just need to go back with my team and look at what the actual number is to provide you with even the ballpark of what it would take to do the adult dental piece.
Okay. All right. Well, we get that number. I hope you guys are having conversations. Although I would say the data that you guys gave us in the pre-hearing responses, overall, even under Medicaid, folks ain't going to the dentist like they're supposed to be. The claim numbers are not.
It's a painful process.
A cleaning is painful?
People have deep fear of going to the dentist.
Sure do.
Yeah.
And then I had doctor after doctor after doctor tell me how if you don't get your mouth checked, you can lose your vision.
Yeah.
So-
I make myself go, but I tell you what, it's when I get there, by the time I get there, I have armpits down to my waist because I'm sweating, thinking about how much pain this is going to be. So it's
you are not instilling health confidence
Yeah.
and the people who might be watching around going to the dentist. We're going to need to bring back some PSAs around. Like,
it is a very necessary procedure, and that we should
procedure, service.
Well, service
Procedure implies
you get
surgery.
Cleaning generally leads to procedures, but your point is well taken. Mila and I have talked about the cost of dental. I'm waiting until she gives me a more exacting figure. And when she does, I'm more than willing to sit down with the CA and talk to him about where we have a gap in our service delivery and how much it would cost to fill that gap, recognizing in full that he may look at me and say, there's no chance because we're still trying to get revenues and expenses to match. And right now we're projected by a significant amount to be underwater. So, but as soon as I get it, because I don't want the figure to shift, I go in and say, CA, we got to have this. And then Mila calls me 2 days later and said, well, it was 5 million, there, it's 9 million. And then that would be not good for anybody.
That is correct. So I guess it's on you now to get the right number.
We will update that number and provide it.
Okay. All right. Give me just a moment. Oh, yeah. Okay. Director Kaufman, we wanted to get some clarity about vision. So I think at one point we had talked about restrictions on the exchange in general, outside of Healthy DC being able to offer the vision piece, but in our looking at other states that have basic health plans, they have been able to offer vision coverage as part of their offerings. What's unique about their situations that may not be present in DC?
So we're using our commercial essential health benefits package for Healthy DC plan. And that does, so vision, adult vision is not in our required benefit structure. Other states, like you probably looked at Oregon and Minnesota, right? New York, they, at least 2 of them are using more of the Medicaid design benefit structure.
And if we had more time, we might have gone that path, but we didn't have that much time.
And money.
And money.
Yeah.
So yeah, and as I mentioned earlier, we really leaned into our commercial side and our expertise and making sure that we design a package that didn't have financial barriers to care. So that was really our first and only priority. No premiums and no deductibles and no copays when people need to see their primary care physician or go to the hospital or get medication. So that was really the decision point.
Okay. That brings up the whenever the federal government starts federal governmenting again and, trying to help people, and we have this conversation about healthcare, like vision and dental should be part of EHP. Why it is not a essential health benefit, I don't understand. But that's not you, that's them, just sort of in the general piece. I did just get a question, Director, about, we talked about the compliance and the working of the carriers who are going to be doing the Healthy DC. We looked at the MedStar Healthy DC Find a Provider tool, and it says that it's still being updated on their website. Will we confirm that everybody's stuff will be live and ready to go on December 31st?
Yes. So right now we have the participating hospitals and the community health centers on our DC HealthLink website. When you go to Plan Match, that it's anonymous shopping, for each of the Healthy DC plans, you see all of the community health centers and all of the hospitals. That is up right now.
Okay.
As the three carriers build out their provider networks, we will be also updating our website for customers. So customers can just go on our website and see who is in the network. And remember, there's a year transition to get into full network adequacy compliance. Exactly. So it's I would say the provider lookup tool, aside from hospitals and community health centers, is a work in progress for the three health plans, and they will get that network information up on their websites as they build it out, and will be updating it as they build it out.
Okay.
And this is not, I just want to say, this is a new program. We had to stand it up very quickly. I had underappreciated the complexities surrounding provider contracting. And I believe that within the year, all three plans will be in full compliance with the commercial requirements. But it is a much heavier lift, even though the reimbursement rates are whatever has been negotiated for the Medicaid population. It is just much more complicated, unfortunately.
I would say it's not you, it's history for some of them, because even on one that I had to call Director Turnage about, it had nothing to do with them not wanting to participate in Healthy DC and everything to do with another beef that they had with the health plan on something else, which at the end of the day, Director Turnage agreed with me. For the hospitals, they had no choice. It was, you're in, sorry. Welcome to Healthy DC. So I do have one, I'm not gonna say it's my final question, but it's my last sort of talked about question. And I hope to have a more definitive answer. So as you guys know, when we did the budget earlier this year, the council passed a contingency list of things to fund if there was additional revenues that was available. And one of the things on the list was $21 million for Alliance. We were supposed to have the CFO's determination on that at some point this week. I was hoping it would be today, so it'd be nice little news to ask you all how you plan to implement those changes now that you have that additional funding for the Alliance program in particular. But I guess we will have to follow up on that once we have some clarity from the CFO about whether or not we'll be able to spend that money at all. The intended purpose was to be able to reinstate full services for Alliance for adults.
Full services?
Benefits, so.
That's more than $21 million. You mean for the existing population or for the?
The existing population.
Oh, okay. So
Yeah,
yes.
no, it's not taking it back to the
I
beginning,
got you.
but it was like, now you get an inhaler, vision, dental, hospital,
Oh, I see.
that part.
Where, and I have not, I may have heard about it and since forgotten. The 21 million, where's that coming from?
I'm sorry?
The 21 million.
Well, it was from additional revenue from the unexpected revenue,
Oh, okay.
which at the end, or in the last revenue estimate, it was a total of about 280 million additional. But then my colleagues decided they wanted to play with tax policy, so they swiped out some of that. But there should be enough, in theory, to provide 21 million for Alliance.
I remember the discussions around the additional dollars that were available. And I was wondering with the CA as to why the council didn't direct any of that towards healthcare. So you're saying that now there's going to be 21 million that will be so directed?
That was, yes.
Okay, wow, that's good news.
Yes.
Yes.
If I had known we had all this other money, I would have taken care of dental and vision, but then you would have but things were
Well,
tough
we could still, we could still use it for that, couldn't we?
for Alliance, not for
Alliance,
Healthy
yes.
DC.
Okay,
So
that's good news.
anywho, all right, let me say the last little bit that I have to say. Okay, that concludes our hearing today. Thank you all for participating. I think we have some follow-ups. I think Dr. Bazaran, you have some follow-ups on some things. Okay, I want to thank everyone who offered their testimony today. We certainly appreciate your stories and your experiences. And as I mentioned at the beginning of this roundtable, the committee wanted to do a check-in with our government agencies who are implementing some of these major changes on our health insurance programs. And we will certainly continue to conduct oversight on these things. The probable next hearing on this is we'll touch base in February during performance oversight. And at that point, transitions will have occurred. So we'll have a bit of a better understanding of what's going on.
Yep.
For anyone who could not attend today's hearing or testify, we'll accept public testimony until Wednesday, December 17th at 5 p.m. You may submit your written statements via the council's hearing management system site, dccouncil.gov/hearings. The health committee will meet next Monday, December 8th at 3 p.m. in room 123 here of the Wilson Building. We will be marking up several measures that are before the committee, including the PrEP DC Act of 2025, the sense of the council on supporting humane and trauma-informed responses to behavioral health crises, the Community Health Amendment Act of 2025, and then we also have 2 Board of Social Work nominees. So we will be working. With that, time is, well, I'll give you, is there anything else you guys want to say for the record that I didn't ask?
No.
No? Okay, great. All right. Time is 3:41. Hearing is adjourned. Thank you.
Oh, Bonnie.
What?